Good morning. Welcome to the first hearing of Portfolio Committee number 2 for the additional round of the inquiry into budget estimates 2024-2025. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name's Dr. Amanda Conn and I'm Chair of the committee. I welcome Minister Park and accompanying officials to this hearing. Today the committee will examine the proposed expenditure for the portfolios of health, regional health, the Illawarra and the South Coast. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence that they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome and thank you for making the time to give evidence today. All witnesses must be sworn prior to giving evidence, and Minister, I remind you that you do not need to be sworn as you've already sworn an oath to your office as a Member of Parliament.
Thank you.
I note that there are witnesses in the overflow seating area as well today, and I'd like to remind you that if you come forward to answer a question, to please bring your nameplate with you and place it in front of you on the table. This assists Hansard in ensuring the correct witness is identified in the hearing transcript.
Sold out.
Witnesses who appeared at the initial or supplementary hearings before this committee also don't need to be sworn. Ms Skoolander, Ms Marr and Adjunct Professor Shembri, you'll need to be sworn in. So could you please state your name and position title and swear either an oath or affirmation, starting on my left.
Yes, my name's Emma Skoolander. I'm the Chief Executive of Health Infrastructure and the Deputy Secretary of Infrastructure and Asset Management. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Anthony Shembri, I swear that the evidence now I'm about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Chair. Kate Marr, Deputy Secretary, Delivery and Engagement Group from the Premier's Department. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Today's hearing will be conducted from 9:15 to 5:30. We're joined by the Minister for the morning session from 9:15 to 1 with a 15-minute break at 11 o'clock. In the afternoon we'll hear from the departmental witnesses from 2 to 5:30pm with a 15-minute break at 3:30. During these questions, there'll be questions from the opposition and crossbench members only, and then 15 minutes allocated for government questions at 10:45, 12:45 and 5:15pm. And we'll begin this morning with questions from the opposition. Mrs Wan.
Thank you, Chair. Welcome, Minister. Thank you for coming along, and
Thank
to
you, Ms.
all
Wan.
your colleagues, and thank you for your service.
Thank you.
That you do. Minister, in September 2022, you said in Parliament that, and I quote, "The independent data showed that our health system is in crisis. The same Independent Bureau of Health Information now shows the system is worse since Labor came to power. By your own definition, is the health system in crisis?"
No, it's not, and I'll say it for a number of reasons. I think it's a fair question to ask what each of us have said in the past. I think where we are facing some significant challenges at the moment, and the data indicates this, is around emergency department presentations. It is up significantly. There are a couple within that I'm very concerned about, and that is the CAT 2.
What are you concerned about? Yeah.
That is the CAT 2 and 3 classifications. They are people who are very, very sick. One of the challenges we face right now as a system is that the availability of primary care is not as robust as it was perhaps when my generation was a lot younger, and there was an assumption that people could access GPs and bulk billing GPs locally, close to home, fairly readily. That's not the case, and what the data indicates is that some people have put off that, particularly as a result of post-COVID, and as a result those people are presenting to our EDs sicker. Now,
Right.
I've got to get on top of that big time, because I've got to try and ensure we have more people being seen outside of hospitals, and that's why our investment in close to, round figures, $500 million in ED, what we're calling sort of ED relief in alternative pathways, had to happen at the last budget. But I by no means think that the performance of our hospitals and our EDs can't be improved. It needs to improve.
Thank you.
And we have to continue to focus on it.
Can I go to that ED's issue then? Why have wait times in those emergency departments skyrocketed with only 60% or 61.3% of patients starting treatment on time? That's the lowest on record.
Well, I'll say probably a couple of things in relation to that. We have a look at today, have released some figures around some of the busiest hospitals in the country, and New South Wales hospitals, as you know, are arguably the busiest in the country. So if you have a look at Liverpool ED, one of, if not the busiest emergency department in the country at times, that department receives around 90,000 presentations a year. So the mass on that per week is very significant. They've halved their average time to treatment for Triage 2 emergency patients from 18 minutes to 9 minutes over the past year. Westmead ED, that receives close to 80,000 presentations a year. That's reduced average time to treatment for Triage 2 by over a third, from 15 minutes down to 9 minutes. Nepean ED, we know that is a very busy ED in far western Sydney. That receives around 90,000 presentations a year. That's seen the percentage of patients transferred from paramedics to ED staff on time go from 65.1% to 82.2%. Now, I'm just highlighting those figures to say there have been some improvements. There are areas where we need to do better,
Clearly.
but New South Wales outperforms when it comes on a comparator to other states and territories. We outperform all other states and territories on ED wait times. And,
Thank you. Just
we-
going to those Triage 2 patients then, or Category 2 as you call them, they're potentially life-threatening presentations, aren't they? So
They're very
and they're
unwell patients.
not being treated on time. Why are they waiting longer to receive that care?
Well, I've gone through, firstly, a few things of why I'm concerned why we're getting more Category 2 and Category 3 patients.
But Minister, I'm just going to pop in there, just to be clear about the specifics of the questions. Fewer than half of those Triage 2 patients are being treated on time.
Yeah,
You've
and
just said potentially life-threatening. They're very
Yes.
ill patients.
They are.
Fewer than half.
Yep. So I've also gone
Why?
through 3 busy hospitals in Western Sydney where the improvement around Cat 2 has significantly improved over the last 12 months. That's by no means am I saying that there's not more improvements to be made around Cat 2 and Cat 3 patients. You are right to highlight the fact that Cat 2 and Cat 3 patients are very unwell, and we need to see them as quickly as possible. The challenge in emergency departments across the country, and I say this for those where there are Liberal leaders and those where there are Labor governments in place.
I'm just going to draw you back to New South Wales. I want to be very specific about the issues in New South Wales. When you're in federal parliament, you can talk about that across the country. But
never
today
been
we're very
federal
clear.
parliament, yes, well.
Good to know. So in New South Wales, we're being very specific. You've released this data this morning at 9 o'clock by a press release. That's a bit convenient just before budget estimates, isn't it?
No, I think data, it's important to release data. I do it frequently.
On the morning of budget estimates, do you normally do it then?
Look, you released something this morning about free flu vaccines.
It's not about me.
I don't
not
know.
about me. We'll get to flu vaccines. I want to know why you released this data
People release data. It's that's what we do.
on the morning of budget estimates.
Well, I'm very transparent. You can't accuse me of.
Let's go to that then.
Not being
So
transparent.
that should be independent. Has it been released publicly? Because my understanding
well,
is some of it's selective.
This is data from the hospital system.
Yeah,
So,
yeah. So it is the BHI data?
well, it'll come into their BHI data. They provide.
Sorry, just to be clear about your answer there.
Well,
That is BHI
Okay.
data that you quoted this morning
Well,
for this
let me
committee?
talk about BHI data.
No,
BHI
just,
data is.
sorry, you've quoted some data earlier, Minister.
Yeah.
Is the data that you've quoted the BHI data that is the evidence you're getting to this committee today?
Yes, it is health data, and health data is BHI data. So there is not 2 different data sets.
Good.
BHI use the data set from New South Wales Health The data released today is from New South Wales Health. I think that's an important
And it is
distinction.
important, and the reason it's important, Minister, is because that information, that data has not been released publicly, has it?
Well, I'm releasing it today as the Minister, so...
But it hasn't been released publicly.
Well, I don't need to
You've done a
wait.
press release this morning, but that
I-
isn't the data, the full set
but-
of data being released to the public, as
But
you're obliged to do.
It's the data of my agency, and that data is the same data that the BHI have access to. The difference is that...
What about the public, though?
The BHI...
Point of order. Is there any chance the Minister might be allowed to actually answer the question?
I think that last interjection was maybe a bit quick, and I'll allow the Minister to continue answering.
No, that's okay. I understand. The BHI data is released every 3 months. I want to make sure that the community and particularly staff understand where there has been an improvement in their local ED, particularly for staff who are working really, really hard. These are some of the busiest EDs in the country.
Sure.
I want to make sure we give them a pat on the back when that data shows that their efforts is working. And
Sure. What about the pat on the back for patients, though, who are waiting extended times in your emergency departments, and that data isn't being released, and what is being released selectively? Do you not... And can I say the quarterly data was released last time from September. We're now in February.
yeah, well,
So-
when they release their data, BHI, that's a matter for BHI. The data set they use is the same data set that I've used for this. It's no different. What I've tried
You've
to
used
do...
for what?
What I've tried... Well, for the release today.
For the press release today,
Yeah.
before budget
New
estimates.
South Wales Health data.
It's cherry picking, isn't it, Minister?
I know, I don't think it's cherry picking because it's New South Wales Health data.
All right, well, let's just be clear on this, because there are many interested stakeholders in this data, and you say that it's released quarterly. That information has not been released in full publicly. You've picked parts of it out, so you can't have it one way or the other. Either it is released in full to the public, the full set of data, or you're picking parts out. It can't be both.
This is data that's New South Wales Health data that every 3 months gets reported on.
But just not to the public.
Yeah, of course it does.
So the full set is out there right now. So
It's-
you're under oath, Minister. That full set of data has been released publicly right now. Is that what you're telling this committee?
No, sorry. BHI released in December, wasn't September, I think you said that. BHI releases data every 3 months. That's the cycle that they choose to do. That's fine. I've got no issue with it. That's been the case for
So as you
previous
said-
governments and ours.
Sure.
What I've chosen to do is, because I want to dive into the data and I want to have a look at where some of our busiest hospitals in the state, particularly in Western Sydney, are performing, and what I've indicated today, I'm not saying all our data is perfect and indicates every hospital's going through the roof.
Minister, I'm not asking for it to be...
I'm not saying that. I've
I'm
never
not-
said that.
Certainly, I'm not asking for it to be perfect. What this committee and the public and patients are asking for is for that information to be released in full to the public. I note that the December information is not yet available to the public. That's the December information. You have cherry-picked parts of that to release conveniently before budget estimates today. That's correct, isn't it?
I'll continue to release data that indicates...
In full?
One way...
Point of order. There's been 3 allegations of cherry picking, and on neither occasion has the Minister actually been given the opportunity to respond. I think he should be given the opportunity.
Thank you. To the point of order, the Minister can respond to the questions that have been put as he sees fit, including responding to that if he would like. I'll go back to the Minister.
Been interrupted.
Yeah, I'll continue to release data. There are plenty of days in this portfolio where things don't go as you like. That's also an area where I front up and are transparent. But
Sure.
I also need to acknowledge the work of health staff in these really busy
Certainly.
hospitals who are making a pretty massive difference
Sure.
in terms of their efforts.
We'll get to
when I
staff.
think they're going well, and when I have data in front of me that says, geez, that's a big improvement from places like Liverpool, that's a big improvement from places like Westmead or
Thank you.
Nepean, I don't think it hurts to give that staff a pat on the back and say, listen, We know
Certainly.
it's strong, we know it's tough, but what you're doing is making a difference.
Thank you, Minister. But I'm going to move back to the questions. I have very limited time in here, and I'd appreciate the opportunity for the stakeholders who are interested in not the pats on the back and the press releases, but the information that they are seeking. So I'm going to draw you back to that.
Yep.
You mentioned flu vax. Let's talk about flu vaccines. Minister, last year you said our emergency departments were getting slammed by influenza. Will you support the opposition's call for the New South Wales Government to provide free flu vaccinations for all?
Not at this stage, I won't.
That's a no.
And I'll probably go through some reasons why.
That's okay.
Firstly, flu is a challenge in this state and in this city. We had a bit of a trifecta of trouble last year. We had RSV, COVID and flu.
Thank you.
I've had discussions with Dr. Chant around this issue. Around
Right, can I ask Dr. Chant about that then, please? As Chief Health Officer, Dr. Chant, would more people getting the flu vaccine reduce demand in our emergency departments?
The New South Wales Health really encourages us to achieve higher levels of coverage in those at most risk of severe disease, and that's our under fives. We've got a very strong focus on vaccination of our under fives. We're only seeing levels around 30 to 40%, and that's been a national issue of how to support that vaccination, particularly in the under fives. Over 65s, who are also a group at significant risk, we really want to see those levels of influenza coverage well over up into the 70s. We're currently in that sort of 60 to 65 range. There's a lot of initiatives underway to really support those at-risk populations get vaccinated, including those at a risk of immunocompromised who are also eligible for the free program. That's our focus. And looking forward, obviously, we're looking forward to new vaccine formulations such as nasal vaccines, which will really make vaccination in other settings more cost-effective and feasible and acceptable to the population.
So getting those flu vaccines would reduce that demand. It makes sense, doesn't it?
Yes, but the current, a number of other jurisdictions have needle-free vaccines and they've used those at a population level with the view to reduce transmission. So by having very high coverage in some populations, particularly the younger children. But I do want to say that the under fives are a group that are most at risk of hospitalisation from flu. Obviously, pregnant women, we're having a very strong focus on ensuring pregnant women both receive RSV, influenza, and other vaccines.
Right,
the challenge is in 2022 when this occurred, there wasn't a significant uptake in people going and getting vaccinated from memory, and I'll stand corrected on this, but from memory, in 2022 there was a higher number of flu notifications with that program than what there was after. Now, I'm just making sure that the committee understands that.
What do you base that on? That's not correct, is it?
So look, the flu season varies from year to year, so notifications and testing patterns change. But we do know that in terms of vaccination coverage, when we introduced a free flu vaccine in 2022, we didn't see a significant increase in uptake, and particularly in our vulnerable, in the populations we really
and maybe
want to
that was maybe that was a factor of cost. Maybe making it available in whatever form and making it free would assist people that
it was actually free.
I understand that, but there is seriously. On the numbers you've just given, it seems to me that there's a reduction in take-up that could be supported.
So in 2022, it was actually free, and there was a reimbursement system for pharmacists to vaccinate.
Right. Can I just go to those numbers then?
Some other states...
I think it's an important point that's been raised. It's the core issue that's been raised. And I think the official should be given the chance to respond.
Chair, I have four. I've tried to not interrupt, and I've politely tried to move back to the questions. I have 4 minutes left, and I've had 4 points of order, so I'd appreciate the opportunity.
To the point of order, because I think we'll be doing this all morning. The committee members shouldn't be interrupting, but also witnesses should be as focused as possible in answering the question that's been asked.
Thank you, if I
Should
may.
about 10 seconds.
So, just on those numbers, then. The flu vaccination rates were higher in 2022. There were 3,417,635 compared to, in 2024, 2,649,895. So they were higher in 2022. Clearly, free vaccines lift vaccination rates.
We need to look. I'm sorry, I haven't got that data in front of me. It has to be adjusted by the population at the time. I'm sure population hasn't increased radically, but I'd have to go back and look at that data and reflect. But it didn't make, our analysis was it didn't make a significant difference to influenza vaccination coverage, and particularly in the groups that we know are most likely to end up in hospital when they've got influenza.
Thank you.
And so our priority focus is really trying to support parents of children under 5 and over 65,
All right.
and those with underlying health conditions, and look optimistically forward to new formulations that would allow
Sure.
a more widespread vaccination approach.
Thank you. So, Minister, I might just ask you to take on notice those numbers just to clarify
Sure.
that that's correct for
Yep.
your benefit as much as anyone's.
Happy.
And just in relation to in question time on the 11th of February this year, the Premier said in relation to the psychiatrist crisis, and I quote, "The government's in dispute with some of these unions, but the situation is tolerable." The situation is tolerable. Do you agree with the Premier?
Yeah, at this stage I do. The Premier's
Sure.
also been very clear that this is a big challenge at the moment, and I
Thank
want to
you.
be very clear to the committee that we are far from out of the woods. This is a challenge.
Yep.
This action has put pressure on our health system, and it's put pressure on our mental health system, focused pressure on that mental health system.
You'll get
Now,
furious agreement with us. I have 2 minutes, so I'm just going to move to some specifics on that then. Is a psychiatric patient having to spend more than 5 days in an emergency department due to psychiatrist resignations tolerable?
Well, any time someone, regardless of whether they present as a mental health patient or a patient with a physical issue, when they spend too long there, I feel for them. I feel for them. I
Is
feel
it
for
tolerable?
their family. Of course I do. We always want to make sure we provide the best possible care in the shortest possible time. Now, psychiatrists, and they have every right. That's the working men and women's right. Have decided to take this action, but
Sure.
at this stage, this action, because of the work our contingency plans have put in place, we are managing it at the moment. That is not to say there is not an impact on the system.
Sure.
There is, and it's not to
having-
say there won't be further impacts.
Yep.
But we are doing what we can because of the preparation that we did.
Sure. I
to
just
try
have
and
a
manage
minute left, so Minister, I'm going to direct you back. Is having your surgery cancelled due to a nurses' strike tolerable?
Well, any time someone misses their surgery for any reason, that would be frustrating for them, and it's, from my perspective, disappointing. Now, from time to time, that happens. That can happen because there's an emergency surgery that needs to take place, and someone with an elective surgery, albeit very important,
Sure. I have
obviously
50 seconds.
doesn't
I'm just
take
gonna,
that.
Sure. Is having to spend an additional $200 million of taxpayers' money to clear surgery backlogs caused by nurses' industrial action tolerable?
Well, the root cause of the nurses' industrial action is a 12-year wage freeze and a wages
Minister,
cap
I'm asking about
from
the
the former
additional
government.
200
And-
nurses' budget estimates, the $200 million of taxpayers' money to clear that backlog because of that action. Is that tolerable?
Yes, it is.
All right.
And
Is having to cancel your medical appointment
and-
because trains aren't running on time, is that tolerable?
well, let's be very clear. In relation to the first issue, I am not going to apologise for investing more money into the system to try and clear the backlog
Sure.
caused by industrial action. I'm
Minister,
not going
would
to
you
apologise
have
for
gone
that.
on holiday if you knew that doctors and nurses were about to resign en masse?
I
Minister?
didn't hear it, sorry.
Would you have gone on holiday or gone on a long lunch to the Hunter Valley if you knew that doctors and nurses were about to resign en masse?
Look, I don't answer hypotheticals. I came back from leave.
No, it's a
to
fact.
deal with
The minister went on holidays and went to a boozy lunch when they knew that the resignations en masse were about to occur. Would you do the same?
I'm here to answer questions around what my role is in the health system, and I've been really transparent about that. Other ministers will present to budget estimates. There'll be an opportunity.
So that's fine by you.
No, I didn't say that. I didn't say that. So.
It's not acceptable for the minister to provide the answer and then a little bit of a sort of hook at the end that was put in there deliberately. Now, that's not what the minister said, and I'd ask that to be withdrawn.
I think the last couple of questions after the bell there contained a fair bit of argument as well, and I'll rule them out of order. That's the end of the time for the opposition. Good morning, Minister.
Good morning.
In 2022-23, New South Wales Health spent in the order of $37 million on commission fees paid to locum agencies for the placement of temporary doctors. And I understand that was an increase of about $20 million from the previous year. Do you know what that figure is for 23-24?
I'll speak to Alpha, might have that figure.
Minister, I don't have that available with me. I'm happy to take that on notice.
Okay.
Thank you.
They are an important part of the workforce, as you know. We have committed, Ms. Con, around $6.3 million to examine the feasibility for the first time of a New South Wales Health locum agency, including how it would work and how much money we might be able to save. I just say that in the context of not having that figure, but it's a piece of work that we're doing.
Absolutely, it was a very welcome announcement, and I was going to ask about the progress of that. I'm extremely concerned that the contingency plan for the mass resignation of the staff specialist psychiatrists has been absolutely celebrated by those private locum recruitment agencies who I imagine are making a fair bit out of this crisis, and I understand that the figure itself's been taken on notice. What's happening with the work to bring it in-house?
Yeah, we're working that through. I might ask Mr. Minns just to give a very up-to-date look at what we're doing in relation to market research, what other states and territories are doing, given it's a national issue. But Mr. Minns?
Chair, maybe a bit of context about where we are with locum use as a result of the campaign by ASMOV and the college. We've had quite a number of people withdraw their resignation, 35, and then about 113 of them have pushed their date out. So the actual number of separations that we've had by head count are 54. 3 are still with health share to be processed, and 2 haven't left the LHDs yet, which kind of means that there's still a local discussion going on. If those additional 5 on top of the 54 head count actually separate, the total FTE value of that separation will be 34. So whilst we have recruited or screened a large number of potential locums, I think the number's more than 50 now, we aren't deploying that many of them in the workforce. I'll have a look and come back to you at a later point with the actual number. The last time I saw it, it was 22.
Thank you. And my follow-up question, Mr. Minns, or if any other witness would like to answer it. Ms. Pearce, you were quoted saying that all psychiatrist locum vacancies weren't able to be advertised for more than $3,050 a day unless authorised by the health department to go over that amount. How many times has that occurred?
None.
Okay. So there were no vacancies advertised?
Nothing has been put before me to sign off on an amount above what we set. The reason we set that rate goes to the very heart of your question, Dr. Con, and that is that we did certainly not want a situation where we were being price gouged on this issue by locum agencies or anyone else. At the start of this process that we have worked through, we were starting to hear rates being quoted of closer to $8,000 a day. Clearly we needed to intercept that and put a process in place to prevent any such thing occurring, and to my knowledge, and as I say, I've certainly not signed anything that I can recall that goes above that rate. Okay. There are a very small number of locums deployed, as Mr. Minns has said, in the context of this issue. We already have locum use in our workforce, as you well know, but in the grand scheme of things, in the context of the matter we've been managing, there is a relatively few number of people deployed under that regime.
Thanks, Ms. Pearce. So you've clarified there's no locums being paid more than $3,050 currently. And what about visiting medical officers for psychiatry?
Well, visiting medical officers, as you know, is an entirely different set of circumstances. Mr. Minns can add more detail to this, but what I will say is that those arrangements are temporary as we work through this issue, and indeed to allow the Industrial Commission process to take its course. But Phil, did you want to add?
Yeah, a couple of things. So 58 is the number of locums that we have recruited centrally and referred to LHDs and specialty health networks. The numbers that are actually working in the mental health response is 24, so up from the 22 that I mentioned. And 72 psychiatrists have sought leave without pay to convert to a VMO contract arrangement. And I couldn't be clear that all 72 are actually now working, but it must be very close to it because that number's been stable for several days now, probably 2 weeks.
Thank you. Mr. Mintz, could you confirm for us this afternoon if any visiting medical officer psychiatrists are being paid more than the $3,050 a day at the moment?
They won't be because they'll be on a VMO contract arrangement. So they're separate workforce, locums and VMOs.
I understand that. I'm just trying to understand how much the VMOs are being paid in the context of the current psychiatry resignations.
Okay, I can try and get that, yeah.
Thank you very much. I'd like to come to safe staffing levels, Minister. Mr. Minns provided this committee an update in November on the process of that rollout, and I'll come to him this afternoon for more updated figures. You're 2 years into your term as the Minister. As at November, the rollout had come to 17 hospitals, but about 3/4 of those positions are unfilled. I talk to nurses every day from the majority of the state who have not felt the tangible benefit of this yet. Are you satisfied with where that rollout is up to? It was your flagship election promise to nurses.
Yeah, was. Well, probably those who know me know that patience is not one of my strengths. So I always want it to go faster. Roughly, we have probably about 260 odd nurses have been rolled out as a result. We have 2 sites complete at Liverpool and Royal North Shore. We are rolling this out, although would I like it rolled out faster? Yes. We are rolling out this faster than any other states who have implemented it, and we are doing it in a unique way, the model that I set up, which was to have New South Wales Health and the Nurses and Midwives Association on the implementation team rolling that out. Now that means they go actually to the hospital, count the spaces, work out, discuss, debate, analyse the amount of staff, and then we go through the recruitment of that. Now, at the moment, recruitment of healthcare workers is a challenge. It's a challenge in this state, it's a challenge in the country, and it's a challenge globally. So I'm not the one saying that I don't want it to go faster. Of course I do. But we are moving at a fairly rapid rate, and I will continue to personally drive it as hard as I possibly can. I frequently go to the meetings. It is a topic of discussion, a standing item that I have with the Nurses and Midwives Association, which I regularly discuss and meet with, and this is an important issue for me.
You've said that recruitment of healthcare workers is a challenge, and I appreciate that that is a nationwide challenge, but specifically here in New South Wales, how much do you think the fact that we've got the second lowest paid nurses in the country contributes to your challenge filling those positions?
Look, I've been clear. I think having a wage cap in place for 12 years has seen big gaps set out. One of the reasons why we moved very quickly last year to remove the wages cap was to try and start the process of rebuilding. I'm not going to once say that having a 12-year cap at 2.5% when other states and territories haven't had it. You learn compounding probably in year 6 maths. It's pretty easy. When it goes the right way, it's good for you. When it goes the wrong way, the gap gets significantly more. And that's what, as a result of that, that's happened. That previous government was elected multiple times, democratically elected. That's what the community wanted. But I'm not going to sit here and say that hasn't had an impact on the gap that we've got. Now, it's my accountability and my job now to try and resolve that. We haven't got that issue resolved yet. We remain in discussions with the Nurses and Midwives Association. I met with them just a few days ago with Shay and Michael, who I meet regularly with. we'll continue to have those discussions. It's in the Industrial Relations Commission. Importantly, that was a commitment that working men and women through their union movement wanted us to have in place to act as the independent arbiter. That's what we've got. We're not resolved yet, but we remain at the table.
Thank you. I'll go to Ms Fairman.
Minister.
Morning.
Morning.
Morning, Ms Fairman.
Minister, I want to talk about, to kick things off, the pill testing trial that's taking place this weekend at yours and our festival at Wollongong in your neck of the woods. What conversations have you had with the police minister around police presence at the festival this weekend?
Nothing specifically about this weekend, but we've had discussions broadly, and New South Wales Police have been very good in working with us during the drug summit over those 4 days. You obviously were involved, Kate. You would be aware, and others would be aware, that the 4 days that I was there was police officers there every single day. So they have worked well with us. I'm not, can't have the ability, shouldn't have the ability to tell police what they need to do, but our department has regularly, and my office is regularly engaged with police broadly around what we're trying to do, and this will be a first. I know it's been a personal issue that you've advocated for a very, very long time, and I'm looking forward to see how it rolls out for the first time in New South Wales this weekend.
Is there, so there will be a pill testing tent, as far as I've heard, but also there's been very strong messages sent in the media by your government that there'll still be a strong police presence with potentially drug dogs and strip searches still taking place. Is that your understanding? Yeah,
I can't comment on what police tactics or what they decide or don't decide to do. Obviously, the area where a member of the public has chosen to go and get the drugs tested, there won't be police per se right there and then, but these drugs are still illicit in nature, and there is a inherent contradiction to what we are trying to do. I recognise that, the Premier has recognised that. This is not an easy piece of public policy to navigate, but they are still illicit in nature, therefore police have the capacity to seize them should they see fit. I won't comment on the particular tactics that they're going to use or deploy for this weekend. That's certainly not my business, other than to say that we are working well. The Secretary has worked well with the Commissioner. We've worked well as a department with police. This is something that we're all looking forward to seeing what happens and what the results are, and we'll be very transparent with the community about those results.
Thank you, Minister. Are you aware of what one of the recommendations from the Coronial inquest into those terrible, tragic deaths at music festivals in the summer of 2019-20? One of the recommendations was not to have sniffer dogs outside music festivals. Are you aware of why the coroner suggested that?
I imagine the coroner made that suggestion because of feedback that there could be a tendency for people to consume those drugs very quickly, and that may or may not pose a problem. What I'm trying to say is I have no influence, nor do I seek to have an influence over the decisions the police make for specific festivals from time to time. They will make those operational decisions. What we will do as a health agency is make sure that we're providing the person who comes in contact with us the most up-to-date advice, clearly say to them that is a risk, clearly identify what we have found from the tests, make them sign a waiver so they understand the risks of taking these types of drugs. We're focusing on the health availability and the health interaction. I'll let police sort of engage and deal with their side of it in terms of enforcement.
Minister, do you see it as your responsibility to recommend a whole of government approach to reduce the harm from drugs, though? That's where you take the lead, isn't it?
Yeah, I do, but my focus is on, one, implementing this trial to the very best of our ability and making sure that we get rich data that demonstrates one way or another the effectiveness or otherwise of this particular trial. It is illicit drugs, and police are able to enforce the laws around illicit drugs, and therefore how they choose to enforce those is really a matter for them. I'm not going to sort of second guess them, but only to say a couple of things. We've been the first government to take this issue on, and that's something that
in New South Wales, is that what you're referring to?
In New South Wales, that's something I'm proud of. Not around the world or in other states; they have already done it. I accept that.
Yeah.
But we're the first government in New South Wales to have a crack at this, and we will wait for the further recommendations that come down as a result of the work that Carmel Tebbit and John Brogden have done through the summit.
Yes, I'm very much looking forward to that as well. The reason I asked about the drug dogs out the front before and the recommendation from the Coronial inquest was because, in fact, one of the people, the young person who died, Alex Ross King, the coroner found she died because she took all of her drugs at once because of the drug dogs. So that could still be happening this weekend at Yours and Ours, even though there's a pill testing service inside.
Yes, that is the case, and those matters are best directed to the Commissioner and the Police Minister. From my perspective, what my responsibility is making sure that that interaction with health professionals is as robust and as strong as I can make it. The way in which police choose to enforce illicit drug use is a matter for them. I'm not pretending that there's not an interaction. I'm not pretending that at all. And I'm not pretending that this wasn't discussed at the drug summit. It was.
Can I just tell you, Minister, I would suggest that every other site, music festival around the world where they have pill testing on site, patrons don't have to run the gauntlet of sniffer dogs on the way in. And if you're suggesting that this is a trial to see whether it's effective, I'm concerned that it might not be effective because patrons are getting a very clear message and may not use the tent as much as you think they're going to.
Well, let's let the festival take its course. I'll person who will dive deeply into the data about this because it's an issue that is important to me, and that it's important that we get this right. I just probably can't say again. I don't know whether there are sniffer dogs in other jurisdictions. I thought there was, but you may raise a point.
They exist, but not to the extent
I'm not aware of. But it's a matter really for New South Wales Police in terms of their operational use of sniffer dogs and the way in which they make a decision to enforce legislation around illicit drug use.
Minister, I think the coroner also found, and her recommendations were clear, that it was the behaviour, the presence and what the police do at festivals that was leading to some of the drug harm. So at some point, don't you think you have to have a conversation with your counterpart, the police minister, about how to reduce the harm from drugs? As health minister, at some point you've got to have this conversation and hopefully come out on top. I mean, this is it. That's the only way to reduce the harm from drugs.
I'm not convinced it's the only way of reducing the harm for drugs. I'm not going to say that illicit drug use in any way, shape or form is safe, nor am I going to pretend in any way, shape or form that illicit drug use doesn't take place. Because it does.
That's not in any way what I was.
But what I'm saying is that that's a matter for police. Coming out of the drug summit, that issue will no doubt be examined and discussed, but the final decision rests with the New South Wales Police Commissioner in terms of the operational tactics they use. I play a part in this, and I'm not saying I don't.
Sure.
But my part is not to direct police to carry out or not carry out certain operational tactics in relation to the enforcement
Just
of illicit
one last
drug use.
question about
Yep.
pill testing before my time's up.
Yep.
Why did the government, again, this is rather unusual for pill testing services in other jurisdictions as well, why did the government feel compelled to run its own pill testing service as opposed to take up the experts who are running it everywhere else, Pill Testing Australia, The Loop? In fact, Pill Testing Australia was going to do it for free, and I think your government's poured $1 million into it. Why did the government feel compelled to do it itself?
Well, we have this infrastructure in place through the pathology that we do across New South Wales, and we believe that this is the best way to do it based on health advice to integrate with other health services that we might be able to provide the person through a very wide and integrated health system, which is New South Wales Health. So we believe that that's the best way of doing it. I want to see the trial take its course. I then want to dive into the data. I'll be transparent about what we find and what we don't find. If there can be improvements to be made, if we have another trial site like this, then we will make those adjustments along the way.
I just wanted to make a point, if that's okay, Ms. Verman, that we're actually doing this in partnership with NUA. And just to reassure listeners for this session, if anyone's tuning in, it will be really very much peer-led. So just to reassure them that the peers will be doing the brief interventions, doing all of the front bit. The bit that Health feels is best done by supporting our pathology services. We actually do have an extensive drug surveillance, and I'm probably on the record of saying we've issued more drug alerts based on that intelligence. We do perform functions for police, which test seizures. We do have a system where patients presenting to our hospital systems, such as intensive care units, we get toxicology results from bloods and urines on those individuals, and in some cases also sampled the pills that may have accompanied them to inform a risk matrix. So the back end, I think I would describe it as the back end of this will be supported by the robust technology that's from an accredited laboratory system in our New South Wales Health Pathology that does all of the testing for the Coronial service and for police. So we think that's the best sustainable way of integrating it. But it's important to know that this is very front-ended by a partnership with our non-government organisations, NUA, and the results, and we have got a steering committee which again reflects the partnership with NUA and other academic partners that are part of our overall surveillance and warning system. Thanks.
We'll go back to the opposition, Mrs. Ward. Mrs. Carter, my apologies.
Thank you. Minister, I understand that you met with Eloise and Danny Massa, the parents of little Joe Massa, yesterday.
Yeah.
Can I confirm that you have actually written to the Attorney-General regarding a coronial inquest into Joe's death?
Yes, I have, and I appreciate the question. Probably one of the most difficult weeks I've had in public life. Her family's been through hell, and I don't know how they are doing what they're doing at the moment. I don't think I would be able to do it if it's my child, but I made it clear to them yesterday, and the Premier made it clear to them yesterday that we will use these positions to make sure we bring about change to try and make sure that doesn't happen again.
Thank you.
So I wrote to the attorney wrote to the coroner via the attorney this morning, and I did that because overnight I just wanted to check with the family that the correspondence reflected their concerns.
Thank you very much.
Chair, thank you. Minister, hospital parking fees are a tax on the sick. Do you know who said that?
No, it sounded like something maybe Minister Hazzard would say. I don't know.
Actually, Minister, it was you in 2021.
Jesus.
You said hospital parking fees are a tax on the sick.
Right.
Hospital parking fees are nothing other than a cash cow. Do you know who said that?
No, I don't.
Ryan Park did in 2019. You said that.
Clever fella, I hear, yeah.
Minister, you raked in $51 million in parking fees last year. Why are patients paying more for parking at metropolitan hospitals under the Minns government?
Well, let's be clear. We took a commitment to the election around regional parking.
No, Minister, I'm not
would
asking
be
about
free.
regional. I'm asking about metropolitan hospitals. That was my question. You raked in $51 million in parking fees last year. Why are patients paying more for parking at metropolitan hospitals under the Minns government?
Okay, so, and I'll give you this figure to make sure that it is accurate, but I have had a look at this for the sake of the committee's prep. In 2019,
Minister, I'm going to stop you there. We're not asking about, we're asking about this year.
Question. I
come
don't
on.
think it's really fair to cut someone off about 6 seconds in.
It is this budget estimates from this year. It is your health
I am
report
answering
of
the
51
question,
million.
Chair.
Please do.
I think the Minister was about to answer the question.
Thank you.
In 2019, the annual report showed a figure of around about just over $50 million, and I'll get the exact figure, but just for the purpose of the discussion. In 2024, from memory, that was around about just over 51 million. Now that's less than inflation over that time. Obviously, we have recognised, and I think other governments have recognised, the need for a contribution to be made. We do have free parking across regional areas, but you've got to remember that if free parking was available everywhere, patients and their families would often struggle for a parking spot as well. So it's a real balance that I've got to ride in terms of making sure there's parking available for staff in a way that's affordable, but at the same time making sure that it is available to patients, carers and families who are attending the hospital. Now, the parking under your government was heavily subsidised, 100% it was. Under this government, it's heavily subsidised. That's the case. Every dollar we get of that, let's just call it 51.X, and I'll get the point X to you, but every dollar we get in relation to that goes back into the health system.
Minister, is it still a sick tax?
Well, look, how people want to categorise it is up to them.
Your words. You said it's a sick tax. Is it still a sick tax?
Well, look,
$51 million under you.
I think at the time there could have been some improvements made in relation to regional and rural parking. We made a commitment around that. Minister Hazard.
I don't need your commentary.
Minister Hazard at the time made parking free during the COVID pandemic for a range of reasons. That pandemic obviously has subsided, and we can't continue to do that in the same way, because I've also got to make sure that when families of patients try and access the hospital, that there's parking available for them. So it's a balance, and at the moment this is the way we've chosen to look at it. I'm always open for discussion around parking. It's a big issue. I think it's a big issue in every hospital in New South Wales.
Do you disagree with yourself it's a sick tax?
No, I would prefer to say that
I'll move on.
In the essence of time, as we've come out of COVID, as we've focused on those regional and rural areas where public transport isn't as great
Let's talk about that.
and as strong.
Yeah, let's talk about that then. So Labor committed before the last election to making parking free at Gosford Hospital. So why are patients paying for parking there today when other patients at regional hospitals aren't?
Well, I just want to be, I'm not aware of the commitment around Gosford Hospital per se. I'm aware that we made decisions around regional hospitals that didn't include very large metro centres. I understand, like where I'm from at Wollongong, and that's because for that particular hospital, public transport was better than some other hospitals.
Gosford
in regional
Hospital.
and rural areas, people don't have access to those public transport arrangements. So, yeah,
So, Minister, do you concede that the government's broken its promise in relation to free parking at Gosford Hospital, which you promised?
No, well, I'm not convinced that was the promise. We made Wyong Hospital free, and because of that classification, and we have increased parking spaces under our government by around 3,500 spaces since 2019. So 850 of those have been increased just since we took office. So you made some increases, and then we've accelerated that increase.
Minister, you called for parking You said that parking at hospitals is a sick tax. You slammed the former government over it. Now patients are paying millions of dollars under you. Isn't that just a sick joke?
Well, the reality is parking at hospitals has and will continue to be heavily subsidised. As Minister Hazzard needed to do, was to strike a balance between providing that subsidy and providing affordable parking, whilst at the same time making sure patients and carers, particularly those that are dealing with chronic illnesses, particularly those who are doing cancer treatment, who are there frequently, can get access to parking as close to the hospital as possible.
That wasn't your promise before the election.
I'm not saying that balance is always right. I'm not at all saying that.
All right.
And could the situation be improved? Perhaps it could be. But I've also got to strike a balance between patients and their family who frequently use the hospital and the staff.
You said that. Yep. So it's slightly different to what you said. Let's move on. Minister, on cuts to the IVF rebate eligibility, did you personally raise any objections to these changes?
Well, I won't have sort of discussions that, because it's illegal for me to talk about discussions that take place in Cabinet. I know you would know this as a former minister, but I'm not allowed to do that. So I won't go on that.
Not asking about Cabinet. I'm asking if you made any submission about that cut to those IVF rebate eligibilities.
I had a range of discussions around all of the budget measures in health, around with the Treasurer, with my other colleagues, etc. But I'm not, because I'm not allowed, I'm not going to go into those discussions. I just, on that particular program now, I just want to highlight a few things.
I'll come back to that, and we've got time to do that, but I do have some questions in limited time.
You just asked me about, that's all.
Well, what I'd like to understand is whether you took a stand on that, whether you raised objections to it as the Health Minister.
Well, to be clear, we're investing under my leadership and under the leadership of the Secretary, $52.2 million. That's more than double what the previous government contribution was, which was give or take around $24 million. It ran out of money within 2 years. I had to make sure the scheme was viable and focused on those people who needed it most.
So you took it to Cabinet, Cabinet said no?
I can't comment about what went and was deliberated in Cabinet. I mean, I know that would be an offence, that's all. So
So did the proposal to limit the eligibility come from your department or from Treasury?
We have, as the government, decided to extend the scheme. We've decided to focus on a cohort of people that we believe needs it most. That means that our investment in the scheme has gone up to around about $52.2 million in comparison to around $24 million under the previous government.
But can I just stop you there?
I can't be clear. We've made a focus on making the scheme sustainable by making sure that it focused on those who need that financial assistance.
Sure, and I can read the budget and your investment, and thank you for that. But what we're concerned about is the cut to eligibility for those people that were relying on it. You've now said no. The Premier has said no.
Well, under the previous government, the scheme is going to run out of money. That's always a problem. So I've made a decision to correct that and reform the program. The way in which I reformed the program was to expand the amount of money going into the program, but making sure that it was available to those who need it most. IVF is extremely expensive.
So you're choosing who can be parents.
IVF is very, very expensive. It's extremely emotionally draining for both people involved and their broader family, and I understand that.
Thank you. Minister, you said last year in estimates that, quote, we need to do more when it comes to Parkinson's. The Movement Disorder Service at St George Hospital will close at the end of June if you don't fund specialist Parkinson nurses. Will they be funded?
I'll need to take some advice on that. I can't reveal maybe much to your
with
frustration.
Respect, Minister, it's
I can't
February.
reveal things that are in the budget. I'm not going to make any budget announcements yet. That'll be something that I have to wait for the Treasurer and the Premier to do, as other governments have always done. So I will just take your comment as factual, and I will have a look at it, but I can't make any budget announcements that the government is working on broadly, both in my portfolio or any other portfolio.
So the movement disorder service at St George Hospital, which has helped over 450 patients in the last 12 months, has no certainty whether they will be able to continue after the 30th of June. That's not very far away, Minister. What do you say to those patients?
Well, I'll say again to those patients and those staff that we are in the process of putting together our budget. I've got a responsibility as the person who spends the most to make sure that I'm allocating that money to deliver the greatest good. I'm sure the service that is provided at St George is fantastic. I will take some advice on it, but I can't make budget announcements during the estimates hearing when the budget's not due to take place for a few more months. That's not my responsibility. The budget hasn't been finalised. The Treasurer will hand down the budget, and that'll be a decision that's taken from that point on.
So this is a decision that was made on the basis of dollars rather than on the health needs of these Parkinson patients?
Well, no, not the case, because I'm going to seek some advice on the specific program, but I'm never going to apologise for making sure that I spend taxpayers' money to deliver the greatest good to the greatest number of people. You would be aware that there were programs that we inherited, including the potential removal of 1,100 nurses, that we had to find significant funds to ensure that they continue to operate within the health service.
And Minister, I'm also aware that you inherited this program, that the Coalition invested $8.6 million in over 4 years, which has helped fund really critically important movement disorder nurses across New South Wales. These patients and these nurses need certainty that care and jobs can continue after 30th of June.
Yeah, and I'll give a commitment to the committee, because I think budget estimates committees are really important for transparency and accountability on the executive, and I'll give a commitment that I'll seek advice on that. We did, coming out of a discussion that we had, I think last year, and I'll stand corrected, that we provided some funds to Parkinson's New South Wales, is I think the peak body of around about $75,000 to help those with movement disorders. But on this specific program, I'll take some advice, but I can't make any announcements regarding the budget.
Have you told the Premier that the movement disorder service at his local hospital will close at the end of June if they don't receive ongoing funding?
No, I haven't, but I'll check. The Premier's a very good advocate for the people of Cogra, and this might be an issue that he's corresponded with me about. I don't know if that's the case. I haven't spoken to him about. I can assure the committee that I haven't spoken to him about this one, but I was at St George Hospital yesterday, and the investment happening there is really important. Close to $500 million will be completed at the end of this year, operational back end of this year, early next year. So I know that hospital
and
well.
you're advocating for the services at that hospital, especially for our Parkinson's patients?
I'm always advocating for improved health services. Minister Hazzard and Minister Taylor would have advocated for improved health services within their government. That's my job. I'll always do that. That's what I would expect of a health minister, and
Thank you,
that's
Minister.
what I expect of myself.
Can I confirm whether the land for the Rous Hill Hospital site has been purchased?
Well, the Rous Hill Hospital is a significant development. Now, that
Have we bought the land?
We've had to increase that allocation by an amount which is staggering, an extra $400 million. Now, the reason why we've done that in relation to Rous Hill is because what was originally planned, Ms Carter, wasn't going to keep up with the growth in that particular area of northwestern Sydney. Now, in relation to the
Minister.
land,
have we bought the land?
I know. I just wanted to give the committee context.
Yep.
I know you know a lot about the health portfolio, but not everyone may have that same knowledge. So I just wanted to give that context. The land has been identified, yes, and I understand that the purchase has taken place, but I can ask the Deputy Secretary to to make sure that that is as accurate as what my memory recalls.
Yeah, thank you, Minister. Just to confirm that we're in the process of resolving that land acquisition within the Land and Environment Court in terms of the dollar value payable. However, we were able to progress the project on the basis that the land acquisition is complete, but we are needing to finalise the number. That's a process that proceeds through the Valuer General and then into the Land
Who owns
Environment
the
Court.
land?
The current land ownership, I just need to confirm that actually. I'll check that question.
So Health doesn't own the land yet. And
We're
why
working
is
through
there
that process. So
why is there an acquisition dispute in the Land and Environment Court?
In relation to the value payable. So there was a disagreement in terms of the amount of money that the land was worth. And what we're working through is the amount payable to GPT, who are the owner of the land.
And if GPT are unsatisfied, will that acquisition proceed?
Yes, it goes through a process with the Valuer General. It's a established process, so that there's no question that it will proceed. It is the case that we are just negotiating in relation to the amount. It goes through that Land and Environment Court process. The Valuer General provides
so this is
an amount.
an arbitration clause in a contract as to value, is that?
It's
I
a
just think
standard.
in simple terms, we're probably having some discussions around not the location of the site, but the amount
How much?
that will be exchanged.
What's the dollar amount?
Yeah, I don't have that on me.
Will it
but-
blow the budget?
No.
So it's
No.
manageable.
No, not look. The thing with Rous Hill, I would have thought not having an emergency department there would have been problematic. That's what the last government proposed.
Sorry, we
So-
don't seem to have an answer. Ms. Skulanda, what's the top figure that we will be paying for that land?
The Valuer General determined an amount. I don't know.
Which was what?
I need to confirm if that's a confidential amount or not. I'll need to come back to you. I'll try and come back to you during the
Thank you.
session.
Okay, thank you.
And to confirm, we have budgeted an amount that will enable the project to proceed. And therefore, we're progressing on the basis of the fact that we own the land and we're able to continue. It is not delaying the project.
Thank you. Minister, you indicated that Labor promised a full-service hospital at Rous Hill.
Yeah.
Is a hospital where women can't give birth a full-service hospital?
Well, birthing is a very interesting topic, and I've spent a lot of time over the last 2 years
It's
looking
part
at
of a
1 minute
full-service
left,
hospital,
yeah.
isn't it?
Well, an ED is probably a basic part of a hospital. You didn't propose to have that in Rous Hill.
The question
We
to
are-
you is, Minister, will
yeah.
there be a birthing unit
So-
at your full-service hospital at Rous Hill?
So, Ms Carter...
It's a yes or no question, Minister.
Just let me jump in if you don't mind. We are having a look at the issue around birthing services, the provision of birthing services at that hospital and surrounding hospitals. I have become aware through community advocacy, local member advocacy, upper house member advocacy, who are duty electorates, that is the duty electorate, that the community do see that as an initiative that they want to focus on. Government is looking at that. There has been no decision made, so I want to be clear about that. I've not made that decision. There is provision in place, but we have not made a decision around
Minister, just
maternity
on
and
Rous
birthing
Hill,
services at that
you've done a
hospital
sod
at the
turn at
moment.
Rous Hill, haven't you?
What was it?
You've done a sod turn at Rous Hill.
I've been to the Rous Hill site, a couple
You've
of
done
times.
press releases and a sod turn, but you don't even own the land.
So just to confirm, Health does own the land in terms of the exchange of contracts, and it is the value of the land that is in dispute through the Land and Environment Court, which is a standard process.
So contracts have been exchanged but not completed?
Mrs Cotter, I've allowed witnesses to continue after the bell, but you can't ask another question.
Could I just clarify for when you're coming back on that question, just specifically, could you just come back to us on how much the land value has increased?
Yeah, I'm just checking if
Thank
that
you.
one's confidential. Thank you.
Thank you.
Minister, I just wanted to briefly come back to the issue of Joe's tragic death at Northern Beaches Hospital, and acknowledge there's already been some questions this morning about that.
Yeah, I understand.
In your commentary in the media, you said that it's not your preferred model of healthcare to have a public-private partnership operating the Northern Beaches Hospital. Do you support bringing the management of that hospital back into public hands?
I'll just be careful with my comments because I'm just acutely aware of the pain and suffering a family is going through, and I don't want to politicise this in every way, so I'll just take my time. It's not a model that we supported. It's not a model that we are ever going to do. We won't ever be going down the path of a Northern Beaches Hospital model of healthcare whilst I'm the Minister and whilst the Premier is the Premier. That's been made clear publicly, it's been made clear to the family. It is a very complex contract that Healthscope have with government, and the previous government entered into that contract with Healthscope. To unpick that can't be done overnight, but we are looking at that provision of care and that model of healthcare. Now, I don't have any more to say than that at the moment. We are not at a stage where we are making any commitments one way or another about that. That's not the case. We made it clear to the family yesterday that we understood that that's what they were advocating for, but from our perspective, this is a very complex contract that goes over many years that we would be essentially unpicking and unpacking. So that can't be done overnight, and that does not mean that I don't understand the concerns expressed by the family and by others, including the local member in that area. I have given them assurances that this government won't be going down that model of healthcare going forward.
Thank you, Minister, and I appreciate your sensitivity to the family at this time, but I look forward to following that up with you perhaps later this year.
Yep.
I just wanted to come back to the wage negotiations with the New South Wales Nurses and Midwives Association, and you mentioned that you'd met with them recently, which is welcome.
Yep.
The Commonwealth's recent announcement of significant additional funding for hospitals came with commentary that this would help address the wage pressures you're experiencing in New South Wales. As a result of that additional funding, have you improved the offer that you've actually taken to the Nurses and Midwives Association?
No, I haven't, and I want to be very clear about this, and this might be unusual coming from a Labor Minister to a federal Labor government, but I'll be just very transparent. That money cannot and will not be used for that, and there's a number of reasons why it won't be that I'll explain now. Firstly, it is one-off money, so what I would be doing is essentially saying to Nurses and Midwives Association, you could have this amount for essentially 1 year while your wages are adjusted, and then it has to go back because there's not a flow on. We did not secure a 5-year deal, so that's number one. Number two, which is important, is that there is strong advocacy from nurses and midwives for increase in remuneration for their employees and members, and rightly so. But there is equal strong advocacy for other parts of the healthcare sector and profession, including those represented by the HSU and ASMOF and the PSA. I have the joy of working with multiple unions across the portfolio, and all of them, as you would expect, are advocating for increases in remuneration. And the next thing about that federal money is that the 407, which I think is roughly what it is, we haven't seen it yet, hasn't hit our bank account, so we're waiting for that. But that will primarily flow through to staff through hospital activity. As you know, that's what it will largely result in. From memory, about 65 odd cents in every dollar that we fund in hospital activity goes to staffing related costs, and the largest proportion of that is obviously nursing. So that there's a number of reasons why we can't just do that. What the Commonwealth could do to help us is give us a better deal for our GST, and that would be very helpful, and we would welcome that, and we would have wanted a 5-year National Health Reform Agreement rather than a 1 year, but that decision wasn't taken.
Thank you. I'd like to turn to a different issue, which is abortion. Firstly, commend you for your intervention late last year at Orange and Queanbeyan hospitals after it came to light that patients were being turned away from public hospitals. Since that time, what work have you undertaken to understand the extent of that issue across the state?
Yeah, this is a tough issue, and the issue around Orange Hospital was not one that I found satisfactory, and we made it clear that needed to be fixed. We have extended the search project, which that builds the capacity of regional and rural service providers to provide that abortion care. We've extended that extension of around about $800,000 builds on the initial investment of around 1.2 that we made into that. We've got a 2-year extension commencing in 2024 that will expand that model to add 20 new organisations, partner organisations, and 40 individual GP partners, particularly in rural and regional and remote New South Wales. We're in the process of finalising the mapping of where these services are and are not. You are right to say that the further you get away from metropolitan Sydney, the more challenging these services are for women to access. By no means am I saying that it is perfect at the moment, but we have a very committed group of staff within the ministry who understand that the availability of this service is important, not just to me and the Secretary, but more importantly to women across the board, and we need to continue to do what we can in this space.
Thank you, Minister, and I appreciate that the search project is very worthwhile, but I'm specifically interested in the issue of public hospitals, and you probably would have seen some investigative journalism from The Guardian that found that only 3 public hospitals in New South Wales are consistently providing abortion services and actually making it publicly known that they do. Is it your understanding that that figure is correct? And if not, what are you doing to actually ensure these services are provided consistently and that the public knows where to find them in public hospitals specifically?
Yeah, so a few things. There was an immediate and pretty urgent review of a New South Wales health policy directive and the related policy documents and the data notification requirements that that'll commence in March. There's immediate initiatives to boost consumer information and awareness, which you raised. That includes financial assistance to address access barriers, particular barriers for priority groups. That'll continue. That commences March, that program, and that'll continue to the end of budget commitment 26-27. We also, through the Secretary, made it clear, sent a clear direction to districts that the New South Wales Health had responsibility for abortion care under the Act that had been changed, and that the New South Wales policy framework for termination of pregnancy in New South Wales, those 2 policies govern what we do. That occurred in November of last year. So we are making inroads. We are not by any means pretending that this is perfect across the board, but we are making inroads, and I note that you have a private members bill that we've engaged in and will continue to engage in for our political party. That is a conscience vote, so it won't be a recommendation where that comes from the minister, but that will be a conscience vote that members of the government can decide how they want to weigh. But it would be wrong for me to ignore the fact that there's a piece of legislation that you have led, that you've engaged with us on, that you believe will lead to improvements in this area. It would also be wrong if I said that this would necessarily be a government position when under our party structure this will be a conscience or free vote.
Thank you, Minister. Just in my last 20 seconds,
yep.
Coming to the issue of meningococcal B vaccination, I understand that you've met with people who've lost children to meningococcal B previously and taken the position that this is something better funded by the federal government. What specific actions have you taken to advocate to the federal government to fund meningococcal B vaccination?
A couple of specific actions. I've written multiple times to the Federal Health Minister about this because I do believe that this should be done through the National Immunisation Program. I've met with the Health Minister about this. I've discussed it at Health Ministers' meetings, which occur roughly every couple of months. That decision hasn't been taken as yet by the Commonwealth. I have met with family members who have been directly impacted, and I understand their advocacy. At this stage, New South Wales has not decided to go it alone. We will continue to advocate for for this to be on a Commonwealth program to be done so that there's no discrepancies across the board, but to date we haven't seen that, and I understand that is frustrating for people involved in this across the sector.
Thanks, Minister. I'll go to Ms Fairman.
Minister, are you concerned by the results of blood testing by a few Blue Mountains residents that have found high levels of PFAS in their blood? Are you aware of what I'm talking about?
Yeah, I am aware of what you're talking about. It's an issue that I've had a pretty long and extensive chat with Dr. Chant about. Yes, I won't take up any of more of your time, but I am aware of it.
Okay, so are you aware of what, for example, one of the residents, Catherine, has 20.98 parts per trillion, nanograms per millilitre in her blood for PFAS, for the total of PFAS? Are you aware of that amount?
I'm aware of reports around that. I obviously haven't seen those results, Kate, but I'm aware of public reports of people with a high number.
So the issue with this is that that stat or that amount of PFAS is much higher than the average amount of PFAS in the blood of communities who we have historically know are PFAS impacted, such as Williamtown, Oakey and Catherine.
Yep.
So this is the average PFAS there is from 4.9 to 6.6 nanograms per millilitre, right? So we've got one Katoomba resident, in fact we've got three, that have their average PFAS levels higher than what the government has historically thought are PFAS impacted communities. Firstly, clearly the Blue Mountains, the Katoomba area, Blue Mountains area, they're PFAS impacted now. You would agree?
Yep.
Right. So these people paid $500 to get their blood tested. But the woman who I just mentioned, Catherine, has had a lot of different health issues over quite a few years. She had to pay $500 to get her blood tested. Do you think that's fair?
Well, obviously, like many communities, PFAS as a forever chemical is in place. So when I say that community is impacted, so are other communities. I'm not saying most communities across New South Wales is likely to have some impact of PFAS. And the advice I've got from Dr. Chant, and as I said, I've taken the time to have a number of detailed discussions with the Chief Health Officer about this, that at present there's insufficient evidence for medical practitioners to be able to tell a person whether their blood level of PFAS will make them sick now or later in life. That's the first issue. Dr. Chant has recently, and is in the process of, have taken a decision to establish an expert panel to report directly to her on a range of these issues, including PFAS, to make sure that the way in which we're managing it at the moment is most effective. The epidemiological studies that would be, from my advice, and I'll ask Dr. Chant to have some words in a moment, but would be very unlikely to be able to show any health outcomes that could be directly attributed to that PFAS amount. Now that's the advice I'm getting. But
Minister,
Dr. Chant
I will go to Dr. Chant in a second, but I certainly hope that the advice you're getting now is updated compared to what New South Wales Health was saying even 2 years ago, because there's just been so much more information that's come to light. Dr. Chant, what advice are you still giving the Minister, the same advice that New South Wales Health was giving a couple of years ago, or are you basing it on where, for example, best international science is at with this? And let's start with the International Agency for the Research on Cancer.
Yeah, so clearly, and I think even when we stood up in relation to this, that report had come out. Also, that was an initial report. I'm pleased to say that IARC has actually published the full rationale behind it just recently, so we are reviewing that, and that will be an opportunity for our expert technical panel to review the full details behind IARC's thinking. So I agree that...
So just to be clear, in terms of IARC's thinking, So that's saying that so one of the PFAS chemicals is carcinogenic.
That's right.
The second is possibly, so it's PFOA, I understand, is carcinogenic according to IARC. PFOS, possibly carcinogenic. So that's come out 745 pages. I had a look at it as well. 745 pages from the International Agency for the Research on Cancer published the monograph 2 weeks ago.
That's correct.
How is it going to influence New South Wales Health's stance? Will you challenge the National Health and Medical Research Council's year-old PFAS guidance as a result of this?
Well, there's been a couple of things that have occurred, which is NHMRC's recently, as you are aware, released the information around the updated water quality standards for PFAS, and that led to a range of the testing across the state. So that testing, that change in policy reflects NHMRC's looking at the contemporary information available. I understand, and we actually requested that NHMRC link in with IARC and try and get more information about the underpinning studies that IARC relied on, and some technical aspects of some of the endpoints used. So we are really engaged in recognising that there is emerging evidence and we need to give people the best advice. And that's why I've brought together a technical panel that'll be representatives across cardiologists, toxicologists, neurodegenerative specialists, across all of the areas. And that will review all of that information. And obviously that will then mean that we can give the most up-to-date. At the moment, we are still saying the current advice is we don't know how to act on or interpret the PFAS testing. But as science evolves, that may change.
So
that
just
may change.
To be clear, thank you. So, Dr. Chan, you approached or recommended to NHealth to consider whether it needs to review the statement on PFAS, their guidance, in light of the IARC's findings initially. So you fed that back, I understand. Is that correct?
So a couple of things. One is in relation to the NHMRC's consideration. I can say,
but not the Australian Drinking Water Guidelines. At this point, it's the guidance that was released in January last year.
So what I'm talking about is the Australian Drinking Water Guidelines that have been reviewed. As part of that process of NHMRC, obviously the IARC statement was very significant, and I did urge NHMRC to try and get some of the underpinning documents so that the Australian Drinking Water Standards Review would be principled on the most up-to-date and current.
So I understand that the NHMRC or NHealth has said that they will wait for the full monograph behind the IARC's findings on PFOA and PFOS, which came out 2 weeks ago, right? So this has come out. And this is their justification and reasoning and all of the evidence and all of the science to declare PFOA carcinogenic, and for example, states like countries like the US to have a 4 parts per trillion guidance.
We stand by the IARC's considerations and deliberations, and so I've publicly on the record of saying that.
Does that mean the draft drinking water guidelines will change?
No. So there's two separate processes. The drinking water guidelines were developed at the time, were going through the process of revision during the time when IARC came up with the monograph. And what I'm saying, in terms of the NHMRC, they did attempt to interact with IARC to see if they could get an early release of some of the more detailed data underpinning it. I'm not sure of the outcome of that, but I would assure us that NHMRC would have been very keen to understand the basis and include that in the review. I can follow up with NHMRC about that.
So the question is really that, are you comfortable then with a 200 parts per trillion guidance for the PFAS chemical that IARC has just released a 745 5-page document saying is carcinogenic?
I'm very confident with the NHNMRC process, which is an independent process led by NHNMRC. I'm happy to follow up the details of how that's really a matter for NHNMRC, but I'm confident with the processes, the robust processes we set to establish
There is a
drinking
lot
water
of disquiet
guidelines.
in the department, though, Dr. Chant, in terms of some of the emails that I've seen through this call for papers. There's quite a few different correspondence and discussions over email from people within New South Wales Health and other jurisdictions being quite uncomfortable with the direction that the NHMRC is going in terms of disregarding the IARC's
I'd be happy to look at
rulings.
any of those emails. I think I would be happy to review those. I think the issue that we certainly highlighted to NHNMRC was our request to deeply understand some of the threshold levels, the difference between the endpoints, about whether they were using thyroid or cancer endpoints, what was the rationale. So I'm only aware that our staff have interacted, as you would expect, in a technical way to have a fuller understanding of the guideline developments and the underpinnings for that. But I'd be happy to review any emails to actually understand what you're referring to.
Thank you.
Thank you. That brings us to questions from the government.
There's no questions from the government yet.
Thank you. There being no questions from the government, we will break early for morning tea and recommence at 11:15. Thanks, everyone. Everyone, it being 11:15, we'll recommence and we'll start with questions from the opposition. Mr. Fang.
Thank you, Chair. Minister, thank you for attending today.
Thanks,
I want to start, will you guarantee 24/7 emergency coverage for Waa Hospital?
Waa Hospital, staffing of Waa Hospital has been a challenge. Want to be open and transparent with the community.
Could you just bring your microphone a little bit closer? Sorry,
sure.
I'm struggling to hear you a little bit. So
No worries at all. Sorry,
Wes.
Sorry, Wes. The staffing of Waa Hospital has been a challenge. It's been something that we haven't resolved as yet. We are working with both the local member and I know he is working with community leaders. In May of 2023, we reduced the hours from 24 hours, as you indicated, down to 8 till 5:30, 7 days a week. Outside of these times, ED presentations are redirected to Narrabri. Patients presenting to Waa who need admission will obviously receive inpatient care at Narrabri. We are making recruitment efforts for the vacancies. There is what I'd loosely call a working party established with the local MPs, local community leaders, local health representatives around how we can try and accelerate that and what we can try and do to get that resolved. Mr. Sloan, as the Deputy Secretary of Regional, has also initiated a collaborative care program which was facilitated by the Rural Doctor Network to review the planning and delivery of public health services to the community. So that piece of work is trying to identify what we really need there and then roll it out. But vacancies has been a challenge in Waa. I know it's something that the Shadow Minister for Regional Health, Gurmesh, has raised with me. I know it's something that Roy Butler has raised with me on multiple times. I'm not going to pretend I've resolved it yet, but I'm acutely aware of the issue because of community representations, Shadow Minister representations, and the local MP, Roy Butler's representation.
Thank you for that, Minister. In your answer, you said that that you're working out what the community, what's needed. The community needs 24/7 care in their emergency department. Isn't that? You don't need a working group to determine that.
Well,
right?
I've just got to make sure that the presentation levels at that hospital are adequate enough that clinicians can ensure that they are getting enough throughput. Clinical health, as you know, as someone who's been involved in the delivery of healthcare, does rely on a volume issue to ensure that practitioners maintain their skill level and their knowledge. If that volume is not there, that becomes a safety issue and a concern for me. So whilst I understand the community may want something 24/7, I'm not ignoring that. I'm just saying, A, the ability to staff it in a way that is safe, and B, the ability to staff it in a way that clinicians themselves continue to get that exposure and volume of patients through there is just a bit challenging.
No, I accept that, Minister. But I'm just trying to understand how you're managing some of those challenges. In relation to Waa again, how many of the health staff have taken up the rural incentive scheme there?
I don't know. Let me just check if I've got that specific number. I don't have that as a site specific. Luke, you don't. I'd have to take that one on notice. I'm happy to, but I
worries.
I can
All right.
confirm that all the vacancies there are advertised with an incentive.
You might just bring them. Yeah.
So I can confirm all the vacancies there when they're recruiting are advertised with incentives.
Okay. Will the hospital remain open even outside of the emergency hour times?
Yeah, it will. What we've just got to work with the community on now is getting the very best possible service there that meets the needs of the community, but at the same time is safe and effective for clicinians to get that volume through. And I'm not trying to dodge this.
No, I appreciate that.
I'm just being honest about I have to make that decision as well.
You indicated that Narrabri is effectively the overflow for Waa when the emergency department is shut. Have you provided additional resources, doctors, nurses, etc., to Narrabri in order to cover the surge that they'll have?
Yeah, what I know and what I'm advised, Wes, is that since the change in operating hours at Waa, and Luke can jump in if any of this is not accurate, but I talked about this recently with the local MP. There's been an average increase of around 1.17 presentations a day to Narrabri, so not, for argument's sake, not quite 2, and that's from the wider Waa region, including Burren Junction and Pilliga. There's been a negligible increase in patients from the Waa region being admitted to Narrabri. Just Waa is about 0.6 admissions per day on average. So it hasn't saw that volume. I don't have the staffing profile of Narrabri in front of me, but I understand that that is also an area that would be linked with incentives, and I just don't have the volume of increase hasn't been
Maybe
huge.
you can take it on.
I'm happy to.
Thank you.
Yep.
Minister, the Shadow Minister Gurmesh Singh is down the back with some representatives from the Waa community.
Yes.
And I'd encourage you to meet with them after you've finished at estimates here. But they've obviously, and as you said, Gurmesh has raised, the community has raised concerns with you. What will you say to the community if there's, the unthinkable happens and something happens outside of those emergency hours and somebody loses their life because the emergency department isn't staffed 24/7?
Yeah, I'd say to the community that living in a community where I'm from, where we had a round-the-clock ED at Bulli, that the previous government and others reduced the hours in, and I had to explain that to the community. The way I explained that to the community is that health facilities have to be safe. They have to meet the needs of the community. Part of them making sure that they're safe is ensuring that staff has the throughput of patient and patient diversity of conditions to ensure that they keep up their skills and knowledge. What I can't do is open up facilities that don't have that volume and put at risk patients who may present there, believing that the staff have adequate resources, skills, knowledge to do that. At the moment, we are struggling to recruit in that part of New South Wales. I'm not putting my hands up and saying,
Minister,
I quit. I'm not doing that at all. I'm really working closely with both my own agency and the local member, and to be fair, representations made by Gurmesh and the community broadly, I have read and paying close attention to. I've just got to make sure that they can be safely those services can safely be delivered.
I appreciate that. I'm just not sure that that's going to be sufficient for the community of Waa. Just if you wouldn't mind, I know you took some of the numbers around Narrabri on notice. Would you mind taking on notice some of the overflow issues that go to some other surrounding hospitals like Tamworth, etc., that have come from Waa?
Yeah, sure.
Thank you so much. I just now want to move to another issue. Harrington is a growing regional community with and the nearest ambulance station to that community being 30 minutes drive away. The community have advocated long and hard for an ambulance station. Will you commit to matching the National Party's election commitment for a new ambulance station at Harrington?
I'll have a look at it as part of the budget. I'm in discussions at the moment with Commissioner Morgan and the team at New South Wales Ambulance about the budget proposals. Obviously, like I said to Ms Carter earlier on in this hearing, I can't disclose that. That's not appropriate for me to do, given that the budget hasn't been handed down and the money is not available. I'm acutely aware that we are funding significant increases, as did the previous government, of new ambulance infrastructure across regional rural areas. Obviously, everyone wants a brand new facility or a facility. I understand that.
I appreciate that, Minister, but I think we're just talking specifically about this community in Harrington. They are desperate for an ambulance station. The National Party have committed to one. Are you going to match that commitment?
Yeah, I'm happy to. If Commissioner Morgan wants to.
I might ask Mr. Morgan in the afternoon. I'll just say that
I'm happy to take it on notice and have a look at it.
I appreciate that, Minister. Yeah. That's actually really helpful. Minister, has the Mid-North Coast Local Health District raised the issue of Wrights Road roundabout impacting hospital access?
What road? Sorry, where's?
Wrights Road roundabout in Port Macquarie. Has the Mid-North Coast...
They could have. It doesn't... I don't recall it. For my sins, I read every piece of correspondence.
Yeah.
So
recently, we had an ambulance that had to actually divert across the nature strip because there was such congestion in the roundabout.
Okay, that's a problem.
Yeah. Obviously, the National Party has made an election commitment to fix that hospital access. Are you going to match that commitment and ensure that the community can get in and out of the hospital without being impeded?
You certainly made an important election commitment in last year's budget from memory to upgrade that hospital. I'm confident that as a result of that, the access will be looked at. I'll take some advice probably from the Roads Minister and the Regional Roads Minister just on the specific nature of it, because I can't recall it coming across through correspondence. That doesn't mean that it hasn't. I don't want to make out that it hasn't. It could very well be.
Well, Minister, if it hasn't, I can tell you I'll be the first to raise it with you now, and
Okay.
I'm sure that you and I can work together on fixing that roundabout. Just in relation to regional maternity services, are you able to tell me how many regional maternity services have closed in the last 12 months?
I've got some figures the other day that I was having a look at around maternity, because out in places like Tamworth, I've got some concerns at the moment around maternity services. We have...
Well, can I say, Minister, I do share your concerns.
Yeah, no. We've got around 70 birthing services across the state. They obviously range from 1 to 6.
Mm-hmm.
We have doubled the rural health worker incentive scheme that was introduced by the former government, because we had to...
Great
had to look
program.
at that.
Minister Bronnie Taylor brought
Yep.
that in. She was fabulous former minister.
I've acknowledged her multiple times for that incentive.
Yep.
We expanded the midwifery sign-on bonus.
Yep.
That got up to 20,000.
While I appreciate
20,000.
While I appreciate you highlighting Bronnie Taylor's excellent work in the previous government, that isn't really addressing the question that I asked, which was how many maternity services have closed in regional areas in the last 12 months?
Well, I'm not sure. We've
maybe taken on notice. Is that okay?
I can answer that question. So we answered this in a previous question on notice that New South Wales Health is not aware of any regional New South Wales public maternity services closing in the last 12 months.
Okay.
But we have been advised and are aware of private maternity services that have closed in the last 12 months, and that was answered in the December 13 budget estimates.
Okay. On the issue of regional maternity services, is there a plan for Muswellbrook to reinstate birthing services?
Well, I want to have a look at what is happening there, and I want to make sure it's safe, and I want to make sure that we can get staff there. There is a subsection of the nursing workforce broadly, and that is midwifery, that we are having some really, really big challenges for. I am
Minister,
aware.
I don't mean to interrupt you, but I guess that's a broader issue.
So at Muswellbrook, I'm aware that birthing ceased back in 2022 under the former government. It ceased there. That was at the time due to struggles with GP obstetricians and their resignations.
The question was, is there a plan to reinstate the services?
Well, we've got level 1 maternity services that provide ante and postnatal. We're continuing the discussions with the district. I haven't made that decision yet, but
so can I draw from that answer, just to condense it, because I have limited time, that there is no current plan to return birthing services to Muswellbrook?
No, you can take it that we are having a discussion about it. We haven't.
Okay, so there is a plan.
I think the minister's endeavouring to answer. He's been continually interrupted.
Continually interrupted? I think that's a bit of a stretch.
At least 3 times in that instance.
Sure. This committee has similar points of order on a regular basis, and I always make the same ruling, which is that the minister should be given time to answer the question, and also that the minister should try to directly answer the specific question that's being asked.
Yeah, so just to be very direct, we are having those discussions with the district, but I will say this, Mr. Fang, it has to be done in a way that is safe. I have to be able to make sure that I can get adequate numbers of midwives and staffs there. We had a reduction in GP obstetricians in the area. the previous government rightly, I'll just be honest,
Minister,
rightly would have said that service cannot probably be operated safely.
We're now delving
We have to
outside
be
of where
wary
the
of that.
question, I guess, really was directed. I'll move on. What birthing services exist in parks? Will Forbes continue to be the fallback for that catchment area?
Well, I know that the member for Orange has raised this issue with me,
and I'm sure Gurmesh Singh has also raised it. Correct?
I'm sure Gurmesh may have as well. I'm not saying he hasn't, and I know the community has raised that with me. The challenge around that area is that whilst recruitment is ongoing, whilst we are throwing everything at that, and I've assured the local member about that, they're suspended at parks due to the inability, like in Muswellbrook, to attract and retain suitable medical staff and workforce. And the hospital, I just want to be clear on this, just so people understand the difference. The hospital is still doing antenatal and postnatal programs. I know that's different. I'm very aware that's different.
So I think you've already foreshadowed the point that I was going to make, which is you're not actually answering the question that I asked, which is are birthing services going to be returned to parks?
No, they're suspended.
And is Forbes the overflow?
Well, they're suspended at the moment, but because I can't get adequate medical workforce recruited into those positions, we're doing everything we can. I've spoken to the member, and I know the member for Orange has been advocating strongly, as he should do, as each of us would do for our own respective communities. But I've just got a responsibility as the Minister to make sure that I can deliver birthing services that are safe, that have the volume of women going through them, and that can be delivered in a way that's sustainable.
So this actually might provide you an opportunity to talk to that Minister. Does the government actually have a plan to ensure that rural New South Wales women are able to birth and have their families close to and nearby where they live?
Yeah, we do. We've investing and are investing in grad start, mid start programs designed to try and make sure that we can fast track midwives into the sector if they commenced a nursing degree and they want to go into midwifery. We've doubled the incentive. We are doing what we can to try and make sure that we've got medical staff in those areas to be able to support midwives doing it. One of the best programs that never gets a front page but is important for me from a policy perspective is that the expansion of the midwifery group practice. I know that Emma Hurst has been an advocate of this through the birth trauma inquiry that was underway. That is regarded as I'm not saying a gold standard, a high standard of care, and we've expanded expanded that MGP program. So
I appreciate those incentives. The next follow-on question is obviously when you've got a program and a plan to do these things, how do you measure its success? What is the New South Wales government have by way of targets, timelines, accountability to the health services to ensure that these incentives are actually working?
Well, I think they're working because the number of midwives who received those recruitment incentives in 2022 was around 3 people, and in 2024 it was 288. That's in anyone's mathematics a reasonably significant increase. We are also expanding MGP, coming out of the birth trauma inquiry, a landmark inquiry and an important one. That shone the light of that we need to do more as a system in relation to midwifery group practice, and we are expanding that. That doesn't mean, though, we don't still have significant workforce challenges, particularly around GP obstetricians and particularly around the sheer number of midwives that we've got.
I look forward to working with you to address some of these issues, Minister. I'm just going to move on if that's okay, because I've only got about a minute left.
Yep. Sure.
Tresillian, has funding been renewed for the regional Tresillian family care centres?
My understanding is Tresillian has continued to receive the funding that they've asked for. I won't foreshadow stuff in the upcoming budget, but we're working through with them and closely with them. Tresillian, like Karatani, do really important work to support families.
So you're not aware
parents.
you're not aware of a funding cliff arriving for them. You believe that their funding will continue into the next budget.
I mean, there could always be a funding cliff that you left us. I mean, I've had to
Well-
deal with a
well,
lot of them.
Minister,
So there's
the
probably
current-
there's
we're-
probably one or two.
We're now looking at the budget for 24-25,
we're
and
working
their
through
funding
that.
cliff arrives June 30.
Yeah, we're working through that. It's not budget day to day, but
So
I
Tresillian-
can't foreshadow, and I'm not allowed to foreshadow an announcement around that.
But Minister, Tresillian are often the only supports in regional areas for new patients around breastfeeding, nutrition and selling
are.
a baby, as well as mental health issues such as postnatal depression and anxiety. So will you commit now to there being funding post-June 30 so that rural regional women will have some confidence that they will have support if they need it for their babies?
Yeah, I think it's an important question because I think the first 2,000 days of a child's life sets them up for long-term health outcomes. All of the data, both here and overseas, demonstrates that the first 2,000 days of a child's life can have a significant impact on their trajectory. The work that both Karitani and Tresillian do in that time is something that is of great importance to me. There was $6.5 million allocated as part of the Family Start package in the most recent budget, and that allowed 7 services of Tresillian to continue to operate. I'm in discussions with them around the ongoing support and programs that they provide, but I can't preempt what those discussions in. I'll just have to wait for budget.
Thank you, Minister.
Thank you.
Thank you. We come to crossbench time. I'll start with Mr. Ruddock.
Thank you, Minister. Now, the New South Wales framework for the Specialist Trans and Gender Diverse Health Service for people under 25 years was published in September 2023.
Yep.
It references the establishment of a clinical advisory group which would be tasked with developing clinical guidelines. Now, a year later, in September 2024, in response to some questions of budget estimates, New South Wales Health did refer to the clinical advisory group, noting that New South Wales Health would consider its advice. However, I understand there is no publicly available information on either the chair, the membership, the scope, or the work of the clinical advisory group. So can you tell us, has the clinical advisory group been formally established, and if so, when?
I think it has. Does anyone want to? I'll have to take that one on notice. Sorry, Mr. Ruddock.
Okay,
if
well,
I can get it beforehand, I'll give you a commitment to get it back to you today.
Okay, good.
That way you've
Well,
got the information.
I do have a few more questions
No,
related
that's
to it,
all
so hopefully we can take them all on notice.
That's all right.
So we'd also be keen to know who the appointed members are and what their qualifications are.
Yeah.
We want to know what guarantees there are that there will be a diversity of views on,
Okay.
on this panel, which
Yep.
is best practice for advisory groups of this nature.
Yep.
We'd like to know if advocacy groups like were involved in the selection, including whether ACON was involved.
Yep.
And we'd like to know why has New South Wales Health not publicly disclosed the membership and the terms of reference about the clinical advisory group?
I am happy to take all of those on notice, but I will just say this, Mr. Ruddock, on this topic. These are pretty vulnerable children, and I just want to be really careful in the way in which we speak about these individuals and their families. They are often going through very challenging times, and I'm just, perhaps as a parent, cognizant of the comments that I make as a leader, that I've got to be aware of that people may be viewing this, and I don't want them to view it in a way where I don't think that we're taking their healthcare seriously. We do everything in this space on an evidence-based framework. We don't operate outside an evidence base. We had Sachs Institute have a look at what we were doing and making sure that we were doing that in line. I do note that the federal government has recently asked, I think it's the NHMRC, to have a look at this type of care across the country. We support that, but we are also confident in the work we are doing in this space, and I by no means say that that doesn't mean we can't be questioned. I accept that. I'm just saying I need to be careful in the way in which I answer as well.
Okay, no, I fully understand. Look, I mean, we're not asking for anyone's names to be.
No.
We're just, I mean, it is an authority that's been created by law.
Yep.
So I think the public does have.
Yeah,
I think
no
there's a
problems
fair
at all.
enough question
No problems
for
at all.
Transparency on that front.
I think it's a very fair question.
Thank you. And then the same report also did refer to the creation of a consumer advisory panel. So we'd also be keen to know, is that up and running? If so, when, and who the members are of that? Okay, so on a different question.
Yep.
In March 2022, New South Wales Health released the New South Wales LGBTIQ+ Health Strategy 2022 to 2027,
Yep.
accompanied by a summary of evidence. I am told that the most recent evidence cited in the documents dates back to 2019. Since then, multiple systematic reviews in peer countries, including the UK, Sweden, Finland and Norway, have led to significant policy changes regarding gender medicine, particularly in relation to the use of puberty blockers for minors. How does New South Wales Health ensure that its policies remain aligned with current international evidence and best practice, given that the evidence base for this strategy was already outdated at the time of publication?
Yeah, so I announced in roughly July 2023, I can't get the exact date, but I just remember it was around the middle of the year, that we asked the SACS Institute would review the evidence for the care of trans and gender diverse people. They're independent, as you know. It's a not-for-profit research body. The review provides a synthesis of what you highlighted, which was the latest evidence from roughly the period 2019 to 2023. And you are right, there was a significant volume of research in that time. The volume of research, though, didn't necessarily mean the quality of research. I don't mean that disrespectfully, but researchers obviously, given what they can influence and the way in which they set up their control mechanisms, depending on the quality. So the key findings of that review that I commissioned was that on the volume of the evidence, that volume has increased significantly, but on the quality of evidence, there are limited studies using gold standard research methods. And for those of us who have researched, done an honours or a master's or a PhD, things like randomised controls and things like that we know. And that was the case because of ethical concerns about withholding care and the small number of participants. But the review, the research showed that what we were doing was evidence-based, was in line. That does not mean in any way, shape or form that we are not prepared to continue to have a look at emerging research trends in this area. We do. I expect health to continue to do that. I would expect it about any form of healthcare, and I expect it about this, particularly with this, because you're dealing with vulnerable people, you're dealing with very, very challenging family situations, and you're also dealing with a case of a lot is happening in terms of the overall volume of research, but because of those challenges, the quality of research is problematic. And I don't mean quality in terms of poor, just in terms of the instruments that researchers use to provide robust conclusions.
We'll go to Ms Emma Hurst.
Thank you, Chair, and good morning, Minister.
Good morning.
My understanding is that maternity, antenatal and postnatal services MAPs are expanding at a much faster rate than the MGP programs across New South Wales. While obviously we're still supportive of the MAPS program, and I wouldn't discourage expanding those further, can I just get an assurance from you that MAPS aren't being implemented in place of continuity of care, of midwifery care models such as the MGP models?
No, you got assurance from me that what we're trying to do is expand maternity services and use the very best model possible to try and deliver that. I come from a community where the MGP model has been advocated pretty strongly, where there needed to be improvements in the midwifery and maternity area. That has taken place as a result of that, but I don't also pretend that, as you didn't, that that's the only model that we do. But what we're trying to do is improve maternity services across the state using the very best possible model with the constraints that we have around workforce. All of those things don't always align, I suppose is what I'm trying to say.
I understand what you're saying. And just in regards to the constraints within the workforce, does the government monitor and collect data on midwives who actually want to work within those MGP models but aren't able to find opportunities to be able to do so?
Mr Minns, I'll take it on notice. I'll probably take that one on notice. Sorry.
Yeah, that's okay. In regards to the midwifery group practice programs, are you able to give me any information about how many more have been established in New South Wales or expanded on in the last 12 months?
Yeah, I have, because I was looking at this specifically the other day, and it comes up at times when people like Roy Butler and Gurmesh and others in regional and rural areas raise the availability of this. We've opened and expanded midwifery group practice this year in Glen Innes, Port Macquarie, Goulburn, Shoalhaven, in my own local hospital, one of my own local hospitals at Wollongong, and we also opened home birthing on the Central Coast. That was from memory back in 2023, so that wasn't 2024. And you would also be aware that we're investing just under $50 million into the Aboriginal-owned and midwifery-led freestanding birth site and the hub down in Nowra.
Thank you. And just on that funding, in regards to the government incentives, fundings and other support encouraging the upscale of complete continuity of midwifery care models, has there been an increase of women actually accessing continuity of midwifery care, or a decrease, or has it stayed the same since the inquiry report in August last year?
I'd say, I'm happy to double check this, I'd say there'd be an increase just because of the expansion of services that we have, i.e., I'll take it back, there's more MGP now than what there was when you advocated for the inquiry. That doesn't mean there doesn't need to be more MGP, but I think those sites would be seeing more women going through that MGP model of care. The feedback that I get from both midwives and from mums and families is that that's a very valuable program to them. It's not simple to staff, as you know and would have heard in the inquiry, Ms. Hurst, because it's fairly demanding on the midwife involved. So they've got to have space and time in their careers to be able to do it. But from my perspective, this is a very good program, and we're doing our best to lean as far into it as we can. But more work to do.
Yeah, and could I just get on notice maybe some of the more specific data points? I understand that's probably not sort of front of mind.
No.
But if I could get that on notice, that would be really helpful as well. But I appreciate your answer.
No, that's all right.
Can I also get a bit more information about an implementation timeline or any specific funding allocations for the accelerated implementation of the 5 key initiatives from the inquiry into birth trauma?
Yes, you can. I had some information here around the birth trauma inquiry because I wanted to have a look at this in relation to some of the information that regional and rural MPs was talking to me about, particularly about MGP. I can give you a progress update on the 5 that we accelerated, and I'll be as quickly as possible. We've increased access to the maternity continuity of care models, and I've gone through those areas in my previous answer, so I won't go through those. We've also, something that you raised with me personally at the time, was we've embedded trauma-informed maternity care, and we've got a draft of a trauma-informed care quick guide for maternity staff to accelerate the adoption of trauma-informed care, and we finalised the integrated trauma-informed care framework and begun the implementation of that consultation progress. The third one, this certainly came out in your inquiry, improve the way information is provided to women. So piloting an induction of labour decision-making tool in 3 local LHDs that has been co-designed with maternity consumers, which will conclude in 2025. We've improved consent processes in maternity care, something that was also raised in the evidence from the birth trauma inquiry. We've got drafted guidelines for obtaining valid consent during maternity interventions to support women and clinicians, and we've carried out consultation with peak bodies, consumers and clinicians around those particular processes. And lastly, in relation to supporting women who are experiencing pregnancy complications, and that includes pregnancy and infant loss, we've completed the perinatal loss guideline, which will provide specific advice for clinicians on how to provide respectful care, including bereavement support to women who experience pregnancy or newborn loss. And I know that was an issue that a number of constituents from Better Births Illawarra raised with me personally as well.
Thank you. I'll throw one more quick question in.
Yes.
One of the inquiry recommendations included training for maternity care professionals on trauma-informed care and informed consent training.
Yeah.
I know that the department's had a proposal from Western Sydney University
Yeah.
who was told that they'd have to wait for a tender.
Okay.
I'm just wondering if you can inform us of any tendering processes, when that might actually be undertaken, any funding available, so when that process will actually begin.
I might take that on notice first, if that's okay,
Yep,
just
that's-
because of the specific nature. If I can get it back before the end of today, I will.
That'd be great.
That's
Thank
all right.
you. Thank you. Thanks, Minister.
Thank you. I'll go to Ms Abigail Boyd.
Thank you, Chair. Good morning, Minister.
Good morning. Good morning, Ms Boyd.
Are you aware of calls for a statewide disability health strategy similar to the one that was developed for the LGBTIQ plus community?
Yeah, I am aware. I initiated a meeting this week with disability groups specifically to discuss this. We had a number of both Peak Health Consumers New South Wales as well as a number of key Peak stakeholders from the disability sector, including from stroke, including from physical disability, intellectual disability, and they raised with me the need to, they raised the fact that from their perspective they felt the work that we did in the LGBTIQA+ strategy was one that we should be looking at from a disability area.
Yeah.
I quite, to be honest, agreed with them on this. We are in the process of finalising some more practical, I suppose, initiatives that we're delivering in this area. My perspective is I think we can do what you're suggesting, which is use that as a basis for the policy on the way in which we treat people with physical or cognitive disabilities, and that is a piece of work that I'm willing to undertake and focus on.
Thank you. That's good to know. Currently on the New South Wales Health's webpage, it does have a reference to a disability strategy, but it just takes you to the Commonwealth one that doesn't have any sort of actions or targeted plans at a state level. But in the New South Wales section of that, it makes reference to legislative changes made to the New South Wales Disability Inclusion Act and the outdated DIAP. I would say, though, that the New South Wales Health Policy Directive that you updated in September 24 has been really well received, responding to the healthcare needs of people with disability.
Yes.
Are you concerned that, I guess, that New South Wales is lacking this coordinated strategy, and it's because of this that we're now seeing these reports in the media about people with disability sort of not getting the support they need in hospitals?
I think the area of disability healthcare is one that every government and every minister should personally take on and look to improve, because the feedback that I've had from the sector in multiple forums where I've been at is that a poor diagnosis or a diagnosis anchored in incorrect feedback and information can, for people with a disability, spiral into perverse and suboptimal health outcomes. They also raised with me the other day, and I had members of the Health Ministry there as well who've been working with the group on it. They raised with me the importance of training of staff, particularly in this space, and that they feel at times the carer or the family member who is perhaps supporting the person with a disability is sometimes ignored in a way that they don't feel would be the case for an able-bodied person. And I think that is perhaps as a result of training, not anything that I think healthcare workers are deliberately trying to make it difficult. I'm not saying that at all.
No.
I'm just saying sometimes people with a disability present with symptoms that are consistent with other illnesses or disease or injuries, that we can at times, because the volume is low, pick them up and assume that they are experiencing something which in fact they're not. They're just experiencing a part of who they are, which is their disability, and we're probably not engaging with them right. And I reckon from what I've read and the chats that I've had with people in the sector, that we do as a system need to continue to look at ways in which we get that better. And I'm not saying training's the only one, but I think the training piece is important because it can result in a diagnosis rooted in something that perhaps is not the case, and that can lead to poor health outcomes. Sorry, that was long, but that's...
No, and I yeah, it's promising. What you're saying is really promising.
Yeah,
I think in the context of, incredibly sort of overworked, under-resourced health workforce, to be talking only about training is not going to sort of quite get us there, and I think you acknowledge that. We need some sort of targeted resources put in as well into this issue.
I do, and I think in relation to the LGBTIQA+ community, governments, not just the government I'm part of, but former governments have lent right into this. They've used the stakeholders, people like ACON and others, to really inform the strategy. So they haven't informed it in isolation to the stakeholders. What we just need to do, and what the stakeholders talked to me about this week in relation to disability healthcare, is we need to make sure that we do engage widely and broadly with the sector, not just a couple of peaks, and that is a mistake that people like me and big agencies can sometimes make. And part of the reason why I wanted to have a face-to-face discussion with them this week is to try and get a sense from them what we were doing well and what we could be doing better. They felt what we could be doing better is a broader strategy that you talked about, and that be anchored into similar what we do with the LGBTIQ+ community.
And can I check, the organisations you've met with, did it include physical disability or New South Wales?
It did. It included the physical disability group.
Great, thank you. Just in the time I've got left, one of the other emerging issues that we hear a lot about in my office in the domestic and family violence portfolio is in relation to support for, greater protocols, training, and support for frontline domestic family violence services to be able to identify traumatic brain injuries in victims of domestic and family violence. And I know there's been some pretty promising roundtables and people sort of trying to push for a pilot program around the Hunter. Are you aware of this issue? Is this something that
I am.
you're already looking into?
I have a fair bit to do with the women's health services across New South Wales. I sort of took a pretty big election commitment about their services. They have talked to me about some of the early research that is showing the traumatic brain injury often as a result of a choking that is happening. I'm going to stand corrected around the Hunter one. I don't want to give you a bum steer, but I do think it is an important area that clinicians and frontline emergency department staff are going to have to become more informed about because of the prevalence of this behaviour in relationships. And when I've spoken to some of the peaks and the specific women's groups, there was one, the Women's Health Services, one where I went to at Blue Mountains, they talked to me about this becoming an issue that they were seeing predominantly more in younger cohorts of women, and they were asking me around how do we ensure our clinicians are looking for this and treating this, and it's probably through better research and practice. But so I'll just stand corrected on the Hunter one. I think I know it, but I don't want to give the
are you able to come back on notice? Just
with
a little bit more information on what you're doing on that. That'd be great.
I'm happy to.
Thank you.
We'll go back to the opposition, Mrs. Wong.
Thank you, Chair. Thank you. Can I just come back to the school under the Rous Hill issues? Have you had a chance to get that answer?
Yeah, I have. So I think probably I should have clarified that it's a compulsory acquisition process. So I think that's
it's under the Just Terms
important
Act?
context under the Just Terms Act.
So I thought you'd said that. Sorry to interrupt you, just to be clear on that. I thought you had said that Health owns it. That's
Health does own that
So
site.
you're
the
compulsorily acquiring
the
from-
land ownership has been transferred. The Valuer General has determined an amount.
What's that amount?
Which I am allowed to tell you, which is 42.763 million. HAC has paid a proportion of that, but the amount has not been accepted by GPT. Therefore, GPT have
From
challenged
whom it is being compulsorily acquired.
Correct. And it's been challenged and it's going through that court process that I referenced previously. The next hearing is in August of this
Thank
year.
you.
In parallel, because HAC owns the site, we can progress with the project, so there is no delay.
Thank you. In 2018-19, $75 million was allocated for the land. How much is allocated now?
I think within the budget that would be a confidential number. Obviously,
why?
I think just from a sensitivity perspective around commercially the agreement that we need to take through the court process. So I can confirm that we've got an allocation remaining within the budget that exceeds the number there with some risk within it. But I think that number is probably better not to be publicly available.
All right, might ask you to take that on notice and check that, because
No
it would have
problem.
to be an allocation in the budget.
There is an allocation in the budget.
And you're saying that you can't tell this committee what that allocation
number.
is?
Yeah, I just want to retain that commercial principle. Obviously, it's going through
For a
that
budget
process
line
with
item.
GPT at the moment in the court. So I'll come back to you. I'll take it on notice.
If you don't mind coming on today all right, so then I would have thought, it's all right, I'll move on. Minister, meningococcal, Stacey Chater's 23-year-old son Braden died tragically from meningococcal B in 2022. When you met with Stacey and Meningitis Australia in November 2023, do you promise Stacey that you would write to the Federal Minister for Health requesting a 50-50 funding split between New South Wales and the federal government for that vaccine?
I know Stacey very well. I grew up.
Sure.
I grew up opposite her
just
at
the letter.
Dapta, and it's a tragic set of circumstances. I wrote to Minister Butler twice about this issue. I'll stand corrected around the specifics that you said in there around the 50-50. I don't recall that part of it, but I certainly made it clear to them that I will and have and continue to advocate. I'll do that after
Can I just be clear,
the federal
though?
election to the Federal Health Minister.
And appreciate you've confirmed you've written and you've done that twice. I appreciate that.
Yeah.
Can I confirm, though, or could you come back, or could your office come back in the next little while on whether those two letters contain the representation that you were seeking a 50-50 funding split?
Yeah, I'm happy to correct. I'm happy to provide that. I don't.
You don't know, or
on the record now, I don't believe those pieces of correspondence would have went to the funding split, but I am happy.
So what were you asking for then if you're writing to them?
I'm asking the Commonwealth to do what the Commonwealth's responsible for, to be brutally honest, and that is run a national immunisation program, and they are the people responsible to deliver that. That's the expectation that I have. I went into bat twice through written correspondence. I went into bat in separate health ministers' meetings about this issue.
Okay, but when you did that, we just want to clarify what the ask was. Was it 50-50 or not, or you're not sure, you can't remember, or you need to clarify?
Well, at this stage, I don't think it was 50-50, but I want to make sure the committee has accurate answers from me and the officials, so I just want to put that, I'll double check that and I'll come back to the committee about what I specifically said.
Thank you for that. We
I think I would have
appreciate
said
it.
to them, fund it, but anyway.
Stacey and the CEO of Meningitis Australia, Karen Quick, say that you're explicit in your promise about 50-50 funding. Are they wrong, or have you broken your promise to Stacey?
No, I don't recall me saying a 50-50, because the reason why I'm unsure why that would have happened is because that would require me to go through the budget and ERC process, and I wouldn't have had that ability at the time to have done that. So I don't recall that. I'm not going to stand what people said or didn't say. Yeah.
All right, a statement from the Department of Health and Aged Care. Actually, I might move on from that, sorry. I might go back
That's right.
Yep, we'll clarify that once you have
Yep.
an answer.
Yep.
We'll go back to the slides.
Minister, since January this year, how much money has New South Wales Health spent accommodating public mental health patients in private hospitals?
I'd have to take that specific one, Ms Carter, on notice. We have a situation now where we are, through Susan and the system, engaging with private hospitals. I will stand corrected on this, but I think recently we've engaged Ramsay in some bed availability in spaces to try and take some pressure off what the current situation is that has been well ventilated. But I don't know the specific number.
Well, if you could take it on notice, and also the length of any contracts that you've entered into, and perhaps the daily bed rate that you're paying for, and the number of patients that are being transferred, all of those things on notice would be great.
Yeah, okay.
Another question in relation to accommodating public patients in private hospitals. Were any public hospital nurses provided either to transfer or to assist in the care of those patients in private hospitals?
Geez, I'd have to. I would
on
say
notice would be great.
I would
Thank
say
you.
no, right? I would say no. That would be a bit of an unusual one, but Mr. Minns, no, I don't believe so.
Happy for you to
but
take on notice, Minister.
Yeah,
Thank you. I'd rather get the right answer.
No, 100%.
And understand these are technical.
Every right to.
In terms of accommodation of psychiatric patients within the public system,
yes.
How many psychiatric patients are in general beds, for want of a better term, rather than dedicated mental health beds since the 21st of January?
Okay. Probably more one from the Minister for Mental Health, but I'll take it on notice to give you an accurate answer.
Yeah, no, thank you very much. Thank you.
Yes,
There,
Ms. Piz.
Look, I think in the ordinary course of things, people who have mental illness and other diseases will be accommodated in wards throughout our hospitals. I think we don't discriminate in respect to people's mental health. Obviously, if
Ms. Pearce, I'm not asking about patients with comorbidities. I'm asking about patients who are specifically admitted for a mental health issue. But happy to take it on notice and pick it up this afternoon. Minister, since the 21st of January, when psychiatrists began resigning, how much money in dollar terms has the government had to spend on VMO and locum roles to cover resigning psychiatrists?
I had a look at.
If you need to take that on notice, I would like these specific numbers. So
Yeah,
that would be.
Yeah, sure. I think Ms. Conn asked something similar earlier today, so I'm happy to take it on notice.
Thank you. Thank you very
much. If I
much.
can get it to you beforehand, though, I will. Because
I'd be grateful. Thank you. You'd be aware that the Premier said yesterday that paying VMOs, which is sort of, if we assume 8-hour day, 48-hour week, and we assume the average starting wage for a staff psychiatrist is roughly twice what a staff psychiatrist gets paid, and locums, although I was surprised by the $8,000 a day figure Ms. Pearce was mentioning as the ask earlier.
We have not paid that, to be clear.
No, but it was the standard is closer to $3,000 a day, as far as I'm aware, significantly more than the staff psychiatrist wage. These were characterised as short-term emergency measures, and as the explanation why the government can afford to pay these as compared to the 25% uplift sought by the staff psychiatrists. I think the figures indicated this morning something like 72 staff specialist psychiatrists have already transferred to VMO roles.
That's correct.
So
yeah, temporarily, yep.
Well, I guess the question is, why are you so sure it's temporary? Like once you've transferred to be a VMO, why are you coming back to be a staff specialist at half the pay.
I'll let Mr Minns add, but I just want to say that on average, though, it's important context for the committee to understand VMOs cost less than the
Locums.
25% pay increase that the psychiatrists are asking for.
Well,
So
actually, Minister, I'd be really interested to see your figures. Perhaps you could produce the figures based on a 25% pay increase and on what you're actually paying to VMOs and on what you're actually paying to locums, so we can really pull those figures apart, because I'm not sure that your figures are correct on that. I look forward to getting all of that on notice.
Well, we're paying more than what you ever paid under a wages cap. That's what I can say.
Minister, we're looking for care for psychiatric patients and
Mr.
respect
Minns.
for staff psychiatrists.
So the 72 that have chosen to transfer, that's been the result of a local dialogue where they...
Sorry, it's a bit hard to hear you, Mr Minns.
It's been the result of a local dialogue at each LHD or network. And the fact that people have sought leave without pay for that arrangement is a result of their request. So, you know, at some point in mid-January, the question was raised: would people be able to access leave without pay? Our view was that in the circumstance where they would choose to take up a VMO contract for, and 6 months sort of became the typical period, that we would agree to that. And the only comment I can make with respect to why people might be doing that is that they're prepared to await the outcome of the IRC process. Hearings will commence on the 17th of March. There's possibly reserved dates in the weeks following that, and then it'll be up to the IRC as to when they resolve that matter.
Mr Minns, on notice, could you provide the number of staff who currently have a VMO contract and a staff specialist contract at the same time? Because, and in the figures, Minister, that you're going to provide on notice, perhaps there could be a calculation if all of those staff specialists come back half VMO, half staff specialist, what that cost to the health would be, because that is also a possibility that they may come back in a hybrid role, isn't it, Mr Minns?
We typically don't support people working as both a VMO and a staff specialist in the same facility because of the potential for conflict.
Be interested to get those figures across the whole of the LHD.
I won't be able to give you figures because VMOs are not paid through a payroll system, they're paid through V-money, and so what we pay a particular VMO is what they claim from us, and we agree to pay.
Thank you.
So it's going to be quite hard to give you, current status.
Okay, thank you. Minister, is the mental health funding to LHDs quarantined for use within mental health, or is it a general allocation to the LHD from which mental health is funded?
There are, when you do the budget through health, there is obviously funding in there that goes to the provision of mental health services, but the Secretary touched on this beforehand. Often they are not in isolation. You'd be aware that there's allocations for specific mental health funding, yes, but people present in our hospitals with a mental health issue, but their primary admission at that point may be for a physical injury. I'm just making it up. So the 2.9, I think it's around 2.9 billion that we put into for mental health services. There are specific ones for program allocations and activities, 100%, but the funding is also used across the health system, because I might present with a physical injury or disease or illness, but I may also have a mental health diagnosis. So that person's still funded. The bucket, though, is the broad health bucket, but there are specific programs and staff allocation in the 2.9 for mental health that we do.
So if I can summarise, some money is quarantine, but other money is general purpose.
Yeah,
may cover both.
The 2.9 is quarantined for mental health services, and Alpha and others can just back me up here. It's Minister Jackson's portfolio, but I know it well enough in this space. So 2.9 roughly for mental health services. That covers some specific mental health programs, staff and initiatives that collectively we have in our either duty electorates or our electorates per se. Then there is the overall macro health budget that mental health people still access because they often come into the service with not the mental health condition as the primary reason for that admission. That's
Understood.
I mean, I'm
Thank
not
you.
trying to make it...
No,
Yeah, that's
understood,
all.
Minister. Thank you. Psychiatrist Dr. Cameron Ahmed said in The Guardian that it was unacceptable that patients are waiting days in emergency departments with psychiatric issues. Do you agree with Dr. Ahmed?
Yeah, that is too long to be waiting. Every time someone has not a great experience in our hospitals, I take it pretty seriously. I want them to have good quality healthcare that's accessible and in a timely manner. Most of the time we do that very, very well because of the incredible work of our staff, supported by the ministry, across the LHDs and the pillars, but at times that doesn't happen. And
thank you, Minister.
Been brought up in a way to admit that at times that doesn't happen, and you've got to be upfront about that. And clearly, I don't know the ins and outs of that case, but clearly on the surface, that's not a optimal outcome for that particular individual.
Thank you, Minister. I might just jump in at that point. Just on funding agreements, the Prime Minister and Federal Health Minister really haven't been very good partners on health, have they?
Look, there's always argy-bargy. Minister Hazard, I remember, has talked to me about some of the challenges.
Current federal colleagues, the current funding arrangements and the current budget estimates that this hearing is considering.
Well, I think compared to the federal opposition leader, they've been good.
No, that's not what we're talking about. The current funding arrangements, let's get specific then. Isn't it the case that the failure to get a 5-year hospital funding agreement for New South Wales is down to the Prime Minister grinding these negotiations to a halt last year?
No, it's I think states like the one I represent weren't prepared to sign up to something that was long in nature, that wasn't going to deliver the benefits, and it probably would have been easy for me to sign off as a Labor Health Minister with a Labor federal government, but first and foremost I've got a responsibility to the people of New South Wales, and I take that responsibility serious regardless of who's in power in Canberra. And I didn't think that the proposed agreement where we were was going to be good enough for 5 years. We did settle for one. That's about 407 in terms of total amount, but we didn't get to a 5-year agreement. Would I have liked to? Absolutely. Was I prepared just to sign off on anything? No, I wasn't.
Okay. I've got 2 minutes. So you wrote to the Prime Minister along with other health ministers last year saying what was happening in our hospital system was a national crisis. How is that crisis going to be resolved when New South Wales doesn't have funding certainty from the feds after 2026?
Well, I would have liked to have a 5-year agreement. I'm pleased that the federal government...
You said that, but I'm just asking how it would be resolved.
Well, it hasn't been resolved yet. I suppose from my perspective, I'm not going to be someone who signs off on a long-term agreement if I don't think it helps the people of New South Wales, given the pressures on my emergency departments at the moment. We signed an interim agreement, the 1 year, 407, but that's not a 5-year agreement. Would I have liked to? Yes, but was I prepared to sign off on something
you've said that
was not going to do it? No.
So when you last discussed the National Health Reform Agreement with your federal counterpart, were foundational supports still being linked to additional NHRA funding?
Yeah, it's a very good question, a very informed question. The foundational support issue is what I would call a live issue for discussion at the moment. We are working through what the removal of the feds around that foundational support and the subsequent take-up from the state looks like.
Right.
There are 2 portfolios that probably have the biggest impact and are at risk of this, and that is mine as the Health Minister, but also as the Education portfolio also has a challenge. We haven't got an agreement yet around the nature of that, but we are working with Commonwealth agencies around what that looks like. That's probably the best. Minister Washington obviously leads on it, so I don't want to I don't want to take any of her thunder,
Sure.
but we've met and had discussions about it.
All right, and another question quite separate to that. Minister, in your local area, when will women be able to give birth at Milton-Ulladulla Hospital as promised by the member Liza Butler before the last election?
Yeah.
She said babies will be born at Milton-Ulladulla Hospital.
Yeah, I'll take that one on notice because I want to be specific around it. I'm aware.
Could you be specific on when?
Yeah, I'm aware of that issue. I'm also aware that I've got some staffing challenges in the Illawarra Shoalhaven local health district, and maternity are acute shortages in that space. So I've got to make sure that I can provide that in a way that's safe. The local member has been a strong advocate around that.
No, she promised it. That would be born.
I'll continue to work on delivering that. It is not the case yet. We're doing the health service planning for that is underway, but I haven't got a time right now, right here, when I can say that'll be operational. We've introduced midwifery group practice back in 2024, last year, but in relation to that specific site, I'll need to seek some further advice around where that hospital planning is up to.
When will babies be born?
Yeah.
Thank you, Minister. The government has recently announced an end to gambling advertising on transport assets, which is a very welcome announcement. Are you considering extending similar restrictions to other harmful products that are advertised, such as highly processed food or alcohol?
Not at this stage. I don't have any plans for that. No.
In October 2023, you stated that you were looking at a UK ban on junk food advertising with interest.
Yeah.
What's been the result of that?
I had a look at it. I'm not convinced that the way in which people consume their information now, that is necessary. Young people, and being the parent of two of them, seem to consume a lot of their information not through billboards and advertising on government locations, but through their devices, particularly their phones. And I think that is a challenging area of public policy that we are going to have to work through and deal with. I think there is probably an area where we can make improvements, but I'm not in a position at this stage to say that government has made any decisions on that, because we haven't.
The government's obviously taken the view that it would make a difference and benefit people's well-being to ban gambling advertising on transport assets, and particularly noting these are areas with really high exposure to children who have now been banned from social media by the federal government. Why is this of benefit for gambling, and you don't view it of benefit for other harmful products?
From my perspective, I think there's a bit of mixed evidence when I had a look at this in the UK. But, you know, my background is in health education, health promotion. It's an area I'm interested in, but I've got to make sure that I'm pulling the right levers here as well. One of the things that I want to try and make sure we're doing more is, as we build and develop estates and land releases, that we include the adequate green space, adequate cycle paths, access to the provision of fresh fruit and vegetables. I think government of all political persuasions over the last 30 or 40 years could have done that better. That's all governments, not making a political comment. And I think that has got to be a focus where health can play a role in the development of new estates and new housing releases, to make sure that the ability for people to actively move and recreate and access green space for physical activity, and at the same time have access to fresh fruit and vegetables and not saturate a particular area with fast food options, is an area where I think health can play a responsibility as a part of a focus. But yeah.
Moving to a different issue, last year you advised the member for Balmain that New South Wales Health is continuing to work with other government agencies to assess future use options for the Kirkside precinct in Callan Park, the Kirkbride precinct in Callan Park.
Yeah.
Has that work progressed? Is there any plan or update for the use of that site?
I'd probably seek some advice if anyone Emma, did you?
I think that is in my portfolio, but I just need to check in relation to the progress. I do know that there's ongoing discussions.
Thank you. And I understand there's significant community angst that site is still sitting idle and has been for some time.
I'll try and get some advice either today or ASAP.
Thank you very much. Minister, coming back to Albury Hospital, as I always do, are you aware that an open letter has now gone to both the Premier of New South Wales and the Premier of Victoria, signed by over 200 clinicians, calling for a halt to the current redevelopment?
Yeah, I am. I've actually, in a recent piece of correspondence, I've written to the local councils and offered to meet with them because they wrote to me specifically around that issue that I know you've advocated for, and I'm of the understanding we're in the process of setting up that meeting to have that discussion.
Thank you, Minister.
That's right.
In the context of this redevelopment that I understand is a particular challenge because of the involvement of both New South Wales and Victoria, have you made any representative to your federal counterparts to play a bigger role in this?
I can't say. I probably want to double check that. It's certainly an issue that I've raised frequently with the Victorian Health Minister around this. I think I might have actually raised the idea of a contribution from the federal government in a joint piece of correspondence with my counterpart in Victoria, but I would just want to double check that was that piece of correspondence and it was not another one. So let me get you a copy of that or take that on notice if that's all right, just the specifics of it.
Thank you, Minister. And coming back to the LGBTQIA plus health strategy, which I understand there have been some questions about that already this morning, there was some initial seed funding as part of that strategy, which has funded some really excellent programs. Is it your intention to provide additional funding for that strategy moving forward, noting it's got a number of years still to run until 2027?
Yeah, we know this area of healthcare is important. So yes, it will be something that I continue to invest in. That sector has made a huge difference for the community that they represent. I think the level of healthcare that the community gets now is perhaps vastly different to what it got access to some decades ago. I think that's something that we as legislators should be pretty proud of. New South Wales Health should be very proud of, but most importantly, the sector should be, because they continue to advocate through their peaks, and we as an agency, I think, have done very well in listening, learning and delivering in an area that's particularly important. And healthcare in that community, like all communities, is important, but they for a long period of time felt they weren't getting comparable healthcare, and I'm glad that our government, previous governments, have made significant inroads into that. Still more work to do. That's by no means job done in that space, but I think we can be proud as a society in the way in which New South Wales Health has improved the delivery of healthcare for the LGBTIQ plus community.
Thank you, Minister, and I agree it's an excellent strategy, and I appreciate the funding that has already been put to it. There's a specific reference in the strategy to people living in regional areas as an identified priority group, and noting things like the Kaleido Clinic, which I've received a briefing about, and I'm really genuinely excited about. Are you looking at particular programs to address that priority group of LGBTQI plus people in the regions? Yeah,
we would be. I'm happy to take some specifics on notice, but this is part of health delivery where the challenges are very clearly exacerbated the further you get from Sydney. That's the truth. And the availability and attitudes within a particular community may not always be the same as other communities, and that becomes challenging for people trying to access healthcare services out there. I've got to make sure that remains a focus of this government, and that the services are not just delivered in the highly populated areas of the state, and whilst of course those areas are important as well, I've also got to make sure that we provide those healthcare services to regional and rural areas. The funding that you would be aware of, Ms. Conn, around the gender centre in the last budget had a particular focus on improving access of healthcare to people living in rural and regional areas. We should and probably can do more, so I'm more than happy to provide some information, but I want you to know that that has been a particular focus.
Thank you. That's very welcome. I will turn to Ms. Fairman.
Great, thank you. Dr. Chand, just wanted to turn to the ANU's PFAS health study. It found sufficient evidence that higher levels of PFOS or PFOA in a person's blood are associated with higher blood cholesterol levels, didn't it?
I would have to, sorry Ms. Furman, just because I think this is a really important area, I'd prefer to actually see the document. I am aware that PFAS has been linked to associated with increase in cholesterol. I'm just not sure the actual exact mechanisms of achieving that. That's why I'm getting expert advice. So I just want to make sure I'm very clear what we know in what I know in this space.
The study did find that. It's got that written in the study. I've got it here, and also in a correspondence internally, but it's public. It's in the study. So,
Ms. Berman, the reason I'm hesitating just to explain is there's a lot of things where there's the association. It's this issue of causality and whether things are being controlled. So I just need that's why I'm just careful with my language.
I think
I'm
most
not trying
of
to.
the causality thing is a little bit like a red herring, don't you think? Because IARC, it's not the causality. There's sufficient evidence, insufficient evidence, but sufficient evidence. It's not causality. IARC isn't suggesting causality.
Well,
but I'll come back to you this afternoon because I've got some questions for the Minister.
Apologies.
Sorry. We can get into the weeds a little bit this afternoon on this. But Minister, so for years, Sydney Water and New South Wales Health assured people that their drinking water was safe, yet the water was actually never tested for PFAS. And it wasn't until an independent scientist, because of an investigation by the Sydney Morning Herald, tested the water and found that the level of PFAS in the water was 16 parts per trillion compared to what is the safe drinking water guidelines of 4 parts per trillion. That was the drinking water provided to 30,000 residents in the Blue Mountains, right? So given what the government had assured the community, despite the fact it never did any testing, isn't the least the government can do now is to offer the community blood tests if they want it and other health advice?
Well, as I said earlier, the challenge for me is that most Australians are expected to have detectable levels of PFAS in their blood due to the widespread use of these chemicals. I know there's been some increases in that area, but my advice is that there's insufficient scientific evidence yet for medical practitioners to be able to essentially tell a person whether their blood level of PFAS will make them sick now or later in life. Our water meets the Australian drinking water guidelines, is safe to drink. I certainly drink a lot of it. The area supplied by Sydney Water in the upper Blue Mountains, processed through the filtration plant, the Cascade Water Filtration Plant, exceeded the proposed new PFAS guideline values, although it
For how long, Minister? Do you know?
Well, but it was well below the current drinking water guidelines. So it exceeded the PFAS guideline values, but it was well below the current drinking water guidelines, and that's where we're at in terms of the blood testing. Dr. Chan has
Minister, just to be clear, the people who are getting their blood tested, have levels higher than the current PFAS impacted communities we know about as a result of historical contamination. This is Williamtown here in New South Wales. and others, right? So when you look at the results coming through, which are higher, surely you as Minister can see what this is saying in that these communities have been exposed, right? We don't know for how long. PFAS was banned in 2007, right?
Yeah.
So for how long? Since at least 2007, and we know the levels go down. Just one thing, right? There's a link between just high cholesterol. Let's not take all the cancers into it. Just high cholesterol. There is a link. Let's get rid of the word cause. There is a link. So if there's a link between high cholesterol and high levels of PFAS, and the government didn't test and assured everybody the drinking water was safe, isn't the least you should do now is test and then advise people what to do to lower their cholesterol levels?
Well, I do want to make it clear that Sydney water, the drinking water, what we're drinking is safe.
No, this is historically.
Yeah, okay. Well,
I'm
I just
not
want to
talking
make
about
that clear, because I just don't want people to think.
Yes, but
they have been
drinking. Yes, but they were assured, the 30,000 people, weren't they? They were assured their drinking water was safe, and in fact, there were high levels of a particular PFAS chemical in their water.
Yeah, I know what you're indicating at. I suppose what I'm trying to say is, I'm not sitting still. The government's not sitting still. We've got the Chief Health Officer, Dr. Chant, to establish an expert panel.
But what's it doing for this community that has high levels of PFAS in their blood now? Are you going to offer them any assistance?
Well, I'll take that advice in terms of, if Dr. Chant was to come to me and say, the medical evidence indicates that we should be doing this now, then obviously I would take that on and talk to government about that. But at the moment, that's not the advice that I've got. So but Dr. Chan is not sitting still. I'm not sitting still. She's establishing this expert group.
I do want to table for you, Minister, which I've got some copies of here, which is the US government's guidance for PFAS exposure testing and clinical follow-up. There's some copies just for one moment. What this is in 2022. It's published. It's the official government documentation. It's provided by the Agency for Toxic Substances and Disease Registry.
Yep.
And it says recommendation 5 for clinicians should offer PFAS testing for patients likely to have a history of elevated exposure. So you would think that this Blue Mountains community has a history. This is on page 6 of 20, Dr. Chant, but I'm sure this is a familiar document. So, and that there is an increased risk of adverse effects above 20 nanograms per millilitre. The woman that I mentioned at the start, Catherine, has PFAS blood levels above 20 nanograms per millilitre. In fact, this graph, this chart, says that above 20 nanograms per millilitre, clinicians should conduct thyroid function testing, assess for signs and symptoms of kidney cancer for patients over age 45, and for patients over age 15, assess for signs and symptoms of testicular cancer and other diseases. Why is New South Wales Health 10 or 20 years behind on the science when this is what's happening in the US?
Ms. Furman, I just think it's really important to establish that we are not out of line with the national approach that's been considered.
The national approach has got its head in the sand.
But, Ms. Furman, I will look at this document. It really isn't appropriate for me to read it in depth in this committee. I have gone to the page that you've asked. The issue that we really need to establish is what we advise, and as I've reflected, we're having an expert panel to look at it. I've also given undertakings that community members have written, and all of this information will be put to the expert panel.
But they're not getting any assistance.
But the issue that comes to it is when a clinician is given a result, we need to actually spend some time interpreting that and saying to the patient what this means.
How can they reduce their PFAS levels?
Well, that's an interesting
There are
question.
ways to do it. So what are they being advised?
I do understand that, but there's also...
But they don't.
No, there is not an established scientific agreed method at the moment to deal with PFAS levels. There are a range of issues that we would suggest that people are screened for anyway. We are establishing an expert panel with relevant cardiologists, cancer specialists, neurologists to actually go through all of the available evidence and to say what would we actually guide, because we have to go to the next step of what it means for patients, what we're recommending. I would suggest that everyone there are recommendations for screening for cholesterol at various points, and it needs to be matched with overall health. So please, I want you to take from this that we're taking this seriously. This is a study. I'm not sure. We will put it to the committee. There are a lot of documents in different perspectives.
The people who are coming back with their blood tests again, I think there's about 4 or 5 now that I've seen, are coming back, are higher, the PFAS levels, just once again, are higher than the Williamtown study.
So we have asked that there's a couple of pieces of work that's happening nationally. There's also a national blood sampling regime that's a random
nothing
sample.
for Blue Mountains residents.
That will give us a benchmark of where we sit in terms of overall population level PFAS exposure. We have undertaken, a number of the members of the community have written to me, and I've undertaken to put their particular circumstances to the expert panel. I will put this document to the expert panel as well. But as I said, we need to make sure we do this thoroughly so that we're supporting clinicians' understanding, as well as the patient, as well as the community members, understand what it means for that, what we can reasonably conclude, and how it fits in with their broader healthcare needs.
Chair, I've got the call.
There's
Chair.
about a minute and a half for
Chair.
Chair.
Thank you. Minister,
No, sorry.
Minister,
Chair,
when will the Auditor General's
Natalie
report
Ward is not
on
a
Northern
substantive
Beaches
member of this
Hospital?
committee.
I must
I'd
ask
ask
Northern
you,
Beaches
Order.
Hospital.
Two members of the committee sought the call. I've given the call to Mrs. Ward.
Yeah, Chair.
Minister, when will the
Natalie
Auditor
Ward is
General's
not a
report
substantive
on the
member.
Northern
Natalie
Beaches
Ward is not a
Hospital be
substantive
made
member of
public?
this committee. She should not be receiving
Fang,
the
I'm
call.
asking about Northern
She is
Beaches
not a
Hospital.
substantive
Please be
member of this
quiet so we
committee.
can ask the
No,
question of
Natalie,
the
you
Minister.
had the
Minister,
last
when will the
rotation.
Auditor's
Natalie, you had the
report
last
be
rotation.
available?
You've had 60.
I called up Honourable Wes Fang to order for the first time.
I don't
speaking
understand,
over
Chair. I'm the substantive member
Minister,
of this committee.
when will the
Natalie
Auditor
is
General's report on the Northern
substitution
Beaches
member. I
Hospital
don't
be made
understand
available?
how you've not given the
for
call.
the Auditor General, but I don't believe it's been received yet. Obviously, that's a matter for the Auditor General to do.
So
Minister,
when
can I
will
ask
that,
you,
when will that
Minister,
be released?
I sort of matter for the Auditor General. I'm not.
All right, could you take it on notice and see if you can find out? Thank you.
Minister,
and can you confirm
commit,
just...
Minister, I'm going to
I
ask the question
call
now.
the Honourable Wes Fang to order for the second time.
can you
Chair,
or Ms. Schoolander please...
How have you given the call to
whether
a
the
non-substantive member of this
additional
committee?
cost for the land acquisition...
I've now got
Well,
a
Chair,
point
you
of
can call me to
from
order for a third time if you want, because this is unbelievable.
Sorry,
This is yet again the
Ms. Schoolander,
circumstance
can you confirm
where
whether the additional cost for the land
where the
acquisition
Honourable Natalie
will come out of the
Ward has
$700 million
taken the
budget
call
commitment
to
for
try
Rous
and get
Hill?
other questions
Yeah,
put-
so to
Well, take a point of order.
clarify your
Point of order, Chair.
question previously,
Point of
I
order.
think I
He's now used the words point of order.
reflected
Point of
that
order.
the budget allocation previously was separate for the land allocation to the main budget. It was subsequently combined into the $300 million number, so we're managing a total budget.
Chair,
So we
point of order.
ordinarily wouldn't break that down into the line items of the budget.
But the total budget item is still the 700?
Yeah, which
700
includes
million for Rous
700,
Hill.
which includes the land acquisition,
Including the land.
Within that, there is the allocation that we've spoken about for land. There's also contingency held, so confirming that what we would do is work through the allocation of that budget over the next period while we look at the next steps of the project, but everything would be coming from the 700 million.
Thank you. Appreciate that answer.
With apologies to Ms. Gillenda, I need to hear the point of order.
Well, the point of order, Chair, is that a non-substantive member, even though having been elected the Deputy Chair for this hearing, is not the substantive member. I am the substantive member of this inquiry. Now, no, sorry.
You're just wrong.
Sorry.
To the point of order, Mrs.
Well,
Ward
where was the
has
substitution?
formally substituted for Mrs.
Where was
Carter.
the substitution and notification?
Check the minutes.
That was
of
done.
the meeting.
That was done
notification?
correctly and needed to be
Well-
done for Mrs. Ward to be elected Deputy Chair of the committee.
Well, Chair, that wasn't provided to me prior to Chair, it wasn't provided to me prior to this
Check the
hearing
minutes.
commencing. So I'd...
Mrs. Watt is a substantive member today as a substitute for Mrs. Cotter, and in my remaining...
No, this is all about Port Macquarie.
Order.
It's just trying to... So
Order.
Yeah, the by-election. It's all about the by-election. So.
Order.
Sorry, Rous Hill Hospital is...
Mr. Fang, I have a question on behalf of a regional community for the last minute, please.
You need an estimates committee.
In a supplementary question in September, I asked how much operational funding was provided by the New South Wales Government to Albury-Wodonga Health. The answer to that supplementary question was to please refer to the Albury-Wodonga Health annual report. However, the Albury-Wodonga Health annual report aggregates the funding provided by the New South Wales and the Victorian governments together for operational funding. So I'm going to ask that question again. How much operational funding was provided by the New South Wales Government to Albury-Wodonga Health for operational purposes over the last 5 financial years, please?
I'll take it on notice, see if we can disaggregate it. I don't want to give you incorrect information here. I don't have that breakdown available for the committee yet.
Thank you. I'm happy to have that answer on notice as long as I'm not pointed back to the annual report, please.
No, I'll take it on notice. I just want to check if we can disaggregate it. But, yeah.
Thanks very much, Minister. Do you want the last 20 seconds?
Minister, are you aware of what New South Wales Health advises, for example, workers, say firefighters, who have been exposed to PFAS firefighting foam historically? Are you aware of what the advice is for those workers? Are they able to, for example, access blood testing as a result of that historical exposure?
No, I definitely need to take that one on notice.
Dr. Chan?
I would just also have to take that on notice. Obviously, there's been a lot of focus on those occupations that are significantly exposed, so I'd have to liaise also with work cover in terms of the arrangements in
They're not
place for
provided
firefighters.
testing, Minister, just so you know.
Maybe you guys can ask the question I was going to ask about
Order.
the HSU wanting that they
It's
wanted
the
to ask.
time for
Yeah, and maybe they might want to ask the question.
No government questions, thank you.
You sure?
you.
They can talk to the minister.
There being no...
Apparently they can't.
Order.
Them all the time.
There being no government questions, we'll now break for lunch. Thank you very much, Minister, for
Thanks for having
your
me.
time.
Thanks for
You
having
won't be
me.
back with us this afternoon.
Thank you,
with
Minister.
Apologies
Thank
for
you,
some
Ms.
of the disorder this morning.
Right.
And we'll see
It's
the
always good.
remainder of the witnesses at 2 o'clock. Thank you.
Thank you.
Welcome back, everyone. Before we resume questioning, we have some additional witnesses to swear in. Mr. Horan, Mr. Lespina and Associate Professor Thomas, if you could take either the oath or the affirmation, starting on my left.
I swear that the evidence now I'm about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
You may have to bring
And
your
your name
microphones
and-
closer, please.
Yes, could you bring the microphone closer for Hansard, please, and also state your name and position title?
Sure. Sorry, can you hear me now?
Yes.
Okay, perfect. So, Gregory Horan, CEO of Healthscope. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Peter Thomas, Chief Operating Officer and Chief Medical Officer of Northern Beaches Hospital. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Tino Lespina, the incoming CEO of Healthscope. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. We'll resume this afternoon with questioning from the opposition. Mrs. Ward.
Thank you, Chair. Thank you all for coming back this afternoon. Before we begin, Chair, I'd just like to acknowledge the parents of Joe Massa here today in attendance, Eloise and Danny Massa, and acknowledge the passing of dear little Joe. Mr. Horan and Mr. Thomas, I'm not sure between you, but if you indicate who might answer these, thank you. Mr. Horan, perhaps I might start with you. The foundation of any health system is patient trust. Healthscope has lost the trust of patients, haven't you?
Thank you for the question. If you don't mind, I'm happy to answer that. If I can just say something to the Massa family.
Sure, certainly. Two quick things.
Yes.
We are very limited for time, so if I do try and interject, I'm not trying to be rude. I'm just trying to be conscious of the 19 minutes I have, and if you could just pull them over.
I'll be very
physically
quickly.
closer, that'd be
Sorry,
great.
it's still not loud enough.
Thank you.
Is that better?
Thank you.
So, I just wanted to pass on my deepest condolences to the Massa family for the loss of your baby boy Joe, and for the care that Joe did not receive at our hospital at Northern Beaches. I cannot imagine the grief that you're feeling right now. I'm also sitting here accountable for what happened at Northern Beaches and accountable for making sure the actions going forward prevent this type of incident from ever happening again. Thank you. And to your question, and our primary focus in all of our hospitals, not just Northern Beaches, is patient care. And particularly at Northern Beaches, we have been very focused on building trust within the community, and we recognise that this tragic incident has had an impact on the confidence of the Northern Beaches community. But we have amazing staff there providing care, and we are confident in the care that we are providing, and we are going to make sure that we take the lessons out of this tragic incident and ensure that it does not happen again.
All right, we might hear more about, there's a lot, that's a very general statement, I thank you for it, but I might just get to some specifics. Mr. Horan, why did Healthscope have an inferior IT system for medical records? Was this a decision by Healthscope to save money?
Look, so the decision to put in Telstra Health, which is the electronic medical record that is in place at Northern Beaches, has been at Northern Beaches and was proposed to be installed at Northern Beaches prior to its opening, and was done in conjunction with the New South Wales government at the time. I would say that I don't agree that it's inferior in all cases. All EMRs have pros and cons. In this instance, one of the causes I outlined certainly was a contributing factor in that the triaging process did not enable the heart rate of baby Joe to be charted and then alerted. That is something that we are actively working with Telstra Health on, and in the meantime we put in place a dual triaging process so that any paediatric patient will have not only one triage nurse look at them, but also the nurse unit manager, to ensure that there is no triaging error.
All right, thank you for that. On the IT system though, has that been replaced in line with the serious adverse event review recommendation?
No, the serious adverse event review recommendation was to review, and we are working with Telstra Health to resolve these issues, along with Daedalus, who is the provider of the patient administration system. We are actively working on that, and will ensure that the system will be able to provide the necessary information to our staff as part of that action.
All right. We may have some further questions on notice, supplementary questions on that. Mr. Thomas, St Vincent's Hospital ED does not treat children. Arguably, the trainee doctor was logging hours at Northern Beaches Hospital to gain training and experience with paediatrics. How many hours had he logged and how many children had he treated prior to working at Northern Beaches Hospital?
Thank you for the question. Essentially, the trainees that rotate into Northern Beaches Hospital are part of a statewide training programme, in this case under the College of Emergency Medicine. In terms of the training programme, specific numbers of cases are not logged by trainees. What happens in all of the training programmes is usually a 3-monthly review to assess competency. There are a number of different mechanisms to do that, including direct observational procedures and on-floor assessments by the supervisor of training. In terms of this trainee, they've been with Northern Beaches for 6 months. They had not at the time of arriving at Northern Beaches completed a specific ED paediatric term, which is usually done at Sydney Kids Hospital, but was at the stage of training. At the point of arriving at Northern Beaches, there were no concerns have been raised about performance, and they were at the appropriate stage of their training program.
All right. I might refer this to you, Mr. Horan, and you can refer it to others if needed, but do you think it's safe and acceptable to leave a trainee doctor in charge of paediatric ED who has very little experience with paediatrics?
So I will comment and then pass to Peter. I'm not a clinician, but what I would say is that the trainee, all trainees have appropriate supervision and have access to senior staff specialists to ensure that there is someone overseeing that trainee at all times. So I might pass to Peter.
Yeah, thank you. The training model and model of care in our public emergency departments is such that we have a supervisory. Also, we'll have an ED physician in charge, and then we'll also have ED specialists who are allocated to different areas. At Northern Beaches, that is no different. We have a specialist who covers the fast track, paediatric, short stay, and acute areas. So we have 3 specialists on the shift. The model of care is such that the trainees, the registrars will assess patients, they will escalate care as required, and the specialist will also round with patients and the doctors as part of the handover rounds. So the standard model of care will be a supervising specialist who will be on the floor. He will assess certain patients, but also be a point of escalation for the registrars and indeed nursing staff who want further advice or support for particular patients.
All right. Well, Mr. Thomas, why were parental and staff concerns not listened to and actioned in a timely manner?
I think it is. It's very disappointing. I agree that this did not happen. As part of our CERS response, which is called a clinical emergency response system, the expectation would be that once a patient is recognised to be sick or deteriorating, that will be escalated to a more senior member of staff. In this case, unfortunately and tragically, that did not happen, and we're very sorry for that. The second is that we also have a program called REACH. REACH is an escalation pathway such that a family member who has concerns about their loved one are able to escalate that care. Unfortunately, in this occasion, the concerns of Joe's mother were not heard by the staff. That is really part of what should happen in terms of the REACH program. We have embedded the REACH program at Northern Beaches, but one of the things that we have found as part of that review, it is a passive process. Since this tragic event, we have implemented a new system with REACH, which is a proactive program. So as part of the triage process, there is a stop moment. At that stop moment, there is a card given, at this point a card given to the parents with a QR code. That QR code can then be scanned by the parents of any child, and that will also direct them to the REACH telephone number, but also the process of escalating if there are concerns.
And that's in place right now?
That's in place right now.
Okay.
It's something that we've
Thank
taken.
you. All right. Mr. Thomas, why was Joe Masser denied IV fluids?
From a review, it wasn't that he was denied fluids. The initial assessment and diagnosis was this might be gastroenteritis, and a sip and wait mechanism, which is a standardised type of protocol for these patients, was employed. My understanding, looking at the clinical notes, is that baby Joe was taking some sips, and later on he was given IV fluids, but clearly, when we look at this retrospectively, that was too late, and he should absolutely have had IV fluids prior to the moment that he did.
Yes, well, Eloise Masser requested an IV drip on 3 separate occasions. Why wasn't this step taken?
As I mentioned earlier, tragically, this is a result of a lack of recognition and a lack of a parent's voice being heard by nursing and medical staff in the emergency department. As Greg has said, we take full accountability for that, and more importantly, have already put some steps in place to try and rectify that so that this does not happen again.
All right, what is the rationale for refusing a drip to toddlers who are deteriorating?
A clinical assessment is made of patients. Generally speaking, particularly for young children, there can be difficulties in placing an IV cannula to give a drip. It can be distressing for infants, and therefore the clinical pathway would also be to try oral fluids first, and then perhaps nasogastric fluids. And if that failed, or the child still needed more intravenous fluids, then it would be an IV cannula and IV fluids. There is no rationale to refuse a child who needs IV fluids. In this case, this was a failing on the part of our department, and there are many children that come through the department who would get an IV fluid and drips.
All right, so were there any directions to staff at the time of Joe Masser's death to limit the use of IV fluids?
No, there wasn't.
Okay. Were there any discussions, Mr. Thomas, about at the time of Joe Masser's death about the prioritisation of IV fluids at Northern Beaches Hospital?
As we were all aware, there was a shortage of IV fluids across the state. Perhaps importantly, at the start of that IV fluid concerns and restrictions of fluids, Northern Beaches joined HealthShare, so the New South Wales health system, to ensure that we had adequate supplies of fluids. I can confirm that we had our normal stock of fluids thanks to the participation and collaboration with New South Wales Health. And in terms of restriction of fluids, there were certainly no restrictions in place for emergent patients in the emergency department, or for patients requiring IV rehydration in an acute setting.
All right, so do you stand by the decision to refuse Joe Masser an IV drip after his mother asked 3 times?
As I mentioned earlier, that was a mistake, and retrospectively, it would have been appropriate to have given baby Joe fluid earlier during the point of his admission, yes.
And to listen to mum?
That's correct.
All right. Mr. Thomas, in the SAER, it's reported that a nurse escalated concerns directly to the emergency advanced trainee and they were dismissed. Why were those concerns dismissed, as well as mum's?
In terms of that investigation, it was clear that our escalation mechanisms were lacking in terms of recognition of that escalation. I understand from the clinical record the doctor did make a plan to review baby Joe, but that was later, and at the point that the doctor did review baby Joe, his condition had deteriorated significantly.
Mr. Thomas, is it common for the concerns of nurses about patients to be dismissed at the Northern Beaches Hospital?
It is not common. I think, having worked at the Northern Beaches Hospital for 5 years, and there is a culture of reporting, I think it's probably important to note as well that just 12 months before, we had had an accreditation visit from the National Standards Body, and they had clearly said, and I would like to quote, there's an excellent demonstration of teamwork and productive collaboration. We saw many examples of the positive, engaged and person-centred culture in action, in addition to the culture of continuous improvement.
Right,
it's tragic that that Joel's mother's concerns were not heard, and simply the nurse who raised concerns did not get a doctor to see Joe at that time.
Yeah, it is. Mr. Thomas, why do you think parental and staff concerns were dismissed and were not actioned in a timely manner?
I think one of the issues, and we have seen this in other situations in other hospitals as part of the shared learnings report, that there was a degree of what we call anchoring bias. A diagnosis, a presumptive diagnosis of gastroenteritis had been made, and that gets, I think that it got fixed in perhaps the minds of some of the staff that this was gastroenteritis, and gastroenteritis would often be treated with an IV fluid approach at the last minute or later in that process, apologies, but normally that would be a sip and test and try and challenge with oral fluids first. So again, going back to our overall culture, we often see very successful escalation of concerns by nursing staff, by junior medical staff to senior staff. In this case, this was not acted upon, and it is clearly a tragic outcome because of that. In response to that, we are looking at our culture of safety, and we'll be participating in a cultural survey in participation with North Sydney Local Health District later this year.
Mr. Thomas, can you confirm exactly what time Joe was moved to the resus room from ED and by who?
It was approximately between 10:35 and 10:40 in the morning. Joe was moved from the paediatric ED to the resuscitation room, accompanied by a nurse, a registrar, and then a consultant joined them as they went into the resuscitation bay.
All right, was Joe left unattended in the resus room at any time?
We have records. I clearly wasn't there, but looking at the records of the resuscitation in the resuscitation bay, as opposed to the paediatric room in the resuscitation bay, there is clearly documented evidence that there were 3 ED staff specialists in the resuscitation bay, 2 junior doctors and a number of nurses, each one of those having a role that was confirmed as part of that.
When you say the role was confirmed, but were they there? What do you say to both of Joe's parents' account that Joe was alone for a period of time in the resus room until he went into cardiac arrest?
Unfortunately, I can't comment on that. I don't understand whether that meant that there wasn't somebody by the bedside in Joe. The emergency department resuscitation room is a set of 3 bays, and those 3 bays have a number of staff who are allocated to them. It's an open space, but not having spoken directly to Joe's parents, I can't comment, but the resuscitation record shows clearly there were a number of people involved in that process.
Sorry,
They're actually retrospective, aren't they?
No, Mr. Fang, I haven't
Well, no,
finished my
I'm
questions.
sorry.
Please don't butt in.
No, no.
You've
Are
got
they
the third session.
retrospective? Are they retrospectively
You have the
written?
third session, Mr.
The,
Payne.
the resuscitation also
So point of order, Chair. This is
contemporaneous
not.
because
You
there
haven't
is a
given this
strong-
member
Yeah,
the
with
call.
apology to the witnesses, I've got a point of order.
Yeah, you haven't. This member hasn't sought the call. Neither have you given it. I'd like to continue with my questions.
Well,
if
no,
I may.
I'm-
It's
I'll uphold the
disrespectful
point
to
of order and
parents.
go back to Mr.
Thank
Wall.
you.
Thank you.
I think we have some questions to Ms. Pearce.
Chair, if I may.
Yes.
Ms. Pearce, what would be the cost of exiting the contract with HealthScope for the running of Northern Beaches Hospital?
I'm not able to comment on that.
Are you able to take that on notice?
You'll appreciate the commercial in confidence nature of that question, Mrs. Carter. I can't comment on it.
Are you able to comment on the annual cost for New South Wales Health to take over the running of Northern Beaches Hospital's emergency department?
No, I can't.
Okay. What about the cost to take over the entirety of the hospital?
That would be dependent on a number of factors with respect to the contract deed and any resumption of the state in the hospital is a complex matter. There are various mechanisms in the deed, as you'll be aware. With respect to the public component of the facility and the private component, and also the posture or the position of both parties with respect to that as to how that would occur.
Could I just quickly ask you whether the Minister has asked you to look at any options for New South Wales Health to take over the running of Northern Beaches Hospital?
We have, over a period of time, had a look at what that would mean in the event that there was an issue with, with respect to the HealthScope team here, noting the private equity component and media reporting with respect to some issues associated with the financial viability of the organisation. We have done some work to understand what that would mean for us.
Thank you.
Thank you. I've also got questions along the same vein for yourself, Mr. Horan, and your team.
Yes.
Before this incident occurred, had your clinical staff raised any issues about staffing in the emergency department at Northern Beaches Hospital?
So Peter will be best placed to answer any specific staffing issues in the emergency department at Northern Beaches, but what I will say is that as a general approach to staffing, we staff all of our areas, whether it's emergency department or otherwise, according to acuity of our patients. And particularly on the public side of the hospital, I would also say that our quality metrics are comparable with all public peer hospitals and for the vast majority of metrics, and haven't had significant issues with quality as a general rule through the department as associated with staffing. So I'll ask Peter to answer specifically.
In terms of the emergency department, the biggest challenge for Northern Beaches, as for many of our public hospitals, is junior medical staff for the emergency department in terms of recruitment and retention. We often rely, unfortunately, on overseas, often UK trainees to come across and join us. That being said, at the time of this tragic incident, the staffing levels at Northern Beaches were as per the rosters and as per the agreed staffing levels. But staffing can be a challenge, in particular junior medical staff, and that's something that we work with. We also are fortunate enough to have a casual pool of doctors who have previously worked at Northern Beaches, and we will often call on them if we have shortages on the rosters on any particular day.
The 2020 inquiry into the operation and management of Northern Beaches Hospital, which was undertaken by this committee before I was a member of it, heard evidence from the union representing junior doctors, particularly about lack of support for junior medical officers and understaffing, under-resourcing of the JMO unit and associated issues. Was any work undertaken after that 2020 inquiry to improve the support for your junior medical staff?
Yes, absolutely. I joined Northern Beaches Hospital in the capacity as Chief Medical Officer in December 2019, and so I was aware of those reports. As part of my first 12 months to 2 years in the role, we looked at the staffing and recruitment profiles. I also restructured the JMO unit to ensure that we had more administrative staff to support the unit, but also to review our recruitment and retention campaign. That was very successful. When I first joined in 2020, we had a significant number of locums that were covering shifts at Northern Beaches Hospital. Since then, we've increased the FTE, so the number of doctors, by about 25 to 30 over the 2 to 3 year period, and locum use has reduced to a minimum. That is good for two reasons. The first, of course, is that we then have doctors who are used to working in the hospital that are part of the permanent workforce. That's good for safety, that's good for culture. And secondarily, it's allowed us to have a more proactive campaign. And an example of that would be giving overseas doctors, UK trainees, 2-year contracts instead of the traditional 12-month contracts. And that helped us in the long term with our recruitment and retention. At the start, as an example, at the start of 2024 and at the start of this year, we actually have a fully recruited ED department in terms of positions filled.
Mr. Horan, you said a couple of times in your answer that the hospital and department were fully staffed. I understand that you've got a different staffing policy compared to were this a publicly run facility, and I understand that the Nurses and Midwives Association made a recommendation in writing in November for Northern Beaches Hospital to be staffed as a level 5 public facility. Did that result in any change as a result of that alarm being raised by your nursing staff?
So, to my knowledge, we have continued to staff the hospital appropriately based on the acuity of the patients that we have, and have always staffed it in that way.
Why were 2 staff nurses cancelled for night shift on the 20th of February, leaving the emergency department understaffed by 1 nursing staff member?
So I'm sorry, I couldn't answer as to why on the 20th of February 2 nurses. I'd have to take that on notice.
Thank you. How is a root cause analysis done at Northern Beaches Hospital, and is it any different from the way that that's done in a public facility?
I'll pass to Peter on that, but we follow the SAYA process, which is implemented across all New South Wales Health, but I'll pass to Peter.
Yeah, just to confirm, Northern Beaches has adopted many of the New South Wales health policies. So, for example, in terms of the SAYA process, what used to be called a root cause analysis, we use exactly the same process as New South Wales. And just for clarity, that includes external independent specialists with special sort of SME, who can shed light on particular aspects of a case. The SAYA process is run as a privileged process as per New South Wales. Nobody on that team will have had direct care of the patient that is or the incident involved in the incident that has happened. So it is just the same as the New South Wales process. And we also report up to the regulatory branch of the ministry. So we send our SAYA reports across to the North Sydney Local Health District and up to the Ministry of Health.
And what accountability or follow-up process is there for the implementation of recommendations that come out of those processes?
There's a number of different government structures that we adhere to. So the first is that as part of our monthly performance meeting with North Sydney Local Health District, we have a, if you like, a tracker that informs the district of progress of those recommendations. We also, when a recommendation is completed, explaining that the recommendation is put with a specific timeline, and once that recommendation is completed or the progress of those recommendations are also sent to the Ministry of Health regulatory branch so that they can see the progress of those. The majority of SAYA recommendations are completed within the appropriate time frame. If there is something that requires an extension, then we'd, just as the same process as New South Wales Health, we would request an extension for that particular recommendation. But today, Northern Beaches has followed through and completed its recommendations, and currently there are no outstanding recommendations for any of the SAYAs that we've conducted.
Thank you. The New South Wales Nurses and Midwives Association has also complained, and this is back in November 2024, the document I'm quoting from, that they've attempted to establish equivalence between New South Wales Health and Healthscope's key performance indicators with limited success. They maintain that difficulty in accessing your key performance indicators would also be experienced by the public. Data that's available is high level and will not capture the quality of care issues to the level of detail required or identification of matters such as those described by our members. What action have you taken to align key performance indicators with New South Wales Health and make that information accessible by staff and the public?
Absolutely. Our KPIs, our clinical KPIs, are actually set by New South Wales Health, and if we think about the emergency department, we report on exactly the same KPIs as a public hospital or public emergency department. As part of our reporting, those results are published along with other peer hospitals in the BHI data. It is publicly available. That's a public document, and that is available currently on the BHI.
Thank you. My last question from the same document, raising the concerns from the Nurses and Midwives Association about the implementation of and strict adherence to clear patient flow protocols to address bottlenecking and care delays during triage in the emergency department, which sounds like it may have been one of the contributing factors to this awful incident we're here discussing.
In terms of the whole of hospital project, so patient flow is something that all of us have to consider. In hospitals with emergency departments, Northern Beaches has a very similar structure in terms of its approach to patient flow. Currently, I am responsible and carry that portfolio at the hospital. We have 3 strategies to enhance patient flow. The first is a clear focus on transfer of care, which is getting our patients off the ambulances and getting the ambulances back into the community where they're needed. Northern Beaches, if we look at the BHI data, again, which is publicly available, Northern Beaches has been at the top 1 or 2 of our peer hospitals in that process, showing that we are able to get patients off the ambulances. Moving through the hospital, I think it's important to say that it is always difficult. We have a busy hospital. Over the 5 years the hospital has grown in size. We have just under 500 beds and we are often full, as are the public hospitals. But as part of our patient flow processes, we also collaborate with North Sydney Local Health District. We contribute as part of the whole of hospital district committee, where we have some shared learnings. But essentially the processes that we have in place are almost identical to any other public hospital. And for the most part, our patient flow is excellent. In the 5 years I've been there, we have only ever had 1 patient who has stayed in the emergency department more than 24 hours, which for a hospital with 65 to 70,000 presentations through the ED, I think is an outstanding achievement and testament to our usual patient flow mechanisms. There are very few hospitals in New South Wales that will be able to demonstrate the same in terms of patient flow from the ED.
Thank you. I'm out of time, and I'll go to my colleague, Ms. Kate Fairman.
Thank you, Chair. Ms. Pearce, I'll direct this to you, just unclear of who to direct this to. This is in relation to the Broken Hill lead situation, so lead in children's blood. I understand that there was a $13 million Broken Hill environmental lead program that was funded between New South Wales Health and the EPA over 5 years, which ceased in 2022. How much is the New South Wales Health spending at this point in time on an annual basis in terms of screening for lead in people in Broken Hill?
Okay, I'll see whether, Kerry, do you know that, or perhaps Alpha? If we can't locate it now, we'll try and get it to you.
That's a very direct question, but I've got more on the program.
I'm happy to
the
take
funding.
I'm happy to take Ms. Fairman. I can commit that New South Wales Health continues. Sorry, just take.
That's right. I was hoping to give you a break, Dr. Chen. Go to something else,
I was happy to. We're continuing to ensure that there is access to blood lead testing in Broken Hill. We recognise the community is in an environment where there's ongoing contamination and exposure pathways particularly for young children, and we are supporting that. So I'm happy to take it on notice in terms of the costs, how we're supporting that. And I would also want to acknowledge Marama Aboriginal Community Health Centre, Aboriginal Community Controlled Health Centre, who's also very much a partner in this.
Yes, and I'm glad you mentioned them as well, because I was going to ask questions about them as well. So I do have, I do have a briefing here that is a briefing for the Premier, which is, sorry, I've got more documents to hand around if the Secretary or someone can. But it does state that that the health currently spends the date of this, thank you. The date of this is 2023, it's 13th of June 2023. And it states that health currently spends $290,958 per annum on lead screening. However, since the program that I mentioned before has ceased, health's capacity to follow up with children with high blood lead levels through home visits, assessments and case management for remediation and education programs has reduced. It's also states as well that Marima EPA, so the EPA allocated $1 million to Marima, for example, and they used to do the community dust monitoring home abatement funding of 2 staff, but no funding is available for 2023-2024. So Marima has actually no, we'll just go with that first question. Is that the case? Is there less capacity in New South Wales Health as a result of that $13 million no longer having ceased in 2022?
Look, I would have to look into what the perceived gaps is. I can say that there have been some additional augmentations of staffing in the Western and Far West Public Health Unit in terms of environmental health officers, and also a public health physician was appointed last year. So I would just need to look at, and clearly that person has got a strong focus on the lead issues. I know we're actively doing work with Marima on the appropriate technology for the blood lead testing, and there is an expert group that's working collaboratively across the players. So I think it's a little bit of a changing feast, but I would be sure that there's also a need to address this as a whole of government issue, because obviously the area is highly contaminated and ongoing exposure, and the challenges of doing temporary interventions in homes that then become dust containing lead is then reintroduced into those settings. So it does need a whole of government approach, and those I would just have to update myself on where that process is up to, Ms. Berman.
So you've taken on notice to see if we can get any up-to-date figures in terms of expenditure. As Chief Health Officer, Dr. Chan, what's the ideal level? I suppose the NHMRC guidelines for lead, is that what New South Wales Health goes by?
The NHMRC guideline is the guideline that we would set as our benchmark, and a lead in children is notifiable, so there is that process that we have to actually follow up and know who requires care. And also obviously for children with very high levels of lead, it does require clinical intervention, and that's facilitated collaboratively with Children's Hospital Westmead in terms of the care for the children that are impacted. But
this Premier's briefing note that I think you've got in front of you now, which responsible officer was Mr. Ryan Broom, Director of the Health and Education Social Policy Branch. Excuse me. But it does say on page 2, the second lot of dot points, the second dot point says that in fact reducing the blood lead level threshold to 3.5 micrograms per decilitre, which is lower than the 5 that you've just quoted, and providing case management support for families of affected children with that is lower than the NHMRC guidelines, and will capture more children in the management program, but is in line with other international jurisdictions and accepted evidence that there is no safe level of lead. This is a brief to the Premier. Is this another example of the NHMRC just being out of step with international science?
Look, again, I'd have to take that on notice. Obviously, we try and drive down the lead levels as low as feasible, and it's been great to see actions by governments to remove lead from petrol, which was a major source. That we know that there are a small number of impacted communities, such as Broken Hill, that require a more holistic approach to deal with, but obviously we want to see as low as possible. It's also important that we look at the multitude of factors that impact on a child's development, and I think the lead issue in Broken Hill has really highlighted that we need to work in a holistic way to address multiple factors.
I think, Ms. Fairman, I might just mention that Kate Maher is here from the Premier's Department. If you wanted a whole of government view on this matter, might be useful.
Okay, yes, I just want to finish up one thing with Dr. Chan. And there's one more thing to hand out. The Secretariat's going to be very annoyed with me by the end of it. But
why don't you just table it all together?
Because we're talking about it individually like this, and this one is a New South Wales Health, the Expert Advisory Panel meeting, led in Broken Hill, dated 2nd of February 2024. And it's just a question from you, for you as Chief Health Officer. Thank you very much. Is the question, so on the second page, it does say, which I'll read it out and you'll get it in a minute, that this is the most recent annual and quarterly Broken Hill lead surveillance reports prepared by the West New South Wales LHD were presented to that expert panel. And it says, it was noted, it's on the second page, first dot point, it was noted that Aboriginal children continue to be more at risk and that most children with very high blood levels in Broken Hill have PICA, P-I-C-A, and autism. And the previous document I gave you said that 66% of Aboriginal children in fact had blood levels higher than the NHMRC. So that's a lot of children, 37% of the other rest of the population. So most children with very high blood lead levels in Broken Hill have PICA and autism. That's concerning, isn't it? Very concerning.
Well, the PICA is actually when you consume or eat dirt, so that does explain their additional risk, and obviously autism and some behavioural issues do play into the factors. And I think that goes back to my previous response, Ms. Furman, that we really need a holistic, this is disproportionately impacting Aboriginal children, and that needs to be addressed, and it needs to be addressed in a whole of government, and we need to take it seriously. But in order to produce, I'm also looking at it from a population health outcome measure, that we need to actually support these families that are Aboriginal and often encountering other challenges, to take a very holistic approach, and hence the importance of a whole of government approach. Some of the challenges for the community members is that children may move from parent to more other family members, and so you might have an intervention in the house, but then the child gets re-exposed. So I'm saying that we need a complex whole of government response to the issue in Broken Hill. I think it's a really important one.
On that note, in terms, just the last few seconds, it's given the legacy of lead in Broken Hill, New South Wales Health's view of other lead mines in New South Wales would not be very favourable. Would that be a correct assumption?
I think everything has to be in context in terms of where the, what I think the issue here is that clearly the township has grown up around the sources of historical and ongoing lead exposure. That differs. So what I think Health's perspective is where you have an exposure pathway, and what we know is there is an ongoing exposure pathway because the soil is contaminated. Depending where a lead mine is in proximity to communities, and how people are exposed, either in air or in soil contamination, that will influence how people are exposed to it, and how they could, how that will add to their blood lead levels.
Thank you.
We'll go back to the opposition, Mrs. Wong.
Thank you, Chair. Thank you again. Just back to Health Scope. Can I just ask, does the Northern Beaches Hospital have CCTV or other electronic communications to validate who was in that resus room with Joe Massa?
So we only have CCTV in corridors. We don't have CCTV in the resus bay area.
Okay. So how many consultants were working in the emergency department between the hours of 7 a.m. and 11 a.m. on the 14th of September, both paediatric and adult ED?
I can answer that question. So we have 3 specialists on the floor at any one time. So for the morning shift, that starts at 8 o'clock. Prior to that, there'll be the junior medical staff, the physical presence of the ED consultants or specialists. Their shifts commence at 8 o'clock in line with other New South Wales hospitals, and we would have 3 specialists on the floor at any one time.
So on the 14th of September, can you confirm, and you're sure, that there were 3 in place?
I can't confirm. I can certainly take that on notice.
Please.
What I am aware, there were 3 specialists listed on the resuscitation record who were ED specialists who were present in ED at the time of the resuscitation at after 10:40.
All right. Mr. Thomas, can you clarify when Joe Massa was put on an IV drip? Was it after his cardiac arrest?
I can't clarify that without confirming the notes, but I do know that he didn't have an IV cannula placed until he was in the resuscitation bay.
All right, you'll take that part of it on notice.
That's correct.
All right. And the 3 staff in the resus room, what care did they provide to Joe?
So there were more than 3 staff in the resuscitation bay, according to the contemporaneous record. What we, when we have a cardiac arrest or resuscitation situation, we'll have 1 specialist, and looking at the record, there's 1 specialist who takes the airway, 1 specialist who is directing the resuscitation, and another specialist who is what we call the operator, who will be leading interventions on a patient, in this case Joe. There were also 2 junior doctors and a number of nurses fulfilling various roles in the resuscitation, including 1 person who's allocated as a scribe, which allows us a contemporaneous record of the resuscitation, literally in a minute-by-minute chronological sequence.
So those 3 were carrying out those roles at that time?
So there were 3 specialists at the resuscitation.
Okay. Mr. Thomas, it's been reported in the Daily Telegraph today that a newborn baby has died at the Northern Beaches Hospital under tragic circumstances, and the chief obstetrician is investigating. Can you confirm whether an emergency C-section was called?
I'm aware of the case, and again, I'm limited to what I can say due to confidentiality, but there was an emergency caesarean section for the mother of the child who was transferred to North Shore Hospital.
So there was?
There was.
All right. And so how long did that mother wait for that emergency C-section?
I'm not aware of the details of that case.
You able to take that one on notice?
Happy to take that on notice.
Thank you. And were there any other clinical deficiencies identified?
The provisional risk assessment or preliminary risk assessment has been done and hasn't highlighted any key deficiencies as far as I'm aware.
All right, thank you.
Just one follow-up question, if I may, in relation to the corridor CCTV. Is that available for the entrance to the resuscitation room?
No, it is not.
Because of cameras of where they're positioned, or why is it not available?
Because cameras are not positioned there. There's CCT footage in the waiting area, right. And then there is CCT footage in the corridor outside of the paediatric area, but not actually going into the resus bay.
Right. Thank you very much. Ms. Pearce, I have a couple of questions for you, if I may, in relation to Bankstown and the nurses with which we're sadly all too familiar. Could you update us on what New South Wales Health is doing in relation to review of workplace culture at Bankstown and at other hospitals following this incident?
Look, I'm happy to comment. I'll restate that issue has been dealt with the utmost seriousness. You could see, I think, quite clearly that we were incredibly disturbed by those events. We have undertaken a range of actions since that event. In particular, quite a lot of discussion with Multicultural New South Wales in regard to how we continue to support people from multicultural backgrounds. Tomorrow we have our Chief Executive's monthly meeting. We have a Jewish rabbi coming along to that meeting, as well as one of our Muslim doctors joining in that meeting. Further to that, I think that it's important to note that we have 180,000 staff working across hundreds of hospitals in New South Wales Health, and we want to create an environment where our workplaces are safe, both for our staff and clearly welcoming for patients. Yesterday, we released a video called We Are Here For You, which shows a number of staff from many different cultural backgrounds. That has been met with a huge amount of positivity from the staff of the New South Wales Health System. I think it's fair to say that people were shocked by that event and dismayed by it. It is very clear from our perspective, and we will be issuing further guidance to our system on this, as we have done in the past, that people are entitled to their views, and indeed they are citizens of the state and the community. Those views are to be left at the door when they enter our workplaces and not continue to be promulgated in our workplaces. We are troubled by some of the behaviour on social media, putting us quite aside that incident. The manner in which people speak to each other in society generally spills over, of course, into a very large health system such as ours, and we will be issuing further guidance to our staff on that.
Thank you, Ms Pearce. That's very comprehensive. If I may address some questions to Mr Morgan, who's sitting in the back row, sorry. So, Mr Morgan, Commissioner Morgan, in regard to the rollout of the 500 regional paramedics, can you explain the modelling tool used to guide the deployment decisions?
Yeah, so primarily in relation to that, there are a whole range of things that our service planning area take into account.
Mm-hmm.
Probably you would expect that two of the biggest areas we look at relate to paramedic fatigue and wellbeing and welfare, and obviously activity within any given regional area. So the primary driver of paramedic fatigue has historically related to work locations where we've had a very antiquated model relating to on-call duties. So what that means is a paramedic would work during the day and then would retire to their residence. If an emergency call came in overnight, they would be required to respond from their home. So first and foremost, the service planning people look at where we can retire on call to give additional breaks to the paramedics, and then after we've taken care of that, of course, there's a balance between the activity levels within a community.
And is that tool and is the data generated by it publicly available?
Well, there are many inputs to it, and we have a service planning unit. It may be helpful if we were audited by the Auditor General last year. The Auditor General, as you know, do not tend to make particularly favourable comments where it's not warranted.
Mm-hmm.
I think the commentary from the Auditor General is probably relevant to your question.
With respect, Commissioner Morgan, is this data transparent? Can we access it so we can see how these decisions are being made?
How the decisions are made, yes, that is completely transparent. So what I can tell you is we have obviously a clinical services plan. That clinical services plan is informed by two main documents. One is a role delineation guide that determines what a particular class of, generally speaking, our paramedics will do. The other one is a clinical capability framework.
What about consultation? Is there a consultation with paramedics? Is there a consultation with individual stations? Is there a consultation with regional communities?
Yeah, primarily, yes, the consultation does occur with paramedics. Yes, the consultation does occur at the local level that you're referring to. So through our industrial process where we're rolling out new services and enhanced services to communities, We have two ways we approach it. One is through central consultation with predominantly the Health Services Union and the Australian Paramedics Association, but we also have local consultation where we have representatives go out and talk to the staff on the ground.
And how much weighting has been given in the development of these new plans on allocating paramedics to reduce on-call shifts across regional areas?
Quite significantly. So what I can tell you is that in terms of our reduction of on-call in regional areas, we've reduced 46 different locations we've been able to completely remove on-call. We've had a further 9 where we've been able to reduce on-call, and that was as of the 1st of February.
Yep.
Thank you.
Thank you. Commissioner Morgan, Dr. Morgan, thank you. So can I just ask about whether that arrangement has come at the expense of bolstering coverage during peak demand periods? And the context for that is that I know Goulburn received 5 additional paramedics, but these were allocated to reduce their on-call shifts. They've been asking for them in the afternoon where there is a peak patient demand.
Yeah. So what I can tell you specifically about Goulburn is that Goulburn is part of a hub. There's quite a wide community that surrounds them. One I'm personally aware of is obviously Crookwell. There's another number of stations within reasonably close proximity. The nature of Goulburn is unique because of the way that it supports other local stations. So if you think the scenario through, if there's an incident, say in a town like Goulburn, where there only one day crew is occupied, we need to be able to send another crew out if another emergency occurs in that community, and likewise for any of the other small communities. If we were to have gone with the model that was preferred by the staff to introduce an afternoon shift, and I fully understand why anyone would prefer an afternoon shift than a night, it would have left Goulburn with no ambulance, a major area.
Okay.
And so we had to balance out the needs of the community against the well understood desires of the staff.
Okay. Understand that. Can you advise then how using paramedics to remove on-call rather than placing them in peak afternoon periods meet the Regional 500 Charter, which is explicitly focused on patient outcomes rather than workforce restructuring?
No, I don't think that was actually accurate. So the 500 in the election commitment were not targeted to anything other than regional New South Wales.
All right, well...
But look, I suppose to directly answer your question, it is vitally important that we have a well-rested and well workforce.
Sure.
Yeah.
Dr. Morgan, Hatzalah provides a life-saving bridge of medical care during the first critical moments of a medical emergency before the arrival of an ambulance. For the past 12 years, they've received monthly training by New South Wales Ambulance at Bondi Ambulance Station, but this has recently stopped. Do you know why this is?
Yeah, I am somewhat aware of the issue around Hatzalah. During the pandemic, they were part of a community volunteer program, which ceased to respond during the pandemic. I do know that there has been local engagement with them, but there's been challenges around them coming back into meeting the necessary standards of New South Wales Ambulance to come back into the response grid. There's no philosophical view about this, but there are standards, and we've got to make sure that all of the people that actually respond as volunteers, as an adjunct to New South Wales Ambulance, meet those standards.
All right, so will that be restored? Can you...
It will depend on their ability to meet those standards.
All right, can I ask you to take that on notice to let the committee know what the timeline for that is, when a decision about that will be made, or restore the training?
I think it might be more a question for Hatzalah.
All right, I may or may not pursue that further. So Hatzalah isn't allowed to use those lights and sirens, but they're often first on the scene of medical emergencies in the eastern suburbs. Given if they're to be restored, would you be supportive of them being able to use lights and sirens?
That's an issue that falls under the remit of the New South Wales Police Commissioner as to the grounds upon which the use of emergency warning devices are used. What I can say to that is you can imagine using lights and sirens and being exempt from provisions of the Motor Traffic Act comes with both benefits and risks.
And so would you be supportive of them being returned if they're first there and they're playing that critical role? Is that something you'd be supportive of?
What they would need to do is satisfy the police commissioner that they had the necessary policies, procedures and training and maintenance of those skills to ensure that in their desire to render aid to the community, that they were also not placing the community at greater risk.
Okay, and just one final one for you, just in relation to new ambulance stations, who makes the decision on those? Is that you and your department, or is that the Minister?
Service planning. Yeah, that's service planning. That goes to the nub of what I was saying before. It is a very robust process. And
I just want to know who makes the decision. Is that a decision within that group or within the department, or is that a decision for the government and the Minister?
Within New South Wales Ambulance.
Yeah, so
we'll
the Minister doesn't decide this station's prioritised over that one, or there's a new or upgrade. That's on your list and your decision.
That's on the service planning list. That's correct.
Right. Thank you.
And it's quite, frankly, mathematical how they go about it.
Right.
Yeah.
Okay. But that's a decision within that framework that is not touched by Minister Park or the government?
No.
Thank you. Can I go to Ms Pearce, if I may? Just on pill testing, Ms Pearce, last year in supplementary budget estimates, Mr Tudhope asked you and Dr Kritikos a number of questions about whether New South Wales Health had commissioned an evidence-based review of pill testing. You and Dr Kritikos, I'm sorry if I'm not...
Kritikos,
thank you.
Yeah.
Both appeared not to be aware of any such review, but we now know that New South Wales Health had commissioned an evidence review of Monash University. Can I just confirm that on the 2nd of December 2024 you were not aware that evidence review had been commissioned or provided to New South Wales Health?
Not that I can recall.
Okay.
Yeah.
Who in New South Wales Health was responsible for commissioning the evidence review?
I'll get Dr Chant to respond to that.
Obviously, as part of the support for the drug summit, New South Wales Health commissioned a lot of paper as part of our contribution whole of government, and I've got to acknowledge our other agencies also did a number of papers to support the deliberations at the drug summit. So there were some pieces of work that were progressed just so that we were across the evidence base. There'd been a previous review by one of the other government. I think Victorian government had previously commissioned Monash to do a piece of work, so we felt that it was appropriate for us to do that evidence check, and it was made available publicly.
So that was initiated for the drug summit. Can I just ask?
Well, it was initiated as part of our continually ensuring that we're across the evidence base as you'd expect us to be.
Yep.
So
my question
I can't say it was, I'd have to go back and figure out the exact time it was started, but obviously at the time we've come out of the Special Commission of Inquiry where pill testing came up, we've had coronials. You can imagine that we're interested in making sure we're across the evidence base.
I know you're short on time as well, but could I just add a point of clarification
No, because I didn't actually get to ask the question that I wanted to ask.
I mean, the point is, I think there's a difference between commissioning a review and providing a series of documents for attendees at an event. So perhaps
but I might just get to my question. I can put further questions on notice about that. But did the Minister's office request an evidence review be commissioned?
In relation to pill checking? No, it's initiated. From my recollection, it's really been something that you'd expect from a policy perspective. We would be across the evidence.
Thank you. And so page 24 of the review states that the New South Wales Ministry of Health reviewed the search strategy and drafts ahead of publication. Who in New South Wales Health was responsible for reviewing those drafts?
I would have to take that on notice. I would be guessing, but I would assume it was within our drug and alcohol group that is responsible for the toxicological surveillance, but I will take it on notice.
Thank you. Okay. And before the final publication, did anyone from New South Wales Health ask to have any of the content removed from the review?
As I said, I would have to take it on notice.
Okay. But, and how much did the evidence review by Monash University cost?
Again, I would have to take it on notice.
Okay. Ms Pearce, the rapid review also states that rigorous pre- and post-implementation research is needed, and these types of evaluations should include lived experience perspectives at all stages of design, implementation and evaluation. Do you agree with that, and who will be evaluating the trial?
I'll get Dr Chant to respond to that.
So at the moment, we are going to be commissioning some external stakeholders for the evaluation of the report. We are also very committed to working in partnership with people with lived experience. As part of that, I think to commend the branch, they've had a long track record of doing so. And as I reflected, NU is really a partner in the delivery of this through the provision of peer educators, which are going to be a pivotal part of the pill testing trial. So very committed to doing that.
Thank you.
Thank you. Before I come to Mr. Minns for an update on safe staffing levels, I'm just seeking to table the document, which was the one I was quoting in the previous session, which is the Nurses and Midwives Association submission to the Northern Beaches Hospital audit. Thank you, Mr. Minns. You provided quite a comprehensive update to the committee in early December. Could you update us on the status of the safe staffing levels rollout, including the status of recruitment?
I just have to find the right file, Chair.
I can go to a different topic and come back to you, Mr. Minns, if you prefer.
That might be a good idea.
No worries. Okay. My other questions are on a completely different topic. Apologies. In 2018, there was a federal government inquiry into biotoxin-related illnesses in Australia that made 3 recommendations in particular for state and territory governments. Last year, I asked the EPA about their role in the implementation of those recommendations. So specifically, there's recommendations around developing standards for mould testing and remediation. What role has New South Wales played in that to date so far?
So our role in response to the issues around mould is more of a fact sheet or providing the health advice. I think I'd have to follow up with my colleagues in EPA around that report and the actions on it.
Sure. While you take it on notice, I've got a few questions on this topic. So, the CEO of the EPA, Tony Chappell, advised a different Legislative Council committee last year that they're meeting quarterly with New South Wales Health about this issue, specifically looking at indoor mould and air quality. And I might read those 3 specific recommendations out to you so you have them to follow up. So recommendation 2 of the inquiry was working with states and territories to conduct research and develop standards for mould testing and remediation. Recommendation 3 was working with states and territories to ensure tenants in rental properties, aged care facilities, public and community housing are informed about mould and water damage issues in property. And recommendation 4 was conducting research into the adequacy of building codes and standards for prevention and remediation of dampness and mould in buildings. I have a particular concern that different New South Wales government agencies are pointing to each other on this issue, and I'm very keen to get to the bottom of who's actually responding to those recommendations. So I'm grateful for you taking that on notice.
No, that's fine. I think they do span whole of government. They do draw on many agencies' responsibilities, but I agree. I will take it on notice and respond. Yeah, we'll coordinate a response that reflects who's doing which pieces of work.
Thank you. Mr. Minns, are you ready?
I am,
Thank
Chair.
you.
So this, I can read these, or you might want them to be tabled later. But Liverpool Hospital ED, they had a safe staffing allocation of 34.32, and all of those are recruited. Royal North Shore had an allocation of 34.01, and 34 have been recruited. Port Macquarie Base ED, allocation 13.32, it's a bit small, and recruited 8.17. Lismore Base Hospital ED, allocation 27.93, recruited 5.63.
Thanks,
Coffs
Mr.
Harbour,
Timmins. Perhaps in the interest of time, I'm happy for you to table the
rest? Okay.
remaining hospital by hospital, but have you got the total allocated FTE and total recruited FTE?
The total allocated is more than 500, but that does include implementation resources at LHDs. So the planning work that has to go on, the consultative work that occurs with the association at each site needed resourcing. So if I can just find the source email, I'll be able to tell you.
So I'm just trying to understand, so of the 17 hospitals where safe staffing levels have been promised, it sounds like 2 are complete.
If I went further through the list, I think there might be some more.
Okay.
Right. But we're about 258 from memory that are recruited, and the total allocated is more than 500. The total allocated to frontline nursing roles is somewhere in the 475 region.
Okay. And what's the expected time frame for completing recruitment to those 17 hospitals that are included so far?
Well, once we work through the process of agreeing the site arrangements and the numbers with the association, then we're trying to get to full complement within 12 months. The association has a view that 6 months should be the target. The issue that we face is just the ability to recruit.
And what's the time frame for the next tranche of hospitals?
April for the 3/4s, and the work about the detailed discussion of what's the site status, how many treatment spaces are there, is that agreed, etc. That's in train, and the first 3/4 sites will start to roll out from April.
Okay, thank you. I think my last question is probably for Ms. Gulander, which is the David Berry Hospital, and I'm referring to this excellent document on your website summarising the community consultation on the future use of the site, which I understand attracted 1,200 contributions. This is obviously a really significant interest to the community. What are the next steps and the timeframe for this process?
We are, it took us a while to get that feedback together, and it is reflective of the amount of feedback that came through, so we've released that report this week. We're in the process of working through the consultation approach for the next stage. So the intention is to progress with a number of focus groups, including meeting with community groups and others who have written to us through this process. We will go back and confirm to those people the approach that we're going to take with that consultation. We're intending by the end of March to kick off that process, so we'll be communicating that over the next few weeks. We're also in the process of engaging an independent engagement consultant to ensure that we've got some sort of independent rigour through the process, and then as we collect the further round of feedback, we'll be able to come back with a more detailed sort of piece of work from the community and from those focus groups.
Okay, and just to clarify, you've said by the end of March, so people can expect to hear from you by the end of March, or those focus groups will be taking place?
Yeah, we'd
by the
like
end
to
of
kick
March?
off the process by the end of March, so during March we'll be able to contact. It may be that, we're obviously at the end of February now and we're just working on the approach to that exactly. Maybe that we sort of are in contact with people and then schedule the sessions over the coming months is the likely approach, but I'm very hopeful that by the end of March that we've got some confirmation so that people are not waiting to hear about next steps.
Sure. I appreciate I probably should have asked this morning, but to your knowledge, has the Minister visited David Berry Hospital yet? Or the former site?
I do not know the answer to the question.
Okay, I'll put it on notice. Thank you. I'm happy to go to my colleague Kate Fairman.
Thank you. Just want to ask about the ICE inquiry funding. So the $500 million funding, how many, do we know what funds, remind me what funds were allocated in the last financial year and this financial year? Do you have the breakdown for that?
I'd have to take it on notice. I can find my briefing notes. But there's a range of ICE Commission funding was also to some other government agencies, our own services,
I'm
NGO,
talking New South Wales Health,
and New South Wales Health Facilities. So I can find the note.
Can I check with that as well, with the funding that New South Wales Health has responsibility for allocating? Who makes that decision? Is there a task force, for example, or a committee that has various NGOs on it, from the alcohol and other drug sector, for example? How's the decisions being made in terms of where it's being spent?
So the budget figure, that's the 20, that's the total budget. This includes, there was 156.3 million allocated to support implementation of programs in response to the Special Commission of Inquiry of the drug ice, and I can take it on notice, the whole list of them, but there was a range of initiatives including additional rehab things. So in terms of
the breakdown, one thing that some people in the sector are concerned about or talking with me about is there's a perception that a lot of it's gone to LHDs and not enough has gone to organisations on the front line, if you like, that aren't from the LHD. So, and the transparency particularly around the way in which that money is spent.
So look, I suppose perhaps some examples of recent things that I'm across in more detail is there's been a range of initiatives that have been, I'd actually say there's been quite a strong commitment recognising the importance of the non-government organisations in drug and alcohol treatment and care. There's been a number of competitive tender processes, usually pulling down themes from the Special Commission on ICE. So there was a program of sort of notional budget allocated addressing the recommendations of the ICE Special Commission. And then there's been a range of tender that have complied with tender requirements. An example at the moment is there's a tender around carers and families. That was recognised as a gap coming out of the Special Commission of Inquiry into ICE.
Is there one of the reasons I'm asking is we know the political history of it. The reason that it was the $500 million was given was part of the government's response, of course, to the ICE inquiry recommendations. But there was that caveat, if you like, of let's see between you and the police commissioner, let's see how that spending goes before we look at, for example, in terms of the drug diversion initiative.
That was the EDI program.
Yes, the EDI program. But the reason is because, for example, if we're going to take people away from the courts and send them into treatment, for example, and services, that those services have to be ready and they have to be sufficient enough. That was part of the reason, wasn't it?
So just to be clear, I gave an assurance to the Minister and worked with the Police Commissioner to actually totally indicate that we had a sufficient capacity to provide the intervention.
That's the phone
and the
call.
range of services, yes, and the range of services needed to support diversion. So that is not the issue associated with the uptake of the service.
But why then? Okay, so you're saying that. Let's take a slightly more broader picture though, but people are waiting, months for treatment in regional areas. I'm wanting to be a bit more broad.
So in terms of the EDI, I think it's important to just take all of the programs separately. But the issue with EDI is that people have a choice of taking a fine or ringing a number and getting an intervention. And that is the initial piece of the data that's being presented to you. So people are choosing one path or another. There's also a discussion about whether we potentially could be using that diversion program more broadly and what are the perceived barriers, and some of those I wasn't here for the Sydney Drug Summit, but there were issues that perhaps awareness of the program was not in place universally across our police at all level in police, and we've agreed to work with police on what we can do to raise awareness of the EDI program and the systems that police need to do to employ to have a better understanding of that program. So we're genuinely waiting for the report, but we're also in parallel have heard some of the issues that have occurred and I want to really work through those as a whole of government. But that's not constrained by, I do accept that there are challenges, there is unmet need, but that's not the particular issue that is playing out in the EDI program.
In the EDI, I acknowledge that as well. Is it possible then to take on notice? My office has asked a few times for a breakdown of the ICE inquiry funding, so the $500 million funding year by year. And again, just because we're getting approached by people in the sector who are frustrated at what they see as a lack of transparency in terms of how it's being spent, I just wonder if I could get a breakdown of the spending and the programs, what's going to NGOs, what's going to each LHD, and the services provided. Because I'm sure in terms of reporting back and looking at outcomes, you have that detail.
Yes, certainly. So we will do our best at portraying the whole picture in terms of the funding envelopes, and as I said, from my sense is there's actually been quite a number of opportunities for the NGO sector, but I know there's unmet need as well, so I can really understand the sector's comments on one hand, but please hear the fact that the drug and alcohol branch has certainly been very keen to work effectively. I should also note that there is a program council where the drug and where a number of the NGO peaks sit with our drug and alcohol directors, and so I've got to say that the drug and alcohol directorate in the ministry does really recognise the importance of the NGO sector.
Yeah, thank you. I just wanted to go back to pill testing. Yes. Is there a government committee that has, or a task force that has a range of different agencies represented that is overseeing the pill testing trial?
Yes, there is. So obviously there's needing to be working across justice, health, police, and so there is an interagency sort of
has it got a name?
Steering group. I can find it I will give it to you. It's just in a brief. And
are there plans for, because I think it was 12 maybe in New South Wales, or I could be getting confused with Victoria, but the announcement I think was up to 12 music festival sites within 12 months.
That's correct.
Is there any more planned for this season?
There are some more proposed for this season, noting that there's generally a lull in the winter months, and we see a resurgence towards the end of the year. So I think it would be appropriate to flag that the vast majority will probably fall in the later half of the year. But we are looking at every opportunity to engage with festivals that may be appropriate for pill testing.
Are results coming out after each festival?
Yes. So we're committed. I suppose in terms of results, there will be ability to say how many people use some core data will be presented. We'll be very transparent with what we find, because obviously that's going to be really important as part of our alert system as well, in terms of letting people know any findings. The forensics and analytical services is going to actually do provided that people are happy that we do use one of the technologies which scrapes the pill, we will, and there's sufficient sample, we will be doing confirmatory testing on all of the samples.
Yes.
And FAS has actually agreed to do that in quite quick turnaround.
What's the communication strategy to the festival goers if, for example, a very dangerous MDMA pill containing nitazene, for example, is found? What's the strategy for that?
So just, I suppose, to be very clear, that low levels of nitazene are unlikely to be detected with the technology, but we've also got some strips, and so we could find nitazene. There is
PMA or something that is not.
So basically, depending on what is found, there is actually in the protocol and algorithm, there is a escalation. I know you asked a question on notice at the last budget estimates that I attended, and just to be clear, that the example I think you gave was when there was an announcement at the
yes.
Yep. Actually, that involved our health staff. So we have got an on-call system and on-call toxicologists that will give us advice. We work very closely with our peer educators, NUA, and there will be a decision and risk assessment made depending on the substance found. whether we do, for instance, announcement on the floor of the music festival, whether it might just be some intelligence that we circulate to the peer workers, all the way, and involving also the information sharing with the clinical staff. We are located in the proximity to both the chill out area and the clinical services. Again, so there's that rapid exchange of information. But we have got a protocol that will indicate a risk assessment depending on what we find, and a discussion and a escalation and an intervention.
And have you discussed with, this is my last question for this round, have you discussed with organisers, which is what happens in some festivals in the UK, for example, where the pill testing service will be able to send a text message, for example, to every person that's bought a ticket on that day to look out for example, this type of incredibly dangerous pill in circulation, which has happened. Have you discussed that type of alert system?
We haven't. I would have to check with what conversations the team have had with the festival organisers, but we certainly have acknowledged that they have good records of, because they send the tickets electronically. So we were thinking, so we have been considering the ways of engagement, but I think that's a good
Highly
point, Ms.
recommend
Furman.
it,
Yeah.
There's a couple of minutes of extra time. I might go to Mr. Fang.
Oh, Chair, I'm planning on having a 20-minute. I want. Also, was going to ask for adjunct Professor Shembri to jump over to that side so that I can question. So Ms. Ward wanted this time, so I'll give it to her, and I want my 20 minutes straight. Thanks.
I want. Dr. Chant, just on bird flu, if I may.
Sorry, yes.
Yeah, thank you. There's an alarming H5N1 bird flu outbreak in the United States at the moment that's infected millions of animals, at least 70 people, including one person who died. How prepared are we here in New South Wales?
I want to acknowledge the close work between health and primary industries. At the moment, we're dealing with a zoonosis, so the flu of the avian and animal flu strains coming across and infecting humans. So there is enhanced surveillance in primary industries are doing work in terms of should there be deaths in native and wildlife, enhancing testing and monitoring. Similarly, we've got a very good biosecurity and vigilance system within our chicken flocks and our herds, so there's lots of information. So we are working closely. We've also done a number of exercises in terms of what that would look like.
Yep.
I can provide those details of that on
helpful,
notice.
thank you. And Canada secured 500,000 doses of GSK's human vaccine against bird flu to protect people most at risk. Has there been any discussions in the department about whether we need to secure vaccines here?
The Commonwealth, the Commonwealth has undertaken planning and is the person who contracts for the virus, contracts for vaccines, and we have pre-existing vaccine. The federal government has pre-existing vaccine arrangements with CSL. It's probably inappropriate for me to comment on some of those things publicly, but I'm happy to.
Can you provide what you're able to on notice?
I would be happy to
That'd be helpful,
talk about what contingencies we've got in place.
Thank you.
Thank you. I've also got a question for Dr. Chant. Sorry, you're really under the pump. Right. There was a very recent Victorian Coronial report handed down that particularly commented on the risks of alcohol delivery services, particularly for people struggling with drug and alcohol addiction and the additional risk from poor regulation of delivery services. Is it something that concerns you, or is any work being done in New South Wales to address that?
I'm sure the team has considered that. Alcohol is a major contributor to the burden of disease. So let me take that on notice and see what work they've gone. But clearly that issue has also arisen in other settings with the NANGs as well, with the online delivery, which we are dealing with through a regulatory process. Yeah.
Thank you. My question's probably too long for 1 minute.
Okay, thank you. Just in relation to the Canterbury Hospital, if I may, Ms. Pearce perhaps, how many CT machines does Canterbury Bankstown Hospital have?
Oh, I'd have to take that on notice.
All right. And in mid-February, the CT machine at the hospital was broken, and we were informed of patients that had to be transferred to other hospitals for a scan. Is this a common occurrence at Canterbury Bankstown?
I would not say it's common, no. It does from time to time happen in hospitals generally that the CT scanner might have an issue. I mean, there are computers involved in those devices, etc., and occasionally things do occur for them to fail. So we do have systems in place with New South Wales Ambulance to make sure we get people to the care that they need as expeditiously as possible, which is obviously well available to us in metropolitan Sydney.
And just one last one, if I may, to Ms Gillender, just in relation to the new Bankstown Hospital, and you can take it on notice if you like. Last year you were asked about the new Bankstown Hospital and the relocation of the TAFE. You were unable to definitively answer whether the $1.3 billion allocated covers the new hospital and the TAFE. Can you now provide that information to the committee?
Yeah, so the 1.3, as I think I mentioned before, was set some years ago, and as with across the programme, we've had a number of issues with cost escalation. The 1.3 is not sufficient to deliver the full Bankstown Hospital as it was originally proposed, plus the TAFE. I will note that the site selection decision was made after the 1.3 was set, so the TAFE wasn't part of the original budget either. We have been working on that project. Some good progress has been made, and there's some options with government in terms of next steps, and that will be a decision for government over the next period in terms of the budget cycle.
Just to be clear, that's the TAFE is out?
No. The work that we're doing with TAFE, so the TAFE being out was my reference to the fact that it wasn't included in the original budget because it was before the site was determined, therefore
Sorry,
TAFE
just to be
wasn't
clear,
included.
yeah, so the 1.3, does that cover the new hospital and the TAFE?
No, but it wouldn't cover the new hospital alone either because of cost escalation since that period of time. So the options that we've presented to government include options for the new hospital and the TAFE.
All right. Could you provide any other information on notice, perhaps, to clarify that? Because
I don't think I'll be able to because the options under development, I guess I will say we're working very closely with TAFE, particularly around their decant from the site. And early next year, we're planning to be able to start work to move TAFE off that site into their premises, which is a matter for TAFE, and you might want to raise with them at their estimates. But I think in terms of the options of moving that project forward, it's going to be a matter for government now over the next period of time.
Thank you.
Chair, can I just reiterate, after the break, if Adjunct Professor Schembri could be just repositioned over this side so that I can direct all my questions in the one area, if that's okay.
Yeah, no problem. Over the afternoon tea break, I'm happy to ask the witnesses to rearrange their seating.
Thank you.
Thanks very much, everyone, and we'll have a short afternoon tea break. We'll be back at 4:45. 4:45, and we'll resume with questioning from the opposition. I'll go to Mr. Fang.
Thank you, Chair. Adjunct Professor Shembri, could you outline for me, please, what is the intersection between yourself with the Northern Sydney Local Area Health District and Healthscope's Northern Beaches Hospital?
Thank you. So our role as the district is to provide oversight and monitoring in relation to the project deed. And so we have governance structures in place to assist with that.
Okay. How often do you employ those governance structures?
So we have a monthly operational services group where the executive of the district comes together with the leadership team from Northern Beaches Hospital to review their performance across a range of indicators. We also have clinical integration groups that are at a clinician level. We also have a senior governance board that meets every 2 months for high level oversight in relation to the project.
Okay.
But also in terms of some of the other performance, the beaches is no different from any of our other facilities. So ambulance transfer of care would be a good example where we have real-time monitoring and oversight.
Right. So effectively at the upper management level, at the clinician level, even at the, I guess, the oversight level,
yes,
you have the ability to interact both with the other hospitals in your district, as well as the Northern Beaches Hospital, even though it's run by Healthscope, correct?
That's correct.
Okay. I'm now going to turn to the gentleman from Healthscope, and just for background, I had the opportunity to sit with Danny and Eloise yesterday. We had the ability to go through some of the timelines for me to better understand the circumstances. And they trusted me, and I have all of the medical records reports that have been provided to them through this process. They've entrusted with me, and I thank them for that, because it's really assisted in me putting these questions together. And just as way of background, for 8 years prior to my time in here, I was a pilot for Child Flight, and we were effectively the helicopter arm of NETS. And you would no doubt that NETS was involved in part of this this issue, so I understand that from that perspective. I also was on the Northern Beaches inquiry, so have a reasonable level of understanding of some of the issues, historic as well as what we're looking at now. Now, I'm going to cover over a little bit of ground that some of my colleagues have already covered off, but I'm doing that by way of, unfortunately, I was trying to get some of those questions in, and that was not appreciated by some of my colleagues, but there we go. I want to start by looking at, when we were talking about the resus record, Mr. Horan, you indicated that the resus record itself, and the question that I asked was it retrospective? Can you confirm that that's the case?
So I think it was actually Mr. Thomas who answered, but as I understand it, and I'll pass to Mr. Thomas, is we have a live scribe when anyone is in the resus bay.
Yep.
So it's minute by minute live scribing
Yes.
of what's happening.
Okay. And that's, there's obviously the live scribing notes there, but a lot of the clinical notes that were put in by the clinicians are retrospective, is that correct?
I can answer that. Yes, there are some notes that are retrospective, and as per our expectations, they are documented as retrospective,
Okay.
to show that they have been. They weren't
Obviously, I'm aware
contemporaneously.
because I've seen the notes. I just wanted you to confirm so that everybody was of the same understanding of where we were. Now, given that they were retrospective, you would be aware, correct, that the family has indicated that there was a period of time where they were in the resus room without 3 of your clinicians who indicated on their records were in that room. Is that correct?
What I can see from the clinical notes that are documented is that...
Let me stop you there, sorry. I'm aware of what the clinical notes say. What I'm saying is that you are aware that the family have indicated on numerous occasions that they were in the room alone without the 3 clinicians that have indicated on the clinical notes that were retrospectively done that they were in that room alone. Are you aware of those claims?
I'm aware of those comments from the family, yes, as part of the open disclosure meeting.
Yes, and they made that clear to you in that open disclosure meeting, correct?
That's correct.
Right. My colleague asked about the CCTV, and you indicated that whilst the entry and exit of that resus room are not really covered by that CCTV, you confirmed CCTV footage of that area, correct? General area, I'll say.
No, that's not correct. There's 2 CCTV cameras in the emergency department. The first is in the waiting room that is physically and geographically separated from the resuscitation bay.
Yes.
The second is at the bottom of a corridor, which is next to what we call the fast track area. Again, that is geographically and separated from the resus bay that is actually at the opposite end of the emergency department.
Okay. So, being made aware that the family indicated to you that there was not the 3 clinicians in the room who the clinical records indicate there were, what investigations did you do around seeking to investigate those claims?
So the concerns from the family about, or the escalation from the family that there was nobody in the resuscitation room was part of the open disclosure meeting. The notes that have been documented retrospectively have been documented just after the resuscitation, so sometime prior to that. In terms of one of the doctors, for example, who had documented those, no longer worked at Northern Beaches and was no longer available to us, had gone back into New South Wales Health.
Okay. So, I think from your answer, and correct me if I'm wrong, you've indicated that you've looked at the clinical notes. Did you interview those 3 clinicians at all and ask them at any time, did they leave the room?
I did not personally, but the SATIR team, the investigation team that conducted the SATIR, interviewed the clinicians involved in the care of baby Joe, and also other people who were in the emergency department. That's part of the SATIR process. As I mentioned, that is done under privilege, and I haven't had and wouldn't have access to those interviews.
Okay. So, if I've understood you correctly, the family has indicated that they are concerned that they were left alone in the resus room. You're aware of those concerns. They've then been aired, I'll say a couple of weeks ago again, into the public domain. You've not sought to investigate that by interviewing the staff. You've not sought to, investigate it by reviewing the CCTV. And by that I mean, if there was those staff members anywhere on CCTV, whether it be in the ED area or in the waiting room area, etc., at the time that they were supposed to be in that resus room, they're clearly not in the resus room, are they? Have you done any of that? Have you reviewed the CCTV to see if any of those staff members that were supposed to be in that room are visible anywhere on that CCTV?
I have reviewed the CCTV. I have seen the CCTV. I think 2 points just for clarification. The CCTV feeds auto-delete after 30 days, but CCTV footage relating to baby Joe was duplicated and recorded. Again, I think one of the important things, if we look at the physical footprint of the ED, and happy to provide you with plans of the ED, where the 2 cameras are located. So if you think about the first in the waiting room, so any staff members who are working clinically would not be in the waiting room space, they would be in the main part of the emergency department. And as I said, the corridor camera just looks at one single corridor in the emergency department, and we have not seen the members, and we do not have confirmation that those staff members were not in the emergency department.
So, just to be clear, can I confirm you have reviewed the CCTV footage from the period where Joe and Eloise were in the moved to the resus room, and 10:47 when the resus was called? You've reviewed that period of time, and you've not seen any of the staff members on that CCTV that were supposed to be in that resus room?
Just to clarify, the CCTV footage that I have reviewed are 3 clips. The first clip is when Eloise and Joe arrived in the emergency department waiting room and were triaged. The second is the transfer to the paediatric ward, which is captured from the corridor. And the third is the time when baby Joe was transferred on the bed with his mother from peds to the corner, which went to the imaging department. That is the only CCTV footage that I've been able to see.
You said that all of it was all of the CCTV duplicated before the 30-day erasure?
I'm not aware of that was part of the SAIA team, the lead for the SAIA team. What I have seen are the clips that had baby Joe on those portion of the clips. My understanding is the rest of the CCTV footage at that time did not have that. But again, I would need to take that on notice. I can only give reference to what I have physically seen.
Has the family asked you to view that CCTV footage?
The family have not asked me personally to review that CCTV footage.
Let me rephrase. Mr. Horan, Mr. Laspina, has the family asked Healthscope to review that CCTV
yes,
footage?
as part of the open disclosure. I understand that was part of the open disclosure.
Have you permitted that to occur?
Due to, and we've looked at it to ensure we can allow that to happen, and our advice is that for privacy concerns, in terms of the legislation that's in place, we're unable to allow that to happen.
Okay. If the Northern Sydney Local Area Health District was to ask to review that CCTV footage in order to ensure themselves that they were confident that there was no issue, would you release it to them for their
We will
viewage?
comply as long as it's legal. I will comply with a request for that, most definitely. I would
Adjunct
also
Professor-
like to add,
Yes, go on.
that we are undertaking a broader independent review of our emergency department that will look at a longer period of time, and will look at a broader range of measures across the emergency department, not just this tragic incident.
No, I appreciate all that. What I'm doing at the moment, and I will come to those issues. Unfortunately, I only have very limited time, given that I've only got a 20-minute block, but I will come back to that. Adjunct Professor Shembri, do you think it's appropriate that you might seek to ensure that the family's concerns are thoroughly investigated, and that you request the CCTV footage from Healthscope so that you can assure yourself that that everything has been done to see if the family's concerns are addressed?
As part of our commitment to ensure the incident management policy is adhered to under the ministry policy, we have a number of levers that we can pull, including requesting additional information.
Okay, well, I'll leave that one with you, and I'm sure that if you're not responsive to me, I'm sure that Minister Park will perhaps speak with the family.
Mr. Fink, can I assist you briefly?
Yep.
I can confirm that we have instructed a review with a team that has been compiled by New South Wales Health, including external representation from interstate.
Yes.
As part of that review, I'm happy to request that the CCTV is considered.
Ms. Pearce, you never fail to uplift me. Thank you very much.
I'm happy to assist you at all times.
I appreciate that. Thank you. I just want to go back to some of the answers you provided to my colleagues earlier as well. You indicated that at 8 a.m. you had 3 specialists starting. Now, those 3 specialists that you indicated, are they all ED specialists that we were talking about?
That's correct.
Okay. In addition to the 3 ED specialists that you have, can you confirm whether you have, and I imagine you do, a PEDS team, a surgery team, or whatever? Did you have a PEDS team on the hospital in the paediatric ward at the time?
Yes, the paediatric services staff 24/7.
Yes.
So there's a presence on site, and yes.
And so it's usually a reg that's on, overnight, and then perhaps a consultant that comes in the morning as well?
At the weekend, we'd have a most nights we have a registrar. We also usually have a second trainee, so one more senior, one more junior, usually advanced trainee, and then consultants would come in around, and as a rule they would start at 8 a.m. For the rounds on the weekend.
Yeah. So I'm fortunate, obviously, to have had access to the notes, and I can see that at the resus there was a PEDS reg, and as well as a PEDS consultant who were in attendance. They did arrive 6 minutes after the code was called, so that's by the by. But is it usual procedure that when a family comes in at say 7:30 in the morning that you would not the on call, not on call, but the in-house trainee who was from, I believe, one of the other Sydney hospitals and was doing rotation into Northern Beaches, wouldn't seek to consult with the paediatric reg or somebody else within that paediatric team, given the amount of time they were there, or to let them know that they had a patient that was in the ED. Is that usual practice for you?
If we look at, for example, 2024, Northern Beaches had more than 14,500 paediatric presentations to the emergency department. Not every one of those presentations would be referred on to the paediatricians.
Absolutely granted, that's the case. However, I understand that morning, and as I said, I'm fortunate enough to have had the opportunity to sit down with Eloise and Danny yesterday, and having spoken to Eloise about the busyness of that ED at the time, my understanding was in the waiting, in the behind the curtain, shall we say, in the ED itself, in the waiting area, was Eloise and Joe, and another two teenagers. But other than that, the beds in the ED were effectively empty. Other than I'll say the two groups, but group one being Eloise and Joe, and the other group being some teenagers. How is it that when you've got such a relaxed time in the ED, it's not like you've got somebody in the resus and there's all the chairs are filled in the waiting areas waiting to move people around, that they've come in at 7 a.m. and for the next 3 hours effectively you've got a mother that's begging in effect for help, and nobody thinks to call the PEDS team, thinks to call the PEDS consultant, thinks to call one of the ED consultants. I know not one of the ED consultants, you had 3 on in the day. Nobody came to see and help that family. How did that happen?
So Mr. Fang, I would say a clear causation factor in the SAYA report was the lack of that escalation, and the lack of escalation being listened to both from Eloise and also internal staff, and also a clear recognition that whilst the REACH program was in posters, it wasn't made aware enough of the family so that they were aware of their ability to escalate to a third party to ensure Joe received the care that he needed. So we accept that recommendation in the SAYA report.
Yep. Sorry, I've only got a minute left, and I'm going to run out of time, but I want to go through another few things quickly. The REACH protocol that you speak of, I think I heard somewhere in an answer to one of my colleagues that it was a passive protocol.
Yes.
Were any of your staff, either nursing or in doctors, provided training around this REACH protocol? You obviously were signatory to it. You had signs up in the ED. Did you provide training to any one of your clinicians around this?
In terms of education, when we put the REACH programme into Northern Beaches, there was education across both nursing staff. It's also as part of the junior medical officers orientation. It's part of that, and it's also part of our SIRS, which is our emergency response.
Okay.
I think.
Sorry, I've only got 12 seconds left. I just want to double check on a couple of things. Have you read the Northern Beaches inquiry report that was released in 2020?
I have read parts of it. I've not read the complete report.
You're the medical officer for Northern Beaches Hospital. We released a parliamentary inquiry into the hospital outlining a number of issues, including IT issues, including the accreditation issues of staff training, which it sounds like there might be still a few. We talk about a number of cultural issues in the hospital. You're in charge of the clinical services at that hospital, and you haven't read the complete report?
I've read all the recommendations. I've read the majority of the report, but as I'm on oath, I haven't read every single page.
Mr. Warren, have you read the report?
I'm aware of the report.
You're aware.
And I have read the recommendations, and I have read parts of the report. I have not read the full report.
Mr. Spina, before you start, are you going to commit to me you're going to read that report?
Given that prompting, I'll commit to you that I'll read the report.
Thank you. I'm out of time, unfortunately.
My questions are for Mr. D'Amato.
Good afternoon.
I'm seeking some clarification on the cost of the Nurses and Midwives Association wages claim. That's been cited by the Premier as $6.5 million. He also thinks that nurses make $90,000 a year. The association and the Deloitte report have cited $863 million. There's obviously an order of magnitude difference between those two figures.
Absolutely.
Could you explain where the 6.5 billion figure that the Premier is citing
The
has come from?
association's number reconciles with our estimates, but is for 1 year only. So once you carry that forward over the 4-year period, that's where we're talking about the 6 billion. So that's essentially that's the main difference.
Yeah, so you're putting my mental arithmetic on the spot here, but 863 million times 4 isn't...
You have to add also escalation and the value of additional nurses that we might plan to add. So that's all form part of the estimates that we provided.
Okay, so can you explain in more detail the nurses you plan to add? How did you factor that into calculations?
I found the details, but effectively the 890 from memory, happy to provide some more details, reflects the additional cost of bringing the whole claim for the claim they put forward for 1 year only, so 12 months.
Yeah.
So effectively, once that is in place, and assuming that is then applied ongoing, that's where the additional funding is required.
Okay.
So that's mainly the difference is in the assumptions.
This is what I'm trying to get to the bottom of. So what assumptions did you make about the total number of nurses being funded over that 4-year period?
Look, I'm more than happy to fund the details, but the main difference between the Deloitte's exercise and our costing is that Deloitte's quoted only 1 year.
Yeah, I'm happy for you to take it on notice and provide the detail, but given that number isn't just 4 times the original number, I'm interested in that you've mentioned the assumptions that were different that explain that difference, please.
Happy to have a look.
And happy for that.
Could I add as well that there are other elements in the claim that have been made, salary packaging, and other costs associated. So I think the numbers of staff is one element, but there are other elements always we have to factor into the escalation over time, other on costs that are attached to staffing. So we can break that down for you.
I understand that. That's my request. So if those other on costs were included in your estimate, can you please detail what those were?
Yeah.
Thank you. Got some questions probably for Ms. Pearce about the sustainability initiatives by the Net Zero unit.
Yes.
Could you provide an update on where that's up to?
We might be able to give Mr. Daly his first opportunity for a contribution to today.
I apologise, Mr. Daly, over to you.
Oh, I'm not sure, Dr. Callan. Where can I start? I've got the privilege really of leading New South Wales Health as the biggest polluter in New South Wales government, and we acknowledge that. to kind of pull our weight. And I think we've done an enormous amount of work in probably what's frankly the low-hanging fruit, particularly around infrastructure, off-grid power, transport mechanisms. But really the next big step for the emissions process that we have to work on is really change of clinical models of care that are driving emissions. We've done a lot of work around moving away from certain gases in anaesthetics that are highly polluting, and we've virtually taken that, well, we have literally taken out of the New South Wales formulary, and so it's not available except in the absolute rarest of cases. We've set up only just now, probably a national first, around setting up, with the support of the Secretary and Alpha, 10 multidisciplinary hubs focused on those clinical specialties, medical, nursing, allied health, to drive model of care changes that are going to deliver decreases in emission to get us hopefully to our 50% target and then zero target in the longer term in the variety of specialties, in anaesthetics, ICU, theatres, and then the various specialties that make up the bulk of our emissions. We've identified and measured where those emissions are coming from. We have 18 key targets. We've done modelling on 2 hospitals, one rural, one metropolitan, and applied the measuring methodology, which is one of the really difficult aspects of the whole net zero exercise. But we've been well supported to be able to identify across those 18 areas of our core business the types of reductions that we have to deliver. So I can talk under wet cement about this, but I don't want to.
Thank you. I've got some more specific questions. I'm really pleased to hear those gases are out of the formulary.
Yeah.
Thank you. I wanted to ask more specifically about waste production, so specifically single-use plastics and clinical waste. How are you tracking or measuring that at the moment?
We've got really solid partners within New South Wales Health, Health Share, that are obviously big users of single-use items, whether it be in food services, in sterilising, and they similarly have targets of reduction. They are moving incrementally through their processes, moving towards back, as I recall, having CSSDs that manually sterilised all manner of item that over the last couple of decades we've moved to single use. So certainly we'll be looking at a shift away from goods and services expenditure for the purchase of single-use items that eventually end up in landfill into kind of salaries and wages in order to sterilise and get multiple use out of that. Similarly in food services, there's major programs around waste reduction in particular.
Could I ask you specifically about supply chain and procurement, particularly for those single-use items? Is that a barrier that's being looked at?
Yeah, we've started meetings with pharmaceutical firms and the major suppliers to New South Wales Health. We've also approached Private Hospitals Association because we're going to have exactly the same issue, and to have a bigger bang for your buck in terms of engaging with health suppliers. New South Wales Health is a big entity, but to do it in tandem with the private hospital sector, who will ultimately have the same obligations placed upon them that we will. We've started those conversations with the sector, essentially maybe taking a step beyond our remit at the moment, but putting on notice that government's expectations will be that that they'll need to also give guarantees around their net zero emissions with the supply of our items. And I guess New South Wales is so big, we can look them in the eye and say, we're giving you plenty of notice, so don't turn around in 3 or 4 years' time and say, yes, we can do it, but there'll be a price increase of X. We've learnt from international experience, particularly close partnership with the NHS in England, that with plenty of notice and right across Europe, that those industries, they put on notice and that they do not expect and have not necessarily been receiving price increases for them supplying goods and services with a net zero impact.
Is there any flexibility for local health districts or individual hospitals if they're choosing or wanting to choose a more sustainable option through procurement to have an exemption from statewide contracts?
Sorry, the pause is about the capacity to move off state contract. Certainly, we've got one of our leading chief executives right here, actually, in the net zero space in terms of Anthony and Northern Sydney local health districts. All chief executives and their boards are all very committed and working to this. And they're pushing themselves because their circumstances are different given their different infrastructure and mix of services. So there's a lot of work that goes locally, and we're about to go into the third year of innovation funding to fund source projects out predominantly in the districts. Some may be in the ministry, but predominantly in the districts where most of the pollution actually occurs, to fund pilot projects for which we can then apply system learning. I'm not aware that we've seen any request for purchasing off contract. I'd be very happy to take that on notice because philosophically it'd be something I'd support, but I don't want to get in trouble from Mr. D'Amato either.
Thank you, and I don't disagree with your response, but I'm interested in those LHDs that have been particular leaders. You know, we talked about Hunter New England last year, that
Yes,
they have the flexibility to lead and are not restricted by statewide contracts. I appreciate you taking that on notice.
Sure.
Thank you. Ms. Kate Fairman.
Is there an update in relation to the PFAS testing that local water utilities have undertaken in terms of how many have been tested and what the results are?
Yes, I understand that New South Wales Health requested that all local water utilities publish the results on there for their local communities as their responsibility. And then I believe there's a Premier's there's a website that outlines the summaries of the findings in relation to those that have exceeded. So I'm happy to provide that to you.
Do you know kind of offhand?
So in general, there's been very few exceedances of the levels. I can just bring up the graph. There's certainly been one in Southern. There's been, but they've been publicly announced, and I want to acknowledge the work that the communities have done in terms of the local water utilities, but also the other government agencies in supporting local communities to develop short-term solutions. So I'll just call up the note with the names.
Can I just check as well with this? It's my understanding that New South Wales Health has made the decision to recommend that local water utilities publish the results but not direct them to publish their results. However, it is within New South Wales Health's remit if they chose to direct them to. Why was that decision made?
I think it's always best to, I would have no doubt that local councils, if presented with the need for transparency, would accept it. And so clearly that was we have the capacity to direct, but wouldn't it be better to achieve that through highlighting the importance of it? Because I would suspect that most local councils who run water utilities are there to serve the population. So I really did not have any view that a local water utility would not publish the results, and there's a range of results that we want to be transparent about. So that was the basis of why we asked them to, and they have done that.
Okay, so so you're monitoring to see whether there's any that are tested.
There's no issue that the communities have proactively we've accounted for all of the water utilities, and they've all been tested, and the advice has been provided to those communities. And the results have been on the websites.
What did they test for?
They tested for the full range of the PFAS chemicals, the PFOA, PFOS. I can give you
PFHS, and is that
they tested for the four of them.
Four.
Yeah, 3. And I can provide you the methods that were used. Sydney Water Lab was doing that. We permitted them to use some of the. I think we ended up repeating all the testing because some of the others had used other accredited laboratories, but the level of detection and the rate, they hadn't tested for all of the chemicals, we'd ask them to do. So I'm happy to provide that for you.
Okay, yeah, that would be great. Thank you. So just sticking with testing, apparently Sydney Water is testing for a suite of 45 different PFAS chemicals. Are you aware of that?
My teams are probably aware of the testing regime, but I'm happy to follow that up.
So this came to light during the PFAS inquiry when I was asking Sydney Water what they tested for. So when asking whether they make the information available to New South Wales Health, Sydney Water replied, no, we have a meeting with New South Wales Health where we discuss unusual, like how the results are going and what our monitoring results are like. We're not actively handing over Excel spreadsheets. Then, to clarify, I asked about the 45 chemicals and they said, no, we're focusing on the chemicals that have guidelines limits, so only 3. But they're testing for 45. Do you believe that information should be going to New South Wales Health for New South Wales Health to make it have a view on the chemicals that they're testing for?
I think that there would have been technical discussions. Our teams, we've got a number of teams of technical experts within our water unit, and we collaborate very closely with Sydney Water. We have a series of committees, such as the Joint Operations Committee, where I'm sure all of this would be discussed. Happy to double check and confirm that. I think we don't need, not to put myself in answering that question, but I think what they were actually conveying is we don't give them, where there's no exceedances or where there's no action, we will brief you intermittently, and that will be done in a more comprehensive way rather than every time they've got a result they'll send it to us by an email. That's probably not the best
Is there
system.
work being done? Because I think one of the issues here, of course, is, and what international jurisdictions are increasingly focusing on is, as PFOA and PFOS are phased out and are being not used, and the people's blood levels are going down, that's going down in some parts of the environment, that there are other chemicals, of course, that are now of concern. What work is New South Wales Health doing to keep abreast of chemicals other than the 4 that the Australian Drinking Water Guidelines is referring to? An example is Gen X, which the Australian Drinking Water Draft Guidelines are saying there isn't enough information, but the US and other jurisdictions believe there is, and they are actually putting in place, limits. So how's New South Wales Health keeping abreast of new emerging PFAS chemicals?
So we've got a range of specialists in water. They survey the international environment we have in terms of emerging moves by other international entities. We also actively participate in joint working groups with our colleagues in the water industries, who are also responsible as water suppliers to be abreast of the information. We have regular interaction with our water authority, so I'm happy to take that issue around the Gen X and what people's thinking about it, but I think, as you indicated, the current position is that's not routinely monitored for.
Yes, and you mentioned before if certain chemicals exceed the guidelines. I think the issue is with the 42 or whatever they're testing for. So they're testing for 45 PFAS chemicals, and increasingly in other jurisdictions they are testing for a lot more. That there are no exceedance guidelines. We don't know, so they don't know what to report to New South Wales Health in terms of being concerned.
I would say that again, the technology that I would have to follow this up, but the technology employed to remove the interactions in the cascade I will have to get technical information, but the technology often will remove other chemicals as well. So I think some of the mitigants to ensuring we've got safe water for the chemicals we know about and the chemicals that are unknown. But I do assure you that we are, watching actively in this space.
And another thing that a lot of people have put to the witnesses, including local water utilities and what have you, councils have put to the PFAS inquiry, is the need to stop PFAS at its source.
Yes.
That this is a question I will clearly put to other agencies. But is New South Wales Health involved in any recommendations or advocacy in that regard around the need to stop PFAS in products? Again, a lot of jurisdictions are doing this. I know this is a federal level, federal issue, but in terms of the work that New South Wales does with the NHMRC and other bodies, is there anything that New South Wales Health is looking at?
Well, certainly we are probably taking a look at how we're learning from the cases where the PFAS has got into water supplies, particularly where it's a bit unclear how it has. And so, you know, some of the things are around how waste disposal areas and other things can get into the water supply. So I think our focus is probably on actively looking at those pathways from which water can be contaminated, and, you know, better understanding risk profiles. There is a move to remove PFAS from, and we would support that, given, you know, it's a ubiquitous nature. It doesn't break down easily. For all of those reasons, when there's an appropriate substitutes for it, we totally support its removal. But as you pointed out, those are matters really that need to be dealt with, you know, the Commonwealth in terms of that regulatory framework.
Although some states in the USA are dealing with it at a state level, I will add that. But can I just, the NHMRC, the guidelines, we spoke about earlier when the Minister was here, the guidelines that were released in January last year from the N-Health guidelines.
So there's two different guidelines.
Yeah, that's what I was about to ask you to clarify.
So basically, N-Health is the states and territories environmental health. So it's a group
that's the guidance you need to rely on to.
I know. So there's two different things we're talking about. So the N-Health is a subcommittee of the Australian Health Principal Committee.
Yep.
And it's got the experts from states and territories in relation to environmental matters. For some things that they will commission work where they need to bring on additional expertise. Traditionally, they've done work in asbestos and did do some preliminary statements in relation to PFAS. What we were referring to for most of the discussion this morning was the NHMRC drinking water guidelines, which is part of the standardised methodology the NHMRC does to review the guidelines. It sets national drinking water standards, and then states and water authorities adopt those standards. And that was the document that was released last year in a draft form for consultation, and then it will go through the process of NHMRC releasing that in full. I'm just conscious that there is a draft out there, but you know, we are cognizant of the new and reduced standards, and that's been the lens we've applied to the drinking water testing as well, with being very much around the current but also the proposed standards.
Thank you.
We'll go back to the opposition. Ms. Connor.
Dr. Chant, given what's occurring in the Northern Hemisphere with their flu season, what's the current outlook for the 2025 flu season in Australia? How severe should we expect it to be?
I think we can't directly impute what's happened in the Northern Hemisphere, but obviously we've got to be minded to the fact that that's one factor that gives us cause for concern that we may be experiencing a greater flu season. Some of the considerations we have is that we've also been seeing flu seasons occur a bit earlier than traditional, so that means that we have to plan for earlier, get our messages out in a more timely around vaccination. At the moment, currently, flu activity is low. We are seeing a bit of an uptick in RSV. We do put out weekly reports that provide an idea of the community transmission levels, drawing on multiple data sources, and that looks at particularly COVID, RSV and influenza, but it does touch on other respiratory viruses so that people are aware of the level of risk. Every year we do planning across our systems for surge planning, and my colleague Dr. Mr. Matthew Daly does that from a systems perspective in looking at what safeguards. Our focus is trying to support vaccination uptake, particularly, as I indicated, amongst the vulnerable groups. We've got a media and communication strategy that's being
just
developed.
with respect to vaccinations, how many doses of the vaccine has New South Wales Health been able to secure?
So there's no issue with supply. We have adequate
Okay.
supply of vaccine. The vaccine that's funded for under the National Immunisation Program is procured by the Commonwealth Government. There are no supply constraints, and supplies. And separate to that, we purchase vaccine for our own healthcare workers. And again, I just want to stress there are no supply constraints that we're anticipating in relation to the flu
Great
vaccine.
news. And do you have a figure for how many doses of vaccine you anticipate you will be administering?
I can take that on notice.
Thank you very much. And what was the cost of the free influenza vaccination program in 2022?
I can take that on notice as
Thank
well.
you very much.
I
And-
think one of the other interesting aspects that program raised was the fact that we don't have a system. Generally, we do not fund. We enabled that for general practice and also for pharmacists. The issue for the pharmacists is, unlike the Commonwealth, we don't have a mechanism to directly pay pharmacists. And so that did require some quite expensive workarounds, and I've got to say the goodwill of some of the Pharmacy Guild and others to support us with some of the IT.
Yes.
But the compliance and that, so the costing I give you will put some caveats around it that it also probably doesn't reflect the true administrative burden. And I think if there was a decision made that was beneficial, depending on whatever the settings, it would really be important that the Commonwealth
was involved.
It was involved in that, particularly given that they have instituted a payment for pharmacists to vaccinate using the NIP vaccines.
And so what's the cost to the New South Wales budget through health costs and lost productivity for every 100 cases of influenza?
Look, I just couldn't answer that on the top of my head. I know that
If
there's
you could
been
take
an
it on
audit report, and clearly, influenza is a serious condition. Yeah.
Thank you. Ms Pearce, I have a couple of questions for you in relation to childhood dementia. How is New South Wales implementing the National Dementia Action Plan, ensuring the needs of the priority problem children are addressed?
I would have to take that on notice, I think,
Okay.
Mrs Carter, if that's okay. Yeah,
Right.
I don't think I've got anything with me that goes specifically to the childhood element.
The New South Wales Agency for Clinical Innovation released a roundtable report last year on childhood dementia. It makes 5 recommendations or summary outputs. Are they all being progressed?
Very happy to get Dr Levesque to provide you that on notice.
Right, thank you very much.
Thank you, Chair. If I may, just to Professor Thomas again, just one more follow-up, if I may. Once Joe arrived to that resus bay 3, what staff provided Joe with care prior to the cardiac arrest at 10:47 a.m. from the moment he arrived in the resus bay?
I'm unable to answer that question in detail because I don't have the clinical notes in front of me. What I do know is that I looked at the resuscitation record and noted those, the names that were ascribed to the particular roles, which is part of how we record a resuscitation in the emergency department.
Okay, so will you be able to provide that information to this committee in detail about what was the care provided and who were these staff?
I will take that on notice and see what information I can provide to the committee.
All right, thank you. Can I just ask Ms Schoolander, just coming back to the hospital, Bankstown Hospital, you mentioned earlier that the $1.3 billion, I think, wasn't enough for the new Bankstown Hospital. Can you confirm the new hospital will be still going ahead and how much the new hospital is now estimated to cost?
In terms of the progress there, and we're certainly working at full momentum to move that project forward. We're working on the basis that government will need to make some decisions over the next period, and as mentioned, I think the cost escalation has had a huge impact on construction across the state, as you'd be aware. $1.3 billion used to buy you quite a lot and doesn't buy you very much anymore. In terms of the dollars, I can't provide that information because it's cabinet in confidence and it's going through a process within government. But certainly that decision making isn't slowing us down, because in parallel we're working with TAFE on the relocation from the site and looking to start demolition on that site next year.
So to just be clear, and not to paraphrase, but it's you're clear that it is going ahead, or is that cost blowout a go, no-go decision, given that you can't, it seems, you can't reveal the number, but it seems to be significant?
Yeah, it's significant. I think in terms of the going ahead, I don't have any information to tell me that it isn't, because I'm working very hard on it and I've got a team of people working very hard on progressing that project. I think the scope of what it goes ahead with is what's in question in terms of the available dollars.
Okay.
And Ms. Wood, I can confirm the government has confirmed that the project will go ahead.
Thank you, Ms. Fiss, that's helpful. So then, in relation to that, then what specific new facilities will be built at that hospital, and does that include expansion of to the number of birthing rooms and assessment room located at the hospital?
In terms of the exact scope of the project, I'm not able to confirm that at this point in time, because the options presented will determine that. The clinical services planning work is being undertaken by the local health district. Clinical services planning will drive the outcomes of that in terms of the determination of the scope. So in parallel, we develop the infrastructure plan, and the two come together at a particular point in time. So the options provided as part of this next process will determine how much can fit within the envelope. So I don't have the scope to be able to provide to you at this point in the program.
How many options are there?
I'd have to take that on notice. So it's essentially a draft strategic business case, which is a standard process that we would go through. So as we develop any hospital redevelopment, we'll look at do nothing as an option, and then we'll look at deliver absolutely everything we possibly can, and usually there's 3 or 4 options in between that. So that would be, you know, a standard process that we've gone through, and there's a draft strategic business case for this project.
Could you confirm then the number of birthing suites and maternity beds that would be available following the redevelopment, and how that compares to the current capacity?
I won't be able to confirm that until after that scope's been determined, and after the sort of way forward for the project's been determined.
All right, and then how will the upgrade address the concerns about bed shortages and overcrowding in the maternity ward, particularly given the growing population in the Canterbury area?
I think certainly all of our redevelopments are built on a very strong clinical service planning foundation. So the clinical services plan development will review the population demographics, the current constraints of the site. There's community consultation generally undertaken as part of that process. That part is a matter for the local health district. We will then pick up the recommended sort of scope from that and work out what we can deliver within the funding envelope that we have.
Has that scoping been done? Surely that's formed part of the options.
It has formed part of the options, but that clinical services planning is sort of a work in progress in parallel with that options development.
Well, then should the site still be built on that? Should the project still be built on that site then?
It absolutely went through a very robust process in terms of determination of the site for the hospital, and it was the recommended site by Health Infrastructure in consultation with multiple parties at the time. I think it is a great site for redevelopment in Bankstown. It's adjacent to the new Todd location, and I think it will be an appropriate site for us to move forward with, yes.
All right, and then is de-scoping on the table for this hospital?
I don't think that there's a scope that was originally determined to be able to say what we're de-scoping. So that's not answering the question exactly, but I think options within, you know, delivery of the full clinical services plan, and we usually sort of work backwards from there across every hospital redevelopment. We're doing that at the moment, and we're coming up with the scope that is going to get the best bang for buck. It's very, very rare that we'll be able to deliver a full clinical services plan in a single redevelopment. So I anticipate this will be one of those that we won't be able to deliver the absolute full clinical services plan to a point in time, but we usually prioritise and then look at, okay, well, what can be developed as part of a subsequent stage. It's a very standard process.
So you've said that a business case would be finalised by the end of the year. When you said that, did you mean a strategic business case?
Did I say that today?
Mm-hmm.
Or was that from the last
Previously.
estimates? Yeah, so the strategic business case is what's been developed, and that's what we've submitted as part of this budget cycle. It's going through that process in government.
Yep. So you can't say, and I'm not being disrespectful, I'm just trying to
No.
understand it. You can't say how many options, you can't say the costing, you can't
No,
say the
because
timeline, you
as-
can't say the business case.
No, because as with everything that sort of goes into
No, I understand.
the budget
I understand cabinet
process,
confidence,
it's cabinet in confidence.
but there's no scoping that you're able to assist the committee with.
Not at this point in
any
time,
way.
because it needs to pop out the other side of that process to be able to talk about it.
So a thought bubble of a hospital. All right. Can I just go back to health scope, please? Actually, sorry. No, I'll go back to. Did you finish, Lou? Yeah. Okay. Yeah. I've
Ms.
sort of done
Pierce,
it.
if I could ask you a couple of questions about Canterbury Hospital.
I've done Canterbury.
Oh, you've done
Actually,
them?
yeah,
Sorry.
yeah, yeah,
Okay.
yeah.
I can add
I have a
in the
couple
question
of
about
questions
the
about
CT
Canterbury.
scanner, though, if you wanted
Sure.
the specifics. A very short period of downtime there, I'm advised, and one patient was required to be cared for at Concord. As a result of that, no patient impacts whatsoever.
Okay, I might just continue on Canterbury then, just in relation to that project. So what specific new facilities will be built at the hospital, and does that include expansion of the birthing suite and maternity?
I don't know, Emma, if you know that. I do know, speaking to the Sydney LHD Chief Executive earlier this week on other matters, we talked about Canterbury and the consultation process that's been underway with the community, which I understand is going very well. But Emma, did you have any specifics?
Yeah, I think the Canterbury redevelopment is in progress at the moment. We have released the master plan recently and clinical priorities there. So I think that was recently made publicly available.
Yeah, sorry, no disrespect, I've got a couple of minutes.
Carry
I
on.
can see that stuff
It's
online. I
it's
just wanna know
publicly
from you
available.
what specific new facilities will be
The documents are
built
publicly
there?
available.
Yeah, and so what specific new facilities could be built there?
So the list of the scope there that has been released is a new and expanded and enhanced intensive care unit, new purpose-built inpatient accommodation, expanded emergency department, additional surgical theatres, improved and expanded antenatal care, additional ambulatory and outpatient care capacity, and other clinical and non-clinical enhancements to the existing facilities supporting changes of models of care.
All right, and in relation to the number of birthing suites and maternity beds that will be available following that redevelopment, how does that compare to the current capacity?
I will have to take that on notice.
Is it increased? Is it decreased?
There isn't maternity.
We'll endeavour to find out for you before the end of today if we can.
Within that list of priority scope, there is not an increase in birthing suites.
So no increase in that current scope?
No.
Thank you. And sorry, one last one, then Ms. Cutter will have some questions. So how would that address the concerns about bed shortages and overcrowding in the maternity ward, particularly given the growing population in the Canterbury area?
I think it's a question I have to direct to the local health district in terms of their service priorities, because they're responsible for the service planning, so we can take it on notice and come back to you.
Yes, please, or we'll have to call them next time to come back.
No problem.
These questions are probably for Ms. Pearce or Dr. Chant. In relation to the annual report of the VAD board, the median age at first assessment is 75, and 5 cases of duress were identified during the reporting period. What training is being provided to doctors to detect elder abuse?
Thank you for the question. Important topic. Dr. Chant will be able to assist with that one.
So I think the fact that that was identified as a reason is actually stresses that the training is very significant. So the clinical practice guidelines and the trainings covers that this is a voluntary, it's got to be self-initiated, and that's stressed in all the training. So I can provide the details of that, but it's extensive.
If you could on notice, I'd be interested.
It's extensive
Thank you.
around that. And we also, if other people become aware of elder abuse, there is navigation tools on our website to notify it as well, even outside the VAD program. It's a significant issue.
And is it possible to get a copy of the guidelines that are required by Section 181, subsection 2 of the Act?
Yes, certainly happy.
That'd be great, thank you. This report, like the interim report, still shows a much greater number of requests coming from the regions, despite the population mix being 2/3, 1/3. We've still got almost the inverse. It seems to be a consistent pattern. What is this disclosing about the availability of palliative care in the regions and indeed the availability of primary care? Is any work being done to check that we actually have a quality of access between the regions and the cities? Because the report suggests otherwise.
So from a voluntary assisted dying perspective, I actually think the data is very supportive of the efforts that the districts have put in place to ensure access, and also to commend Mr. Shembry, who also runs the statewide navigator service, which actually is able to fill any gaps in rural regional. So from the get-go, in terms of the design of the program, it was really designed to ensure that there was equal access. So I think that's a testament to it. We do know that age distribution of populations does vary, and obviously the older you are, the more likely you are to have underlying health conditions. We do, however, know, and this is a real focus for us in a rural health division, but also from a population perspective, that some of the risk factors, such as tobacco smoking, obesity, are higher in those areas.
With respect to those risk factors distributed differently in the regions to the city, and if they are, shouldn't health resources be distributed differently in the regions to the city?
And certainly that means that we are having a strong focus on our regional communities to ensure that there's support for lifestyle modification programs. We monitor all of our programs to ensure that there's equal, if not more, uptake commensurate with the underlying need in programs. So that's a strong focus. That equity doesn't mean equal access between the groups, it means commensurate with your underlying need.
Very quick one about the navigator service, because I didn't realise your role, Dr. Shembry. There have been press reports that doctors have been flown up to patients in Lismore as part of the navigator service. Is that correct?
I can probably answer that, but also Anthony can. The navigator service was set up with recruited a number of doctors.
With respect, I'm conscious of the time. I really just wanted to know whether we had doctors being sent all over the state as part of the navigator service.
Yes, that's correct. Where
would I find the costings for that? Could you provide those on notice, perhaps? Thank you very much.
That's fine.
Okay, my colleague.
Thank you. Just back to Northern Beaches, if I may, Professor Thomas. Just one further question. Is it concerning to you in these circumstances that you had an ED trainee doctor who repeatedly fails to initiate basic life-saving treatment for himself? From 10 a.m. onwards, he knows, and nurses know, that Joe is so peripherally shut down that they can't trace a pulse, yet no drip is provided while he's alive before that cardiac arrest.
Yes, it is concerning, and for that reason, we have the findings of the SARE investigation that have demonstrated a failure to escalate. I think I'd just like to say also, there's a lot of questions that that Joe's parents asked as part of the open disclosure meeting that we haven't yet met with Joe's parents to answer some of those questions. I think that's important, and we'd be obviously happy to meet with them further.
So you'll undertake to do that with them as soon as possible?
Absolutely, and that's part of the process. I know the
as soon as convenient to them.
Sorry.
As soon as convenient to them and possible.
Of course. And just by way of notice, if I could, you did ask me earlier about a lower, did the patient have a lower caesarean section?
Yes, thank you.
I just want to clarify that there was a call for a caesarean section, but the delivery was by a different method.
Sorry, who called for it though?
There was a request, there was an expectation of a lower caesarean section, but there was, the delivery was actually by a different method, and I wouldn't go into more clinical details to protect the privacy of the patient, but there was a lower caesarean section called.
Presumably not caesarean.
Correct.
Thank you.
Ms. Pearce, Earlier this year, there was an email accidentally sent from a medical administrator to junior doctors at John Hunter Hospital. You're nodding, I know that you know about this. So for the benefit of the committee, it was an email criticising junior doctors who'd questioned a roster of 10 consecutive night shifts, and the email said, quote, "God help us in future, we're going to have a workforce of clinical marshmallows," end quote. ASMOF has responded to that in very good humour and produced a large amount of merchandise with marshmallows on it. And I know that you responded to the specific incident at the time, but I'm interested more broadly. I think most people can appreciate that 10 consecutive night shifts for junior staff is unsafe. How widespread is that problem, and what have you done to ensure safe rostering for junior medical officers?
I might ask if Mr Minns could come forward here. He also has a response for you with respect to the VMO costs that we talked about earlier, so we might be able to kill two birds with one stone there. But look, I will say in respect of that matter, I mean, the individual who sent that email was deeply remorseful. It was, you know, clearly an inappropriate thing to do. Counselling has occurred in regard to that. An immediate apology was given. There's been work with the JMOs at the hospital. The district really took that very seriously, and they've got a good group of JMOs there that they're working with on that matter. But I know that we specifically looked at the 10 night shifts issue, and I think, Phil, you might be able to respond to that.
Yes, I think the district did an audit for the last 6 months, and they didn't find any instance of where someone had been rostered for more than 7 days consecutive on night shift, and that relates to the standard that exists. I'd be very happy to provide that as a written answer and notice, because
Yeah, please. And I mean, I'm initially looking at that district makes sense, but I'm interested statewide as well to make sure this isn't an ongoing cultural issue from a time when that was an expectation of doctors.
Yes, you might recall those times, Chair, but we have done a lot of work over the last 5 years to reset expectations, and a lot of that is about rostering practice. So again, I'm very happy to present all those strategies in a single response for you.
Please.
Just to go to the question about VMOs that you asked earlier today, and Mrs. Carter asked some questions, and I said there's a limit to some of the data I could get you, but I think I can provide you a succinct answer that clarifies it and definitely indicates we're not paying these transferring locums $3,500 per day. So the 72 people will be placed on 6-month VMO appointments with fixed hourly rates. They'll be the standard VMO rates in accordance with the VMO determination. That currently is $262.60 per hour, plus a payment for on-call, which is I think $15 an hour, and payments for recall when doctors need to attend. The locums that we're engaging, they get, and I mentioned earlier today, there's about 25 currently engaged in the response. We put them on a VMO sessional contract with 0 hours with a set daily rate. That is where that cap of 3,050 comes from. How much they actually earn will depend on how many shifts they work as a locum, and that's the same for VMOs in the sense that not all of them are contracted full-time. Some of them are 0.8, 0.6, 0.4, and then it comes down to how many hours they work. And if they in fact treated private patients at some point while they were at work, that would be deducted from their payments from us. So in broad terms, you can say that it's very hard to compare the two of them, because one is an employee with an annualised salary and set of arrangements, and one is an independent contractor effectively. But if you try to gross up the comparative costs of them both, you can get to a point where broadly speaking, about 13% additional cost applies to a VMO compared to a staff specialist. But there are some productivity benefits associated with having a VMO on deck rather than a staff specialist, because they don't take annual leave that we pay for. They are incentivised in a sessional contract to focus on treatment of patients, and they're just, and they don't have non-clinical time elements to their contractual arrangement.
So
Thank you. You've correctly anticipated what I'm trying to do with this data, and I mean, if you'd like to help us accurately assess those sort of on costs, perhaps a 6-month,
there are a couple
calculation for a full-time equivalent on each of the 3 contracts would be helpful.
There are a couple of tables that I will tender after today for you that try to step through. We've got to be a little bit delicate because these are matters for evidence before the IRC, and we expect both ASMOV and the Ministry will be submitting evidence about this. But what I want to check to ensure that we can share with the committee, and I'll do that immediately after today.
Thank you. And my follow-up in trying to understand these calculations myself, there's obviously different salaries for different levels of staff specialist under the award. Could you provide us a breakdown of the current staff specialist psychiatrists at New South Wales Health? How many in which level classification under the award?
Yeah, I believe so.
Thank you very much. Coming back to Dr. Chant, I understand that there's been a recent death in northern Sydney from Japanese encephalitis, which is obviously of concern to people in the Murray region and Murrumbidgee region. What are your current prevention efforts, and are you satisfied with them?
So the first prevention effort that I'd really like some greater uptake of the JE vaccine. So New South Wales has purchased a number of stalls of that vaccine. We've got that vaccine available. So there's no constraints on people taking that up. We do see a bit of a surge after there's tragically a death or a notification of a case, but we would like to see the sustained uptake, particularly for those that spend significant time outdoors in the region. We also are working with a number of other with occupational groups that might be at particular risk of exposure to try and emphasise the importance of covering up the type of clothing. So we've got an extensive sort of health promotion campaign that touches on particularly those workers that spend a significant time outdoors, but are open to other suggestions around how we can really raise awareness of this ongoing risk. And there's JEV, but obviously other mosquito-borne illnesses. So getting bitten by mosquitoes is not a good idea.
Absolutely. And can I ask, in terms of supply of vaccination currently, I understand in the past there needed to be quite significant restrictions on who was eligible to be vaccinated because of supply issues. Is supply adequate at the moment?
No, supply's not an issue for us. So you can get it at pharmacies or you can get it at your general practitioners. It probably is important to just ring ahead just to check that the practitioner has got stock in their fridge. Because we know also at this time of year where the practitioners are balancing flu vaccines and other vaccines in their fridge, as well as pharmacies. So the key message is please check ahead, but there should be no barriers to access to the vaccine, and we do urge you to get vaccinated.
Yeah, and how is that health promotion or education piece currently being rolled out at the moment? I have some concerns that people who spend significant time outdoors recreationally are probably not aware of this issue at all.
Yes, and we're happy to. So I can give you the websites and some of the products that have been developed, and in your own area there's been some innovative work and booklet educating through the schools as well as a really important way of getting to the community through children telling their parents. So I'm happy to, but I'm also happy to see that nothing is perfect in getting messages out, and if there are gaps, we're happy to consider what else could be done. Obviously, tourists that might be coming in and moving around are a harder group to reach, and so again, if there's ideas of how we can do that, we would be open to them.
Thank you. I'll go to Ms. Freeman.
Dr. Chant, just back to the nHealth guidance sheet. Now, I understand that, so New South Wales Health used to have a fact sheet on PFAS, correct? New South Wales Health relied on a PFAS fact sheet, say, back in beginning of 2024?
We tend to rely increasingly on national fact sheets or fact sheets or only develop fact sheets when there's not a national fact sheet. I would happy to look at the timeline.
But the nHealth the N-Health guidance that came out, and I'm very aware of the difference. So that's now that you've clarified, it was what I was talking about. I thought there was a third in there somewhere, but the N-Health guidance came out at the beginning of 2024 last year. Did that replace an earlier one?
I believe there may have been one.
I think it did, 2016 or something.
2016.
So why? So that's done, the N-Health guidance from where you're sitting. So let's forget about the draft Australian Drinking Water Guidelines.
Yep.
The N-Health guidance is what the health agencies rely upon for general communication, general messaging, your New South Wales Health comments around whether PFAS is a risk or what have you, is from that. Is that right? That's the policy guidance for
we would have drawn from that, but that was developed at one point in time. Since then, the NHMRC has developed its drinking water review, and also IARC came out last year with the with its initial monograph, and as you alluded to 2 weeks ago, it came out with the full tome. I've got to admit I haven't read the 743 pages.
745 or something.
Yeah. So the staff.
There's a big index.
The staff are reviewing that because it is important.
Understand.
So we don't, the N-Health was done at a particular point in time. Our advice around the testing and other things is informed by understanding each of those three things. So we're not anchored to that N-Health.
And so can
guidance.
a state, in theory, go beyond what the federal N-Health recommends, for example? Does that happen, or
yeah, certainly we can. So yes, we did have a fact sheet, but withdrew it when N-Health became available. So our recollections are correct. That is the case, and I was also just looking at your earlier comments around the document that you referred to earlier today, and going to the CDC website. So we would tend to use that as the authoritative, the CDC's got a particular toxicology group within it. And I was just reviewing today, for my own benefit, the comments in that, and there's not much disconnect with our current position from CDC. It concludes that a blood test for PFAS will not identify a current or future health problem or provide information on treatment. It does reference this document much lower in the document where there is some guidance. So I think that, whilst I think I would characterise it as internationally people are grappling with the science of what is the best approach to understanding the role of PFAS testing in supporting people to maintain health, how that fits in to a broader preventative agenda. One of the interesting issues here is it does refer to some of the testing and screening that it recommends would be occurring within the normal context of preventative care from a general practitioner. So I think there's actually, we're in that point where we're really trying to understand what is the best approach, and this group has put forward one view, which is a sort of link in the CDC, but CDC at the moment is not recommending this from my reading of of the CDC website at the moment. It's saying you can consider this approach.
So the various communications that I've seen from this, more than 130 or 40 boxes that came back in relation to PFAS from the SO 52 last year, and I haven't looked through all of them, you can be assured, but is that the guidance came out, the new guidance came out in January, then IARC, very, I think a month before it came out, a month before N-Health came out. I'm just need to let's get the words, querying the process now, because these things tend to sometimes stay in place for another 5, like the last time that one was updated was 2016. it comes out just before some pretty significant shifts, I think, in global science. And what is the process now for a review of the very new guidance from NHealth, a very 2024 in light of the huge IARC tome, for example? The email, one of the emails I think I gave you, says that the NHealth did acknowledge that they would wait until the monograph was published, which again was 2 weeks ago.
Sorry, I didn't get that email, so apologies.
I'll find it for you, but they did, in an email, they did acknowledge that they will wait for that to come out. So it's come out, and it's got all of that information. So what's the next step? Can we be assured that there will now be a review process?
So I can commit to raising this issue through the Australian Health Protection Committee, which is the peak committee. And I think the question for us is, what is the right way for us to ensure that our guidance is up to date? And I can commit to raising that at AHPC, but some of the considerations may well be that as we're getting into very clinical realms around the role of blood testing, and it needs a more diffuse set of experts involved, that maybe NHMRC is better placed to update, given they've just recently done the work on the Australian Drinking Water Guidelines. So I'm really open to re-reflecting, and I think the fact that we've created the technical advisory group to provide advice to me about these matters shows that. So I'm just saying I'm not sure that NHealth may well be the right group to rewrite it. It may well be better sat with NHMRC, but I'm happy to raise the issue that we do need an updated guidance, and we do need to consider the questions that the community's got in terms of, the role of blood testing.
Thank you. Would you also look into, I asked it briefly earlier as well, but around the firefighters' advice? Again, that advice, that comment came from the commissioner that presented in Katoomba, who said that New South Wales Health had advised, that the current advice from New South Wales Health was to not get blood tested. The question I asked him was, if a firefighter comes to you with extreme health issues, maybe they've got cancer, they've got a history of 30 years fighting fighting fires using, obviously, the AFFF foam, what do you do? What support do you provide? Do you test their blood and what have you? And his response was that New South Wales's health advice is there's no point not to test their blood. That seems extraordinary, I think, for occupational hazard.
I think that perhaps the question, there's always there's always the way the question is answered. I would have segued where you segued, which is OC health and safety. There is a requirement for an OC health and safety lens. Looking at the CDC website as well, just because you did raise the issue of interjurisdictional. Again, there's no approved method for the reduction, but if in the scenario you're putting there that the person has cancer, it is within their remit to seek advice about whether their exposures could have been contributed to by or accounted for, and that's a clinical discussion within that OC health and safety framework. So I'm happy to review and get in touch with the
Can I just check with the CDC? Is that like a clinical guidance that they've provided? Because what I provided...
I can give you also the web link to the CDC.
The Centre for Disease Control is
Agency for Toxic Substances is a subset of the CDC.
Okay, well that's
and so the Agency for Toxic Substances has...
produced the guidance that I've
has produced their own... comments in relation to PFAS and the role of PFAS testing. So they make a number of points that nearly all people in the United States have measurable amounts of PFAS in their blood. Blood tests for PFAS are most useful when they are part of scientific investigation or health study.
Yes.
A blood test for PFAS will not identify a current or future health problem or provide information on treatment. So
One
they're
of
the three key messages.
Just quickly, with when your team looks through this 745, I didn't obviously print out 745 page, just that's the front cover, and a few other things. But it does say in here that Australian firefighters were in fact the highest serum concentrations of PFAS were reported among 149 firefighters working at AFFF training facilities in Australia. So it is worth looking at that in more
That's
detail.
fine. And I'll also follow up with Safe Work. I'm advised that they've got some information, but I'll just check that it's aligned. And I think the reflection we've got is that as science evolves, we need to reflect on the advice and the situations.
Thank you.
Thank you. There's 2 minutes for cross-mention, 2 minutes for opposition. So in my last 2 minutes, I'm interested in an update on staffing at Cessnock Hospital. I previously met with members of the community who were really concerned that the removal of the emergency department doctor who used to be rostered out of Maitland Hospital had never been returned post-COVID, and that there were GP registrars essentially covering Cessnock Hospital on an on-call basis. Is that still the case, or has the emergency department doctor returned to Cessnock Hospital?
We would have to take that on notice, Dr. Con.
Thank you. While you're taking that on notice, so while I'm on Cessnock, there was a case in September last year that was reported in the media that I think you'd be aware of a 10-year-old boy who was taken to Cessnock Hospital by paramedics and told that the hospital couldn't see him because it wouldn't see children under 10 who'd arrived by ambulance, but that they would see him if he got out of the ambulance and walked into the waiting room. Hunter New England Health and New South Wales Ambulance apologised for that incident at the time, but I'm interested in understanding, is this a communication issue? Is this related to the staffing issue? How is that policy possibly been interpreted in that way?
It makes absolutely no sense to me why that should be the case, first of all. Happy to look at it. I have some memory of it, but I haven't got the specific details on me at the moment. We're very happy to look at it, though, and answer that on notice.
Yeah, appreciate it.
Could I just mention Mr. D'Amato is bursting to tell you about the nurses' costing, if you wish for him to do that.
Please.
Before we complete.
Please.
That's the most restrained.
You can do it in the government.
He's Italian.
Dr. Cohen, just to go back to your 6.5 billion that you quoted, that figure covers 5 years, so 5 financial years, being the 24-25 to 28-29, and it covers an additional number of claims, not only the 15% wages increase. The claims that covers is the increase in night shift penalty, personal leave entitlements increases, and the increase in salary packaging. I'm just mentioning the big ticket item.
Thank you. Can I be really sneaky and ask one follow-up? Why 5 years? Why is it
normally,
predicted over 5
because this covers this financial year as well as the forward. So normally the forwards will cover the first financial year of being 25-26 plus 3 years. That's the normal approach. And because this has been the assessed in this financial year, will cover 5 years.
Okay. Thank you very much for getting back to me.
Thank you, and thank you, Chair. Just back to Dr. Chant, just in relation to the drug summit, what was the cost of the drug summit, noting it was held across 3 locations in November, December 2024? What was the total cost to the taxpayer?
I'll just come back to you, but Alpha, you can Google too. I think there was an allocation of, I wouldn't want to mislead, so let's just bring up the note.
Thank you. And not just, you can come back to me on it if you like today. Just on the total cost of it, though, not just the allocation. And when will the final report and recommendations from the Drug Summit be provided to the government, and when will that report be publicly released?
I understand that the co-chairs will be delivering that report sometime in March is the timeline. It's a matter for government when the report is released. That's probably best directed at the Minister for Health.
All right. Can you take on notice whether there's any indication in the first half of this year, second half,
yes,
what
certainly.
the current thinking
Certainly.
is? Thank you.
I can say that there is an interagency group that's working on progressing matters concurrently with that.
Sure, I'm sure there is. Thank you. And just a separate, I'm not sure who to direct this to, so Dr. Chan, I'll direct it to you unless otherwise. Share SMR Incorporated had $90,000 cut from Southeastern and Local Health. They do important work in health promotion. Just wondering why their funding was cut.
Have to just take that on notice. I'm sorry about that.
One quick question. The new True Colours Clinic, is that providing cross-sex hormone treatment to patients? Happy for you to take it on notice? Yeah. And if it is, just wondering about the consent protocols for those who are 16 and 17 at that clinic.
Yeah, we're happy to provide that.
Yeah. Thank you. Thank you very much.
Hang on.
It's time for government questions.
Thanks, Chair. I've got a few questions for you, Mr. Horan, but feel free to pass them on to other members of your team. Could I ask firstly how HealthScope manages the apparently conflicting priorities of clinical service delivery to the community and shareholder profit?
Sure. Thank you for the question. So, from our perspective, clinical outcomes and patient care are number one priority. It is the most important thing that we do. All of our hospitals are focused on providing outstanding care to the communities which they operate. Our focus has always been on that. In order to continue to provide that care, there has to be some level of profit so that we can invest back into our hospitals, back into our amazing staff and continue their training, their development, etc. So, and with outstanding care, profit follows actually. So for us, our focus is on providing care.
Yep, okay. I note that last year HealthScope introduced a hospital facilities charge, I think it was called, and I think that was $100 per night or $50 per patient. Just on that issue, is that reflective of private health funds withdrawing on funding services or reducing how they fund services? And could you just explain that to us?
Yeah, sure. So just a slight correction, it was not introduced. It was proposed to be introduced, but not introduced. And it was as a result of particularly two funds that we were dealing with, not providing funding or fair funding for the hospitals and the care that we provide. The intention for that gap payment was to contribute towards the cost of the care that we are providing.
Right, okay. And turning to the tragic death of young Joe, could you talk us through, you've talked about the clinical error that occurred or errors that occurred, but could you talk us through what systemic reforms have been identified in the aftermath and implemented?
Yes. So out of the investigation, the two causal factors were based around the missed triaging categorisation, and there's a systemic issue with that, and then also the escalation points that we've talked about today. So what we've done immediately, we've put in place the dual triaging so that as any paediatric patient comes, they will get triaged by the triage nurse and then by the nurse unit manager or seen by the nurse as a second check on that to make sure that doesn't happen. We have also changed our rounding processes for our senior specialists so that they are rounding more regularly in paediatrics at 8 to 5 and 11 p.m. During the day. We have implemented a proactive push of the REACH program. So when any paediatric patient is triaged, we are providing the parents or family member with a QR code for them to scan and explaining to them what their ability is should they wish to escalate through this third-party contact to intervene in that care, and that is in place today. And then we have accepted all of the recommendations from the SAYA review, and they are in progress as we speak. Principally, if we focus on the system point that you raised, which we talked earlier about, which was Telstra Health. We are currently working with Telstra Health and Adalis to rectify the entry of the vitals when they come into triage so that it does alert. And if you allow me to refer to, I've got an update here. Sorry.
No, not at all.
So the other actions. So adoption of an audit for the retrospective review of assigned triage category appropriateness. That is in place, and we're looking at 20 per month that are being audited to ensure that our triage nurses are categorising correctly. Implementation of the CEC's Family Carer Concern tool into the EMR that aligns with local escalation processes. Again, we've accepted that and are going to be implementing that. Implementation of the Safety Attitudes Questionnaire in the ED. This is something we're doing in conjunction with the local health district, and it's being scheduled and will take place. Education and re-education of clinical staff with the CERS escalation process within the ED for admitted and not admitted patients is again accepted and in process. Development of a standardised post-incident debrief process to use following significant events. Yes, that has been adopted and will take place. Review of the ED paediatric standing order for Ondansetron, I think that's how you pronounce it, which is a medication for vomiting.
Ondansetron.
Thank you. And so that is, again, been accepted and undertaking. And the other actions that we are taking are, we are conducting and implementing a independent review. We have mentioned that with New South Wales Health. We'll be fully collaborating with New South Wales Health. We would also like the Massa's family input into that independent review, and it will be a broader review, not just focused on this incident, but making sure we're looking at the full ED as a process. So in summary, that's where we're at from that.
Thanks, Mr. Hoy. And in terms of the staff directly involved in the clinical errors, are you able to tell us what's happened with those staff? Have they been referred to professional or disciplinary bodies, things of that nature?
Yes. So I can tell that the trainee specialist was referred through the performance management process. So that has occurred and taken place. The other one of the other nurses is currently on extended leave. The performance management process has begun, but has not been completed due to that extended leave.
Yeah. Okay. And I was wondering also, not sure if this is one for you or one of your team, but are you able to provide us with a breakdown and an explanation of the staffing levels at ED? What positions are there and what numbers?
Yeah, we can take that on notice and provide our ED. Probably the easiest would be to provide our ED rostering, and we can provide that on notice.
Okay. I'm specifically interested in, I think, the level or the amount of consultant doctors and whether those levels are consistent with the Australian College of Emergency Medicine safe staffing recommendations. Are you able to speak to that?
I'll pass that to Peter.
Yes, so the rostering template for Northern Beaches is based on the ASIM guidelines, noting they are guidelines, but we have adopted them, and the same for the junior medical staffing and what we call the senior decision makers, or the which may be in advanced training as well, in particular in light of the night staffing as well.
Yeah. So in terms of the day that these events occurred, can you just talk us through what the staffing situation was on that night and the consistency of that with the ACEM safe staffing recommendations?
What we can refer to is the SAIA report, which did look at the staffing levels, and the SAIA report makes it clear that staffing wasn't a contributing factor to the incident.
Yep.
That's what I can definitely confirm.
Okay, yeah. And how many consultant doctors would be in the ED generally?
At any one time, or,
yeah.
So generally for each shift there'll be 3 on the clinical floor, and then there may be 1 or 2 other doctors who may be doing some non-clinical support or teaching, and then there is the clinical director, so the emergency director, who is there on a full-time basis.
Right, okay. That's the government questions. Thanks, Chair.
There being no more government questions, that brings us to the end of the day. Thanks everyone who's attended for giving up your time to answer questions from the committee today. There were a number of questions taken on notice, with which the Secretariat will be in contact with you about.
Thank you, everyone.
Thank you.
Thank you.
Thank you.